Again, okay. Hello everyone, am I audible? Check this now. Hello everyone, am I audible so that we can start the session? Okay, so let me just check. So for today's session, we are going to start with the anatomy MCQs, which will be highly beneficial for your upcoming exam of FMG. So what I would like to elaborate what I am going to do today. So exactly in this session, we are going to cover up all the important question related to FMG examination. So many questions are taken from the previous year of examination, and many high yield topics has to be covered up. So that is the reason we have I have made 100 MCQ session, and actually the whole MCQs will be discussed with you along with the explanation. And that means more or less we are going to discuss 100 topics today or related to anatomy, which will be very useful for your upcoming exam. What I want from everybody that you should revise all these questions which I am going to discuss. In other words, I can tell all these important all these important topics, which is very important. Okay, so my dear students, I think the screen is clear and I am audible. So we can start the session. So let's go one by one. I would like to tell I am Dr. Mona Lisa, the anatomy faculty on the Medway platform. And let's quickly start the session so that you can crack the examination with more than 150 numbers. Okay. So let me start with the first MCQ. Those who are live, they can just give the answers in the messages. So in the message box and in the chat box, they can write their answers and I will see whether it is correct or not. Otherwise, I am there to explain each and every MCQs. So let me start with the first question. So a newborn has hypoplasia of mandible and zygomatic bone, malformed external ears, slanted palpable fissures is there, abnormality is in the development, and we have to see that which of the following pharyngeal arches is most commonly leading to these conditions. So exactly I'm going to highlight the keywords in this MCQ. So the keyword is there is hypoplasia of the mandible. So I'm just highlighting it. There is hypoplasia of the mandible and that of zygomatic bone, and also there is malformed external ears, there is slanted palpable fissure. So the keywords which you have to pay attention here is mandible is not fully formed, zygomatic bone development is affected, also the external ears are affected, and there is slanting palpable fissure. So these are the keywords which will help you to crack the question, and we have to see which pharyngeal arches syndrome is this or which pharyngeal archer abnormality is this. So actually these are all the abnormalities of pharyngeal arch 1. Now let me come up with the explanation. So the clinical condition which I was explaining about the newborn baby is having keywords hypoplasia of the mandible, and zygomatic bones. So also there is involvement of zygomatic bones, malformed ears, malformed external ears, slanting palpable fissures. Palpable fissure is also slanting. So these are all the features of first arch syndrome. And I would like to tell that there are three important syndromes involved in the first arch, that is Teachers-Collins syndrome, Parry-Robin syndrome, and Dye-George syndrome. So we have got Dye-George syndrome related to this condition. We have got Parry-Robin syndrome and Teachers-Collins syndrome. These are all first arch syndrome. And the facial abnormalities which is mentioned in the MCQ is correlated with the first arch syndrome. Now, I would also like to individually tell you about each of the syndromes so that individually also you are able to identify the clinical features of Teachers-Collins syndrome, Parry-Robin syndrome, and Dye-George syndrome. So let's start with this. So the first syndrome which I want everybody to understand is Teachers-Collins syndrome. What is it? It is the teacher's Collins syndrome, which is also called as, if we talk about teacher's Collins syndrome, it is also called as mandibulofacial dystosis. Why it is called as mandibulofacial dystosis? So in this diagram you can see this is an image of a patient. This is an image of a of the teacher's Collins syndrome patient, and the child is having maldevelopment or mandibular hypoplasia. So mandibular hypoplasia is there. Also, the palpable fissure, as you can see, is downward slanting. You can see this is the external ear, which is also malformed. So deformities, if I am going to enlarge this image, you can see the mandible is not formed, as you can see. Also, the external ears are malformed. Also, the hypoplasia of zygomatic bone is also not fully developed. So these are the key features to identify the case, and this is teacher's Collins syndrome. Actually, teacher's Collins syndrome is inherited as autosomal dominant. It is inherited as autosomal dominant trait caused by autosomal dominant gene, and the key features are, as I have explained. Once more, let's revise this: mandibular hypoplasia, downward slanting palpable fissure, and deformed external ears. So we have done with this. Now the second one. Now I told you the second important abnormality of the first pharyngeal syndrome is Parry-Robin syndrome. Parry-Robin syndrome. Now, it is also important that one by one I am going to describe each of the first star syndrome, because the question can be asked, because it's not important that exactly the same thing could be repeated. It's important to know the structures or the important syndromes that is correlated to it. So when I'm talking about Robin syndrome, Parry-Robin syndrome, here what happens, it's a condition in which the infant has got three important traits of the conditions or the syndromes. The microgenetia, when I am using the word microgenetia, it means small mandible. So the baby is having microgenetia, cleft palate, glossoptosis. What is glossoptosis? When I am using the word glosso, it means tongue, and it is posteriorly displaced. So if the baby is having a malformed mandible, posteriorly placed tongue, and it is having a cleft palate and also having small mandible, the condition is called as Parry-Robin syndrome. Done. So we have done with this. Now coming to the next one, Dijor syndrome. When I am talking about a Dijor syndrome, it is actually a very grave condition, and here the major abnormality which is seen is the microdeletion of long arm of chromosome 22. Long arm of chromosome 22. Now, actually, this question has also been asked as a question of pediatrics and the medicine question, where you have to know what is the exact reason or cause of Dijor syndrome. So microdeletion of the long arm of chromosome 22. It is again the reason is abnormal development of neural crest cell, which is not migrated and not leading to the formation of this pharyngeal arch. It is also considered to be a first arch syndrome, and it's a very grave condition. Why? Because full development of thymus. So the person who is born which will have the deformity of not development of thymus and parathyroid gland, and we know that thymus is a primary lymphoid structure, very important for cell mediated immunity. So the baby will have the deficiency of cell mediated immunity, parathyroid glands are not developed, cardiac outflow tracts will be also having defect in it, and this will lead to ultimately the baby will also die. The fish mouth deformity, shortened philtrum is there, low set ears, and the baby, due to the non-development of the thymus gland and parathyroid gland, the baby is more susceptible to the infection. So we have done with this first question, and we are knowing the question being asked is the first arch syndrome. Let's come up with the second MCQ. So let's come up with the second MCQ. This was again a question being asked in FMGE anatomy exam in the previous year. I think it was asked in the last year only. And this is a very easy MCQ. This is an image based MCQ. Identify the structure marked by an arrow in the image. So either it is, the four options are there, whether it is midbrain, whether it is pons, whether it is medulla oblongata, whether it is spinal cord. Four options are there, and you have to mark the right answer. What I want everybody, so I'm just enlarging this image, okay? So when I'm enlarging this image, can everybody appreciate the white arrow? The white arrow is there at one of the important position of the part of the brainstem. That is the hint provided to you. So can you tell me which will be the right answer. Those who want to reply, they can certainly reply here in this, they can certainly reply in the chat box. Okay. So anyone wants to give me the right answer? So exactly this white arrow is at the location of pons. This white arrow is at the location of pons. This one. Okay. So this is P for pons. This is M for medulla. This is cerebellum. And this cavity which you are seeing is the cavity of fourth ventricle. Okay, cavity of fourth ventricle. Also we can see the medial surface of cerebral hemisphere. Also we can see the part of corpus callosum. So my dear aspirants, my dear students, what is corpus callosum? So what I am highlighting here, this part which I am highlighting here is the corpus callosum. This is corpus callosum. So corpus callosum is the largest white fiber, which is an example of chemisural fibers connecting the two sides of the brain. We have got the pons, we have got the part of the brainstem, pons, medulla, and also the cerebellum. And also the cavity which is seen is the cavity of fourth ventricle. Fourth ventricle. This cavity which you are seeing is the cavity of fourth ventricle. So all these important structures has been highlighted here, and now we are coming of the right answer. The right answer to this MCQ is pons. The marked structure with the white arrow is corresponding to pons. Now this is exactly the image which I am sharing it with you. The pons seen as the part of the brainstem. As we go with the parts of the brainstem, caudally to above, or you can say caudally to rostrally, from below to above, the parts of brainstem is medulla oblongata, pons, and the midbrain. Now, this is a MRI scan of the brain, which I want to show you. So let me just highlight this. So in the MRI scan of the brain, the important parts which is visualized, as you can see here, this is the cerebellum. Lower part, you can see the spinal cord. You can see also the medulla part. Then as what was asked in the MCQ is also marked here. This part was asked, and we know that this is PONS, this is pons. What is it? This is pons. This part is medulla. This part is corpus callosum. Now, you can also mark the parts of corpus callosum in this image. So, if I just enlarge this, you can see the medial surface of the MRI scan of the brain has been shown. And just please concentrate on this image only. Parts of corpus callosum also should be known to you. The largest commissural fiber. So, this is S for the splenium. So as we go from posterior to anterior, as you are moving from posterior to anterior, the parts of corpus callosum. Let me slightly highlight this. So what I'm using green color for the parts of corpus callosum. So this is the green color which has been used for the parts of corpus callosum. So the posterior most part, what I have written S here, S stands for the splenium. This is the splenium part of corpus callosum. This will be the body. This will be the trunk or the body of corpus callosum. This is G. What is G? G means genu. What does G means? G means genu. And more anteriorly, if you go more anteriorly, you can see R. What is R? The beak-like projection which you are seeing is R. And that beak-like projection which is R is called as the rostrum. So once more, if I want to tell you about the parts of corpus callosum as you proceed from anterior to posterior, here R for rostrum, G for genu, and the body and the trunk, and posteriorly we have got S for the splenium part of corpus callosum. The other structures which is visualized in the sagittal section of the head and neck, as you can see, the pons medulla is also seen. Also the thalamus, T for the thalamus. So what is this? This is T for the thalamus part. This is T for the thalamus part which has been seen. Okay, now let's also see. So this was exactly the structures which I have shown to you in the MRI scan. But other than that, it can also be possible that the question can be asked in the cadaveric image. So let us enlarge this. The parts of the brain dissected out. So dissected parts of the brain which has been shown is the medial sagittal section. So I'm just enlarging this image. All of you can see this image. I am enlarging it. So when I'm enlarging it, this is the medial sagittal section of the brain which has been shown to you, and this in this medial sagittal section of the brain, the parts of corpus callosum can be visualized. So these are the parts of corpus callosum. This is the corpus callosum which has been seen. You can see T for the thalamus part. This is thalamus. This is the H for hypothalamus. We can use so this is H for hypothalamus. This is corpus callosum. This is P for pons. This is M for medulla oblongata. This is mesencephalon. Also, you can see the parts here of the brain. You can see the cerebellum is lying here. You can see the cavity of fourth ventricle and cerebellum. Also, you can see the occipital lobe, the parieto-occipital sulcus and the parietal lobe. So, exactly most important structures should be visualized in this image, and you should be aware of identification of different parts of the brain which can be seen in the medial sagittal section of the brain. So, I hope you are clear with this. Okay. If you have got any doubt, you can ask me in the chat box. So, okay. Okay, so done with this. Now, let's see question number 3. Let's see the question number 3. Okay. A patient underwent a left submandibular gland excision. So, the patient is going with the left submandibular gland excision, during which the hypoglossal nerve was injured. Which of the following defect could be seen in this case? The patient is not. So the procedure which is performed here is the left submandibular gland excision. So I would like to highlight this. Left submandibular gland is excised, during which hypoglossal nerve is injured. So after the excision of left submandibular gland, there is injury of hypoglossal nerve, and we have to see which of the following is the correct answer. Whether deviation of tongue is occurring into the contralateral side, whether deviation of tongue is occurring to the same side, inability to protrude the tongue is there, loss of taste sensation in posterior 1/3 of the tongue. So we have got 4 options and we have to mark the right answer. The key word which has to be keep in mind is the injury is to the 12th cranial nerve. 12th cranial nerve, that is the hypoglossal nerve. Hypoglossal nerve. Now, as you must have revised, and you must be knowing that the 12th cranial nerve, which is called as the hypoglossal nerve, is giving innervation to the muscles of the tongue. So it is the sole nerve which is giving innervation to all the muscles of the tongue except palatoglossus. So exactly when there is an injury of hypoglossal nerve, it will lead to deviation of the tongue to the same side. So we have got here option B as the right answer. Now, I will explain why the deviation happens to the same side. Now you can see effect of paralysis of the 12th cranial nerve, hypoglossal nerve. Now, as I told you, all the muscle, one of the key point which you have to keep in mind is all the muscles of. So we will come to this. I just want to enlarge this image. So when you are seeing the this image, what you can see, the tongue is deviating to ipsilateral side when there is injury to the cranial nerve, that is 12th or hypoglossal nerve of the same side. Now, why it happens? Actually, the bulk, if I talk about the bulk of the tongue muscle, it is made of genioglossus muscle. So, genioglossus muscle is forming the bulk muscle of the tongue. It is forming the bulk muscle of the tongue. And the function of genioglossus muscle, if there is bilateral contraction of genioglossus muscle, what it causes? It causes protrusion of the tongue. See here. So I am protruding the tongue. When there is bilateral contraction of the tongue on both the sides, so I am able to protrude my tongue. But when there is injury of one side of genioglossus muscle, that side of the tongue is not protruded, and the other side, contralateral side of the tongue is protruded. That will lead to deviation of the tongue onto the same side. So because of injury of genioglossus muscle, which is the bulkiest muscle of the tongue, there is deviation of the tongue to ipsilateral side of the injury of hypoglossal nerve. Now, genioglossus is the only one muscle which is protruding the tongue, and for testing the integrity of the hypoglossal nerve, definitely genioglossus muscle has to be tested. And when there is injury of hypoglossal nerve, as we know that hypoglossal nerve of right side is paralyzed, so on protrusion of the tongue, it will deviate on right side. The reason is that because left side genioglossus muscle is not affected, so it will pull the tongue onto the same side, that is right side. Now, my dear students, before proceeding to the next question, as I know, tongue is a very, very important topic. So let me just enlarge this. this box. Why I'm enlarging it? Because I want that if I talk about an important topic from the head and neck series, which has been asked several times in your FMG exam, is that of tongue. So we know that there, in the case of tongue, there is extrinsic muscle and there is intrinsic muscle. That is known to you. So there is extrinsic and there is intrinsic muscle. So it is important to know the action of each of it and the nerve supply. So all of the tongue muscle, as I've told you, so let me just tell you, all of the tongue muscle we have got, for example, genioglossus muscle is the bulkiest muscle, is supplied by the hypoglossal nerve. The function of this is protrusion of the tongue. What is the function of genioglossus muscle? So slightly enlarging it, it is causing protrusion of the tongue. The hypoglossus muscle is basically depressing the tongue. So so one of the most important function which is not mentioned, you can write, depresses the tongue from the side, make the dorsum of the tongue convex. So dorsum, it is making dorsum of the tongue convex. It is making dorsum part of tongue convex. This is another function. Other than that, if I talk about the styloglossus muscle, if I talk about the styloglossus muscle, its major function is retraction of tongue. It is causing retraction of tongue. Palatoglossus is elevating the back of tongue, intrinsic muscle of the tongue. If I talk about intrinsics, in case of the tongue, we have also got an extrinsic and intrinsic muscle. So I would like to show you an image where you can revise which are the extrinsic muscle and which are the intrinsic muscle. So in case of intrinsic muscles, we have got verticalis, longitudinal muscle. So these are all intrinsic muscle. If I talk about the extrinsic muscle, it is formed by genioglossus muscle, styloglossus muscle, palatoglossus muscle, hyoglossus muscle. So see all the muscles of the extrinsic muscles. So we have got palatoglossus muscle, which is the odd man out. Why? Because it is not getting innervation from hypoglossal nerve. We have got styloglossus muscle, we have got hyoglossus muscle, we have got genioglossus muscle. So these are four important extrinsic muscles. All these extrinsic muscles of the tongue are getting innervation from hypoglossal nerve except palatoglossus muscle. If I talk about palatoglossus muscle, the palatoglossus muscle is innervated by vagus nerve, carrying the fibers of vagus nerve, which is carrying the fibers of cranial part of accessory nerve. Got it? Now let's talk about the other option. Why the other options are not correct? So the other way to solve an MCQ is that whenever an MCQ will come for your exam, if you are going to attempt the FMG exam, the one thing is that you are 100% sure about that option and you will mark the right answer. The other way is that you can rule out the other options by your common sense. So deviation of tongue on the contralateral side is not right, because deviation of tongue on the contralateral side occurs when there is upper motor neuron lesion. But here in this case, there was lower motor neuron lesion. So definitely this is not the right answer. So actually the tongue curves away from the side of damage due to affected genioglossus muscle and will be seen only in upper motor neuron lesion. Inability to protrude of the tongue completely. If I'm telling the person who is having the hypoglossal nerve injury is not able to protrude the tongue completely, that means there is bilateral damage of the hypoglossal nerve and whole of the genioglossus muscle is paralyzed. Loss of taste sensation in posterior 1/3 of tongue. We know that taste sensation in the posterior 1/3 of tongue is done by cranial nerve. Ninth, that is glossopharyngeal nerve. So in this case, there is no injury of glossopharyngeal nerve. So definitely this is also not the right answer. So my dear students, let's move on to the next. And again, a very important question for your FMG upcoming exam. What is the function of the muscle indicated in the provided image? So I will again enlarge that image so that you have a proper look for the identification of the muscle. So you have to identify the muscle and then you have to tell me the action of that muscle. Whether it is retraction of the scapula, whether it is protraction of the scapula, whether it is abduction of the shoulder joint, whether it is adduction of the shoulder joint. So I just want to enlarge this image. So I am enlarging this image. Can you see the arrow marked here? So that arrow which is marked here will give you a hint for the identification of the muscle. So here the key point for identification is that The muscle is lying below the clavicle, as you can see, and it is going towards the greater tubercle. It's going to this greater tubercle. Actually, this key muscle is, so this muscle which is shown here is the supraspinatus muscle. So supraspinatus, so actually exactly this image is showing you the view from the dorsal aspect. So exactly you can see this is the supraspinatus muscle. This will be the infraspinatus muscle, but the arrow is over the supraspinatus muscle. So we have identified the muscle. Now I just want everybody to give me the answer that this. So that this supraspinatus muscle tendon I'm highlighting with green color, as you can see. So this supraspinatus tendon is causing which action? The important action of supraspinatus muscle is, supraspinatus muscle is causing initiation of abduction. So this muscle has an important function of initiation of abduction. So the right answer is, the function of the muscle indicated in this is causing abduction of shoulder joint. So supraspinatus muscle is a very important muscle causing initiation of abduction of shoulder joint. So we have got C as the right answer. Now, the supraspinatus muscle is located on the back forming. So supraspinatus muscle is considered to one of the muscle part of the rotator cuff muscle. So sits are the sits. If I talk about sits, SIT is sits. It is the component of rotator cuff muscle, and this sits muscle that is formed by S for supraspinatus, I for infraspinatus, T for teres minor muscle, and another S for subscapularis muscle. Okay, so here again I am showing you this image where you can see this is the spine of the scapula. What is this? This is the spine of the scapula, and this is the acromial process. Here acromioclavicular joint is also formed, which is plain type of synovial joint. So here this is infraspinatus muscle. So this is supraspinatus muscle. This is S for supraspinatus, and this is I for infraspinatus muscle. And this supraspinatus muscle tendon is attached onto the upper facet of greater tubercle. So it is attached. So you can see three tendons here, three tendons. Yeah, so these three tendons I will highlight with green color. So we have got supraspinatus teres minor. So as I proceed from above to down, we have got on the upper facet of greater tubercle, we have got the insertion of supraspinatus muscle. On the middle facet of greater tubercle, we have got the insertion of infraspinatus, and on the lower facet of this greater tubercle, we have got the teres minor insertion. So these are three muscles of the rotator cuff. The other one is subscapularis, which is inserting into lesser tubercle of the of the humerus bone. So the action, now it is very easy to know the action of supraspinatus muscle. Supraspinatus muscle, which is originating from the suprascapular fossa, inserts onto the greater tubercle upper facet. So this is very important that you should know the origin insertion of supraspinatus muscle. It is one of an important component of rotator cuff muscle. The spine and how the dorsal surface of the scapula is divided into upper and the lower part. So that division is done by the spine of the scapula. Upper is supraspinatus muscle and lower is infraspinatus muscle. So definitely initiation of abduction is an important function. It is an important function of supraspinatus, which will be affected in this case. Now let's talk about the other options which has been given. So other option which is given is retraction of the scapula. Retraction of scapula is not the right answer, because retraction action is mainly done by the rhomboides and rhomboides muscle, also by the trapezius and latissimus dorsi, but the major retractor of the scapula, this action is done by, if I talk about retraction action, this is primarily done by the rhomboides muscle. Protraction of scapula. Protraction means the scapula is pulled forward. So protraction of the scapula is a very important action of serratus anterior muscle, which is also considered to be a boxer muscle because it is moving the scapula forward. So it is called as boxer's muscle. So this is also wrong option. Adduction of shoulder joint is mainly done by the fibers of pectoralis major muscle. So exactly part of rhomboides also, but mainly adduction is done by. So I would like to give you the major adductor muscles. So if I talk about the adductors of the shoulder joint, please don't get confused because primary action of the muscle has to be known. So if I'm talking about the adductor muscles, so adduction is done by pectoralis major and also by latissimus dorsi. Pectoralis major, sternocostal fibers, and by latissimus dorsi muscle. Now, before proceeding to the next MCQ, I want everybody to know about abduction of shoulder joint. Actually, abduction of shoulder joint is a very important action to be performed, and it is important that you should know about this. So let's write in detail about abduction of shoulder joint and all the muscle involved in this primary abductor, all the muscles which are the abductors of shoulder joint. Actually, the range of abduction of shoulder joint is from 0 to 180 degree. So you have to know all the muscle which is causing this action. So let's talk about that. I'm just enlarging this. Yeah. Is it okay? So now please write down about this. 0 to 15 degree of abduction. 0 to 15 degree of abduction of shoulder joint is done by which muscle? If I talk about 0 to 15 degree of abduction, it is primarily done by supraspinatus muscle. And if I talk about 15 degree to 90 degree abduction, so actually 15 degree to 90 degree of abduction of shoulder joint is done by clavicular so exactly it is done by the middle fibers of the deltoid muscle. Middle fibers of deltoid muscle. So when I am using the word middle fibers of deltoid muscle, the other name of middle fibers is acromial fibers. Acromial fibers. So please note down, as we talk about deltoid muscle is having clavicular part, deltoid muscle is having a spinous part. The clavicular part of deltoid muscle and spinous part of deltoid muscle is not causing abduction of shoulder joint. The prime abductors of the shoulder joint, please make it a very important point, has been asked so many in the previous year of examination, is the deltoid muscle. Now, it is also important for you to know the which fibers of the deltoid muscle. The answer is it is done by acromial fibers of the deltoid muscle. Now, if I talk about the abduction greater than 90 degree, greater than 90 degree abduction. So when I talk about abduction greater than 90 degree, it is done by which muscle? It is done by serratus anterior muscle. It is done by serratus anterior muscle, which is acting along with the lower fibers of trapezius muscle. So exactly serratus anterior muscle, when acts along with the lower fibers of the trapezius muscle, it causes greater than 90 degree abduction. The other name for greater than 90 degree abduction is called as overhead abduction. Overhead abduction. Overhead abduction. Okay. Now, so that is very important. So all the muscles I have named it. Now, so before going to the next MCQ, I just want everybody to understand what we mean by overhead abduction. For example, they can also frame a clinical question on this topic. Okay. The clinical question which can be framed on this topic is, for example, a lady has gone for an operation. She was suffering from breast cancer. She was a known case of breast cancer, and a radical mastectomy has to be performed in that case. In that procedure, the surgeon has injured a nerve, that is a nerve, and that is giving innervation to serratus anterior muscle. More commonly, the nerve being injured is long thoracic nerve, and we know that long thoracic nerve is the nerve supply of serratus anterior muscle. So which action will be lost? The action which is lost is overhead abduction. So they can tell like this: in the other morning after the operation, when the lady wants to comb her hair. So when we are combing our hair, or when we are taking something from the above rack, we are causing abduction greater than 90 degree, greater than 90 degree, and greater than 90 degree or overhead abduction action is done by serratus anterior muscle along with the trapezius muscle. So definitely that is the right answer in this case. So let's move on to the next MCQ, that is question number 5. So all of you be attentive for the session for the whole day. This session is going to start, it has already started 9 and it will be in continuous session. If in between I will give you few breaks, but I want to cover the entire 100 topics of anatomy which will be help you in cracking all the questions being asked from the anatomy subject. So I can tell more than 80 to 90% questions will be asked from these topics only. I can't tell 100%, but yes, approximately 80 to 90% questions. So at which vertebral level is the abdominal plane marked as 2? So the option provided is lower border of L1, upper border of L1, upper border of L3 or lower border of L4. Four options are there. So I just want to enlarge this image and you can see there is 1, there is 2 and there is 3, 4. But you have to identify the plane 2. You have to identify the plane 2. So you have to identify which plane is this. Okay, which plane is it? Now, my dear students, actually, if I talk about this plane, this is the subcostal plane which is passing from the upper border of L3. So basically, it is traversing through which lumbar vertebral level? L3 lumbar vertebral level. And to make your concepts clear, I would like to show you another image. So if I talk about subcostal plane, when I am talking about subcostal plane, this subcostal plane is a transverse plane which is passing exactly at the level of 10th costal cartilage, and if we see the level posteriorly corresponding to the vertebral level, it is corresponding to so vertebral level, it is corresponding to the level of L3 lumbar vertebra. So definitely L3 lumbar vertebra is the right answer. Now you can everybody appreciate the abdominal planes which I am showing you. The abdominal planes and the regions has been shown in this image, and very nicely we can see how there are the quadrants which has been formed. But what is very important for us is to identify the planes. So important planes has been highlighted here. One of the plane is subcostal plane. The subcostal plane is traversing through L3 lumbar vertebra. The transpyloric plane, or you can say the Addison's plane, which has been not shown here, that is traversing through L1 lumbar vertebra. Also intertubercular plane is corresponding to L5 lumbar vertebra. Intertubercular plane is corresponding to L5 lumbar vertebra. Subcostal plane L3 vertebra, transpyloric plane or Addison planes corresponding to L1 lumbar vertebra. So let's I want everybody to note down this. Subcostal plane passing through 10th costal cartilage, it is located at the level of L3 lumbar vertebra. Transpyloric plane, which is also called as Addison's plane, is corresponding passing through L1 lumbar vertebra, and intertubercular or transtubercular plane. Intertubercular or transtubercular plane. So when we are talk about intertubercular plane, the intertubercular plane is corresponding to L5 lumbar vertebra. It's corresponding to L5 lumbar vertebra. Now, so the other way which I told you, actually this was a question from the previous year of FMG examination, and I just want everybody to know about this. Why? Because you will be able to strike out the wrong options, and related MCQs can be asked and you can solve it. So a lower border of L1 is not right answer because it through this level transpyloric plane passes. Upper level of L1 is also corresponding not to subcostal plane, and L4 is also not corresponding. Actually L4 lumbar vertebra is the level which is corresponding to iliac crest, and it is corresponding at the level of bifurcation of abdominal aorta. The bifurcation of abdominal aorta into right and the left common iliac artery occurs at this level. Common iliac artery bifurcation. The common iliac artery bifurcation is occurring at this level. So definitely L4 is also not the right answer. So let's move on to the next question, that is, which among the following helps in supination and pronation of forearm? Okay, four options are there and we have to tell which of the following action will be affected. So first thing is that you have to understand what is supination and pronation action and which joint is formed, which when we are talking about, so can you see this is my forearm, and this is supination and this is pronation. This is supination and this is pronation, this movement. Okay, so exactly supination and pronation is occurring in at the level of the radio-ulnar joint. Radio-ulnar joint is taking part in this movement. So definitely the right answer will be pivot joint. The right answer will be pivot joint. So supination and pronation of forearm is occurring at the radio-ulnar joints. So exactly, pivot joint allows rotation, and when the rotation is external, it is called as example, when the rotation of arm is outward, it is external. When the rotation of the arm is inward, it is internal. This movement is called as pronation and supination. Okay. Now, it is very important for you to note down that superior and the joint which is taking place is the radio-ulnar joint. Is the radio-ulnar joint. Radio-ulnar joint is participating in this, and superior radio-ulnar joint. If I talk about superior radio-ulnar joint, the superior radio-ulnar joint is type of pivot type of synovial joint. Inferior radio-ulnar joint is also pivot type of synovial joint, and these are involved in the action of supination and pronation. Okay. Now, I would also like to tell about the other options why saddle joint is not the right answer. We know that saddle joint is not exactly involved in the action of supination and pronation, so definitely it is the wrong option. Saddle joint is actually similar to that of condyloid joint, and the major action performed at the level of saddle joint is abduction, adduction, flexion, extension, and circumduction. Ellipsoid joint, for example, ellipsoid joint. Saddle joint example is sternoclavicular joint is a type of saddle joint. We have got ellipsoid joint. The best example will be the wrist joint. So it is having angular motion, and ellipsoid joint is mainly involved in and seen in the level of metacarpophalangeal joints and the wrist joint, and it is mainly involving angular movement, not supination and pronation. Ball and socket joint is a multi-axial joint, and we know that shoulder joint, hip joint, all these are example of ball and socket joints. And in this case, mainly the actions and the movements which is taking place is flexion, extension. Also, we have got abduction, adduction also with the that of the internal and the outward rotation. So actually the movement is taking place in 3 planes. So definitely all these are wrong option, and we will get the right answer here as the pivot joint is the right answer, which is involved in pronation and supination action of forearm. So let's move on to the next question, that is question number 7. Please determine the size of thyroid gland based on the provided image. So you have to determine, please determine the size of thyroid gland based on provided image. Okay, so based on provided image, you have to determine the size of thyroid gland. So what is that? I just want to enlarge this image so that you have got an idea, so that you have got an idea of exactly, you will get an idea of A, B, C, D, what is that level, and you can tell me which is the right location of thyroid gland. So for the correct answer of this, you have to basically know about its location of the thyroid gland, and then you will able to mark the right answer. Exactly, if I talk about the thyroid gland, corresponding levels to which, vertebral levels to which its location, actually the right answer will be whole of these reasons will be involved for the thyroid gland location, that is A to D. Actually, thyroid gland level corresponds to C5, C6, C7, and also can embrace T1 level. So C5, C6, C7 and T1 vertebral levels, the cervical and the thoracic vertebral level, is the part which is embraced by the thyroid gland. Thyroid gland has having 2 lateral lobes, and the middle part of thyroid gland is called as the isthmic part. So each lobe is extending till the middle of thyroid cartilage, and and it is extending to 4th or 5th tracheal ring. So isthmus, if I talk about the isthmus part of thyroid gland, the isthmus part of the thyroid gland is located at the level of 2nd, 3rd and 4th tracheal rings. So where it is located? It is located at the level of 2nd, 3rd and 4th tracheal rings. So this is also very important for you to know. The isthmus is that part of the thyroid gland which is connecting 2 lateral lobes, which is located at the 2nd, 3rd and 4th tracheal ring, and whole of the thyroid gland की location की बात करते हैं, it is corresponding to C5, C6, C7 and T1. Now you can see here, this is exactly the thyroid gland which you are seeing. So this is the whole outline of the thyroid gland. So L and L. What is L and L? Lateral lobe, and this is isthmus, which is this part, the two parts which is connected, which is the connecting part of the thyroid gland is the isthmus part. So what you can see that there is a small lobe which is called as the pyramidal lobe, which is which is a small lobe extending from the isthmus of thyroid gland. It is attached to the hyoid bone. It is attached to the hyoid bone here, and this extension of the lobe of the thyroid gland which is attached to the hyoid bone is called as levator glandulae thyroidi. What is it called as? It is termed as levator glandulae thyroidi. Levator glandulae thyroidi. Now, the exact location of the thyroid gland which I have marked as the right answer is the corresponding level of C5, C6, C7 and T1. So that is the most correct answer here. Now, thyroid gland is located in front of the neck and it is surrounding the level of the trachea and the larynx. The thyroid cartilage and cricoid cartilage is just lying above the gland below the Adam's apple. What is Adam's apple? The two thyroid cartilages in the midline will join, and that protrusion which is lying in the males more dominant and seen clearly in the puberty of the males, after the puberty of males, that is called as Adam's apple. The isthmus gland is extending from that of the second, third rings of the tracheal ring, and also can go towards the lower part of 6 tracheal rings. The infrahyoid muscle lies in front of the gland. The infrahyoid muscle along with sternocleidomastoid muscle is covering the lateral lobes. It is related on the lateral aspect of thyroid gland. So done with this, my dear students, let's move on to the next question. That is question number 8. Let me read it for you. A woman presented with a sudden onset of dysphagia. The woman has got the sign and symptoms which is mentioned here. The woman is suffering from dysphagia, dysarthria and gait ataxia. MRI relief. When the MRI was performed, it is showing that an acute infarction is seen in the right dorsolateral medulla. What is likely the diagnosis? Okay, the part of medulla which is affected in this case is right dorsolateral. So actually, for solving this answer rightly, we have to pay attention to the keywords which is mentioned in this MCQ. So acute infarction, this is a case of acute infarction where in the right dorsolateral medulla is affected, and we have to diagnose the case. So the right answer in this case will be, actually, if you remember, in neuroanatomy, it's very important to know all the syndromes of brainstem. So we have got many syndromes of the brainstem: lateral medullary syndrome, medial medullary syndrome, lateral medullary syndrome is also called as Pica syndrome, or it is called as Wallenberg syndrome. The other name of medial medullary syndrome is Digener syndrome. Now, and other than that, we have got other syndromes also: Benedict syndrome, Weber syndromes, Millard-Gulber syndrome. So we will talk about that in the further questions being asked from that topic. But अगर हम यहाँ पे medulla की बात करते हैं, what I am telling, the part of the medulla, which part of the medulla is affected? Dorsolateral aspect of the medulla is affected. तो वहाँ पे जो blood supply होती है dorsolateral part की is basically from posterior inferior cerebral artery. Which artery? Posterior inferior cerebral artery is involved, and the branches of vertebral artery is involved, and so many tracts and important structures are residing in the dorsolateral aspect of the medulla. So the function of all these will affected, and this condition is called as Wallenberg syndrome. The other name of Wallenberg syndrome is lateral medullary syndrome. Now, other options are not correct because these are not corresponding, and dysphagia, dysarthria and gait ataxia. So actually clinical sign and symptoms has also been mentioned in this MCQ, and we know that inferior cerebral peduncles which is connecting the medulla with the cerebellum, we have got afferents and efferents tract traversing. So exactly we have got dysphagia, we have got dysarthria, we have got gait ataxia. These are due to the affection of nucleus ambiguous. Nucleus ambiguous is a composite nucleus which is innervating the larynx, pharynx and soft palate, related to 9th, 10th and 11th cranial nerve. Gait ataxia is due to the cerebellum. So these structures are affected in case of lateral medullary syndrome, which is affecting dorsolateral blood supply of the medulla. Digener syndrome is not the right answer because in that part, medial part of the medulla is affected. So let's rule out the incorrect option and give the explanation of the correct answer. So already told you, lateral medullary syndrome is a neurological syndrome which is affecting mainly, which is causing ischemia. So in this case, there is involvement of ischemia on the medulla oblongata part. Medulla oblongata part of brainstem. So the lateral part of the medulla oblongata is affected, and basically the blood supply of lateral part is via vertebral artery and posterior inferior cerebral artery. The other name of Wallenberg syndrome is lateral medullary syndrome and Pica syndrome. It is also called as vertebral artery syndrome. So it is important that the question will be asked with other name of this syndrome. So you should be aware of all the names of Wallenberg syndrome. What are the name of Wallenberg syndrome? Lateral medullary syndrome, Pica syndrome, and vertebral artery syndrome. Now, lateral medullary or Wallenberg syndrome. Let's talk about the features of lateral medullary and Wallenberg syndrome. If I am talking about lateral medullary and Wallenberg syndrome, the important features which was given in the MCQ was that there was injury to nucleus ambiguous. So, if there is involvement of nucleus ambiguous, actually so many times in the previous years of examination, this has been asked either as an anatomy question, also as a question of medicine, that you should know about the brainstem syndrome. So Wallenberg syndrome, which is affecting dorsolateral part of the medulla, will affect nucleus ambiguous here. Why? Because nucleus ambiguous is located in the dorsolateral part of the medulla, and this is a composite nucleus which is giving innervation to ninth crane, which is basically in the composite nucleus of 9th, 10th and 11th, and this is giving innervation to pharynx, larynx, soft palate. So the patient will have dysphagia, dysarthria and dysphonia. The pain of the pain and temperature sensation of the same side of face is gone. Why the pain and temperature of the same side? So very, very important. You have to correlate the sign and symptoms with the nuclei located in that location. Loss of pain and temperature of the same side of face is gone. Why? Because of the involvement of spinal nucleus and tract of trigeminal nerve. Loss of pain and temperature of opposite side of the body is gone because of the involvement of lateral spinothalamic tract. So lateral spinothalamic tract is located in dorsolateral part of the medulla, and we know the function of lateral spinothalamic tract is contralateral pain and temperature of the body. What is the function of the spinal nucleus and spinal tract of trigeminal nerve? Same side sensation of face is gone. So whenever you get a clinical history of the patient in which the same side of pain and temperature is gone of the face, but opposite side the pain and temperature of the body is gone, that is a case of lateral medullary syndrome. Other than that, the other sign and symptoms which I want everybody to understand is giddiness. The giddiness will be there because of the involvement of vestibular nuclei, and also inferior cerebral peduncle is involved. So because we know that cerebellum is involved for maintaining the equilibrium. So when the cerebellum is injured, what will happen? ICP is injured, inferior cerebral peduncle is injured, the equilibrium function is gone, and the patient will have ataxia. Symptoms of the lateral horn, and also we know that sympathetic fibers descends in this part. So affection of sympathetic fibers will lead to the condition of Horner syndrome. And what are the key features of Horner syndrome? We know that Horner syndrome causes sunken eyeball, anophthalmos, the absence of sweating and hydrosis, constriction of pupil, which is called as miosis. So antosis, that is the drooping of upper eyelid. So these are the syndromes which will be seen because of affection of the sympathetic fibers involved in this case. Now, my dear students, let's pay attention to the other. Options. So why not Degener bulbar syndrome is the right answer. Now, the other name of Degerine syndrome is also called as medial medullary syndrome. What is the other name? It is called as medial medullary syndrome. Now, it is called as medial medullary syndrome where the arterial supply or blood supply of the middle part of the medulla is affected. So, this will lead, actually in the middle part of the medulla, there is location of hypoglossal nerve nucleus, there is location of pyramid, and there is location of medial lemniscus. That means the sign and symptoms of the patient will be corresponding to this Degerine syndrome in the affection of these three structures: hypoglossal nerve nucleus, the pyramid containing corticospinal fibers, and that of medial lemniscus. So let me just enlarge this. When I am enlarging this, you can clearly see deviation of tongue will be on ipsilateral side because hypoglossal nerve is involved. Hemiplegia on contralateral side because pyramid is involved, which is containing corticospinal fibers. Loss of disproportion of touch, proprioceptive sensation and vibration sense on the contralateral side of the body below the head is because of involvement of medial limniscus. So we have done. So that is the region. Digener anterior bulbar syndrome is the wrong option. Now, the other one syndrome which was given in the question was Babinski-Nicotti syndrome. Why Babinski-Nicotti syndrome is wrong? It's a rare disorder which is seen in a part of brain. Basically, medullary bulbar transition zone is involved. यहाँ पे कौन सा zone involved है? It is feeling the sign and symptoms is more or less equal to lateral medullary syndrome, but the area involved is medulla and bulbar transition area. So we will not mark it as the right answer. Symptoms are ataxia will be there, sensory deficit of the face, Horner syndrome, and loss of sensation on contralateral side. But basically not the dorsolateral part, but medullary bulbo transition area is involved. So we'll not mark Babinski-Nicotti syndrome as the right answer. Babinski-Nicotti syndrome is considered to be basically it is involving intermediolateral medullary syndrome. So basically it is not involving dorsolateral part of medulla, it is involving intermediate and slight part of the lateral medullary part, representing a lesion which is similar to that of lateral medullary syndrome. Weber syndrome is not the right answer in this case. The reason why Weber syndrome is not the right answer, because it's a syndrome of midbrain syndrome. It's a midbrain syndrome. And basically in this case, the nerve which is involved is oculomotor nerve is involved. So none of the sign and symptoms was showing affection of oculomotor nerve that will affect the extraocular muscle, will cause the movement of the eye will be involved. So such kind of history was not provided, not the midbrain was involved. So definitely Weber syndrome is not the right answer. So it is a condition in which there is ipsilateral third nerve palsy with contralateral hemiparesis hemiplegia. So it is called as a case of alternating hemiplegia. It is called also Weber syndrome. Other name is, it is called as superior alternating hemiplegia. So that is the reason this is not the right answer. So can we move on to the next question? So let's move on to the next question, question number 9. Now please identify the structure labeled A in the provided image and deficit in the image and tell me the right answer for this. So you have to identify A marked structure. So what we can see, this is A marked structure. Okay, so this is exactly the A marked structure as you can see here. Now here the key point for the identification will be here, this is the right and the left crux. So this is what? This is median arcuate ligament. This is median arcuate ligament. So the location of the opening which is lying just posterior to median arcuate ligament, A is the aortic opening. What is A? A is the aortic opening of diaphragm. A is the aortic opening of diaphragm here. This is vena cava opening. This is V for vena cava opening, and this is esophageal opening. This is esophageal opening. So that means the marked structure is A is the vena, is the abdomen, is the aortic opening. So we have to tell the right answer whether the structures passing through this opening is descending aorta, superior vena cava, inferior vena cava, or ascending aorta. So my dear students, the right answer will be descending aorta, which is passing through this. So that is important. So what is very, very important for you is to know all the structures passing through it. So you have to know all the structures passing through it, and you have to mention the correct answer. You have to mention the correct answer. That is very, very important. Okay. So so definitely here I want you to tell that A marked area is the aortic hiatus, and exactly aortic hiatus location is at the level of T12. It's the location of T12 vertebrae, which is exactly located behind the medial arcuate ligament. The three structures which is passing through the aortic opening of diaphragm, which is a major opening of diaphragm, This aortic opening, which is a major opening of diaphragm located at the level of T12, the structure passing through this will be thoracic duct, a gyrus vein, and descending aorta. So that is the reason descending aorta will be the right answer. That is the reason we will have descending aorta as the right answer. Now let's talk about this. So let me just enlarge this. So if I'm enlarging this, you can see the diaphragm, which is a partition between thorax and the abdomen, as you can see. And here what you will see, this is exactly what you can see here. We have got following structure. So we have got foramen of Morgagni here. Anteriorly, we have got a foramen. What is important for you is to know about each opening. So exactly what is foramen of Morgagni? I'm enlarging this. Foramen of Morgagni, which is also called as larynx, is an opening which is lying between the 7th costal cartilage. Now, what is important for you? So I just mark an important point about this opening. The location of this opening is between the slip of 7th costal cartilage, between the slip of 7th costal cartilage and sternal fibers. So exactly we know that the origin of the diaphragm is from the posterior aspect or xiphoid process of the sternum and from the 7th costal cartilage. So that space which is lying between the 7th costal cartilage slip and that of sternal fibers, that space is called as foramen of Morgagni on the right side and space of Lahr on the left side. The structure passing through it is internal thoracic artery and vein branch, and that is superior epigastric artery and vein. So that is the right answer. Now, if I talk about the esophageal hiatus, now esophageal hiatus, as you can see in this diagram, this is vena, V for vena cava opening at the level of T8, esophageal opening at the level of T10, and the structure passing through esophageal opening is following it. The structures passing is esophagus, anterior posterior vagal trunk, esophageal branch of left gastric artery and corresponding vein. So all these structures are passing through esophageal hiatus. Now what was asked in the MCQ was about aortic hiatus, and if I talk about the aortic hiatus, exactly this is the aortic hiatus, and through it passes aorta, azygous vein and thoracic duct. Now other minor openings and the vena cava here, if I talk about the vena cava, so see here, if I just show you the vena cava, can you see here, this is the vein which has been, so this is the inferior vena cava vein, and vena cava hiatus is at the level of T8. Right phrenic nerve and inferior vena cava passes. What passes through it? T8 is the level, and inferior vena cava and right phrenic nerve passes through it. Right phrenic nerve passes through it. Now minor opening से क्या pass करता है? तो greater lesser splanchnic nerves and all structures passes. So definitely this is the quick revision, and exactly the question being asked for the openings of the diaphragm is very important. So you should know all the major and few of the minor openings of the diaphragm and the structures passing through this. This is a very important question to be asked in your examination. So let's move on to the next MCQ. Again, this MCQ is from the previous year of examination of FMG. Which dural venous sinus receives the great cerebral vein of Galen as one of its tributary from the following position? Which dural venous sinus is receiving great vein of Galen as one of the tributary among the following options? The options are A, B, C, D. Options are A, B, C, D. So we have to know that great cerebral vein of Galen is a tributary of which vein? The first thing is that you have to identify what is A, what is B, what is C and D. Okay, so I will give you a time for identification. See this image and have an idea of identification of these veins. So exactly then you can mark this as the right answer. So exactly A here is superior sagittal sinus, which is an important content of flux cerebri. C is sigmoid sinus. As you can see, it is curved. D is superior petrosal sinus. And B is straight sinus. B is straight sinus. B is straight sinus. So exactly the correct answer here will be B, because great vein of Galen as one of its tributary, the correct answer is straight sinus. So in this condition, great cerebral vein of Galen, the formation of great cerebral vein of Galen is by the two veins which is leading to its formation, that is the two internal cerebral vein, and this is exactly located between the location of great cerebral vein of Galen. It's located between the splenium of corpus callosum and quadrigeminal plate, and it drains into which sinus? Straight sinus. So we have marked straight sinus as the right answer. I have already given you the details of what is A, B, C and D. B is straight sinus, so that is the correct answer. And if I talk about option A, it is superior sagittal sinus, C is superior petrosal sinus, and D is sigmoid sinus. That is already done by me. And I just want everybody to pay attention to this image. Why you have to pay attention to this image? Because you can get a quick revision of important dural venous sinuses location. So this is the superior sagittal sinus in the attached margin of flux cerebri. This is the great cerebral vein of Galen, and in this diagram you can see great cerebral vein of Galen is draining into straight sinus, so only straight sinus is the right answer. Here we have got the curved sigmoid sinus. This is inferior sagittal sinus. This one is the cavernous sinus located one on either side of the body of sphenoid. And all these sinus, all these dural venous sinus. What is dural venous sinus? Which is formed by the separation of the two layers of the meningeal, that is the endosteal and that of the meningeal layer, and the dural venous sinus is traversing through it, and the blood from all the dural venous sinus will ultimately drain into internal jugular vein. So only we have got this as the right answer. Now let's move on to the next question, that is question number 11. Is it okay? Can we move on to the next one, that is question number 11? Okay. Identify the anatomical structure indicated by the provided image. Identify the anatomical structures indicated by the provided image. So you have to identify the structure, and here how you are going to identify. So let's see this. Identify. Okay. So I just want you to, this is an location, the anatomical snuff box. This is also from the previous year of examination. So you can see the anatomical snuff box. You have to correlate that where is anatomical snuff box located and what are the important thing is you have to know the boundary of anatomical snuff box. You have to know the tendons which is forming anterolateral boundary, the tendons which is forming posteromedial boundary of anatomical snuff box. Then you have to know the structures residing in the roof of anatomical snuff box. Then you have to know the content in the anatomical snuff box. So here you have to identify the structure. The option provided is abductor pollicis brevis, extensor pollicis brevis, abductor pollicis longus, and extensor pollicis longus. So my dear aspirants, the correct answer in this case will be extensor pollicis longus. D is the right answer, and I will tell you how. So exactly अगर हम anatomical snuff box की बात करते हैं, तो its anterolateral boundary is formed by abductor pollicis longus and extensor pollicis brevis. Its posteromedial boundary is formed by extensor pollicis longus muscle. So when you hyperextend your thumb, here in there is a depression, you will see here if you do, and here it depress. In some of the persons, this depression is quite evident, and this depressed area is called as anatomical snuff box. Why it was called as snuff box? Because in earlier time, perfumes were kept here, and it can be taken sniff, so it is called as anatomical snuff box. So the more the structure which has been asked in this MCQ is extensor pollicis longus, which is forming medial. To be more specific, it forms posteromedial boundary of anatomical snuff box. So if I talk about the boundaries of anatomical snuff box, अगर हम boundaries की बात करते हैं anatomical snuff box की, write down boundaries of if I talk about boundaries of anatomical snuff box, the boundaries of anatomical snuff box is following. Its anterolateral boundary is formed by, anterolaterally it is bounded by, abductor pollicis longus and extensor pollicis brevis. My dear students, I have written in small form. APL means abductor pollicis longus. EPB means extensor pollicis brevis. Posteromedial boundary. If I talk about posteromedial boundary, it is formed by EPL. What is EPL? Extensor pollicis longus. Extensor pollicis longus. So we have got the right answer, that is extensor pollicis longus. Anatomical snuff box. Its the other name is, it's also called as foveolo radialis. It's a triangular depression which is located in the dorsal aspect of the hand at the level of carpal bones, and exactly the structures of the carpal bone which is forming the floor. So the floor is formed by, if I talk about the floor, the floor is formed by scaphoid and trapezium carpal bone. Now this is exactly the anatomical snuff box, and I want everybody to concentrate on this image. So when I'm enlarging this image, so you can just see this. So see here, when I'm enlarging this image, you can see the anatomical snuff box. It is so here, if you will see, this tendon has been highlighted and this tendon has been highlighted. So this tendon which you are seeing here, these tendons, so this is anatomical snuff box which is located in this space, and anatomical snuff box anterolateral wall is formed by APL and extensor pollicis brevis, and this is extensor pollicis longus which is forming posteromedial boundary. In the roof of anatomical snuff box, when I'm talking about the roof of anatomical snuff box, the structure traversing through the roof of anatomical snuff box is superficial branch of radial nerve and cephalic vein, and the content which is lying inside is the radial artery. So if you want to write, please write down. This is very important. Please write down these important points. Write down roof of anatomical snuff box. Roof of anatomical snuff box. Roof of anatomical snuff box is formed by superficial fascia, is formed by superficial fascia, and the structures residing in the superficial fascia is superficial branch of radial nerve and cephalic vein. And if I talk about the content which is lying inside, in the anatomical snuff box, the content is radial artery. The content is radial artery. So done with anatomical snuff box. Now let's move on to the next MCQ. So I hope you are understanding. Okay, I hope the session you are understanding. So let's move on to the next one. That is question number 12. Now before that, I just want to rule out the other option. Why the other options are wrong? So I always tell, for solving the correct answer, either you directly go to the correct answer if you are 100% sure about it. Other thing is that you can also rule out the other option and approach to the right option. So option A is wrong. Why? The reason why option A is wrong is abductor pollicis brevis. Abductor pollicis brevis is not forming the boundary of anatomical snuff box. Extensor pollicis brevis is wrong because it is forming anterolateral boundary along with abductor pollicis longus. Abductor pollicis longus is also forming anterolateral boundary, not the posteromedial boundary of anatomical snuff box. So that is the reason they are not correct. Now moving to the next MCQ, that is question number 12. Again, a question being asked from the previous year of examination. In the given image, which artery can be felt by touching the important artery as listed below? So you can just see the artery being palpated, and you can have a look on the lower aspect of the foot. The ankle has been sewn, and the lower aspect of the leg showing the ankle joint and everything has been sewn. So you have to just make a guess, and you have to tell which artery is being palpated. So this is the medial view. Please mark it. It is the medial view which you are seeing. So now tell me the right answer, that which artery is palpated, whether it is anterior tibial artery, whether it is posterior tibial artery, whether it is dorsalis pedis artery or popliteal artery, My dear, the correct answer is posterior tibial artery, and I will tell you why it is the correct answer. Now, Posterior tibial artery. So exactly, I just want to enlarge this image. When I'm enlarging this image, you can just have a look on this. So here you can see this part which has been shown here. This is which part? This is the flexor retinaculum part. Okay. So this is the flexor retinaculum part. This is the flexor retinaculum part which you are seeing, and it is lying on to the, it is connecting medial malleolus and here on the medial side, as you can see here. Now the structures traversing beneath is the posterior tibial artery and the vein. We have got the flexor hallucis longus tendon, flexor digitorum longus, and also posterior tibialis posterior. So exactly flexor retinaculum, which is extending from medial malleolus. So the extension of flexor retinaculum is from medial malleolus to that of medial aspect of calcaneum. This is medial tubercle or medial aspect of calcaneum. So this is the attachment of flexor retinaculum of the foot and the structures passing below. The structure passing below the flexor retinaculum of the foot is, the doctors are not here. So D for tibialis posterior, the doctors, flexor digitorum longus, artery, nerve, here that is flexor hallucis longus. So here the posterior tibial artery is the right answer. So posterior tibial artery is palpated between the medial malleolus and that of the medial malleolus and calcaneum. An exact location is that it is exactly a branch from the popliteal artery in the popliteal fossa. It is combined by posterior tibial vein along its course, and it passes posterior to medial malleolus, but it is lying anterior to Achilles tendon. The course of this artery is that it is passing beneath flexor retinaculum of the foot, and it runs in the tarsal tunnel. Where it is running? It is running in the tarsal tunnel, which is very important location. So definitely the right answer is posterior tibial artery. Now, it's also important that we should strike out the other option. So let's move on to the other option. Why anterior tibial artery is not the right answer? Exactly, anterior tibial artery, it's another branch from popliteal artery. The continuation of anterior tibial artery, when it goes towards the dorsum of a foot, is forming dorsalis pedis artery. And it can be palpated. It can be palpated on a dorsum of foot lateral to the tendon of which muscle? The lateral to the tendon of extensor hallucis longus muscle. Dorsalis pedis artery can be palpated lateral to extensor hallucis longus muscle. Same goes with the popliteal artery. Popliteal artery is also not the right answer, because popliteal artery can be palpated on deep palpation on the back of your knee, and the reason where it is palpated is over the back of the knee in the popliteal fossa. So that is the reason it is also not the right answer. Dorsalis pedis artery is definitely not the right answer, because it will be palpated on the dorsum of foot. It will be palpated on the dorsum of the foot. It will be palpated on the dorsum lateral to the tendon of extensor hallucis longus. So it will be palpated lateral to the tendon of extensor hallucis longus tendon and medial to the tendon of extensor digitorum longus on the dorsum of the foot. And this is exactly a very important reliable landmark against navicular bone. It can be palpated, which is a very reliable landmark for the palpation of which artery? The dorsalis pedis artery. Now, I also want, actually related to this topic, I want to explain one more thing which is asked in the examination. The structures passing beneath flexor retinaculum of the foot and the extensor retinaculum of the foot. So that structures can be memorized by. So let us write that. So all of you can just write this. So write down. Structures passing beneath flexor retinaculum of foot. So the structures passing beneath flexor retinaculum of the foot can be memorized by a mnemonic. So I am talking about these structures from medial to lateral. From medial to lateral. And the mnemonic is the doctors are not here. The doctors are not here. So here T, D, A, and H. You have to highlight this word which will give you the right answer. So here, T for tibialis posterior. D for flexor digitorum longus. A for anterior tibial artery. No, sorry, it's a flexor retinaculum, so it's posterior tibial artery. Sorry, it's an artery, posterior tibial artery. N for tibial nerve, and H for flexor hallucis longus. Flexor hallucis longus. Flexor hallucis longus. So done with this. So I have given all the structures mnemonic. The doctors are not here. Which are the structures traversing beneath the flexor retinaculum of the foot from medial to lateral? I also want everybody to know the structures passing beneath extensor retinaculum of the foot from medial to lateral. So there is another mnemonic for that. So if you want, you can just have a, so please highlight this. Now, please write down the other heading, structures passing beneath extensor retinaculum of the foot, beneath extensor retinaculum of foot. Structures passing beneath extensor retinaculum of the foot. Here also we are talking about the structures passing from medial to lateral. So for that also I am going to tell you a mnemonic. The mnemonic is, so please note down, the mnemonic is tall husbands are never dear person. So the mnemonic is tall husbands are never dear person. THANDP. Tall husbands are never dear person. The mnemonic is like this, and we have to know the structures passing beneath it. So here T stands for, my dear students, here T stands for tibialis anterior. H stands for extensor hallucis longus muscle. Extensor hallucis longus muscle. A stands for artery. Anterior tibial artery. N stands for nerve. Deep peroneal nerve. Deep peroneal nerve. D stands for extensor digitorum longus. D stands for extensor digitorum longus muscle. And my dear, P stands for peroneus tertius. Peroneus tertius. So done with this. So that means we have done with the structures passing beneath the extensor retinaculum as you traverse from medial to lateral. As you traverse from medial to lateral. So done with this. Now let's move on to the next option. Next question. So is it okay? Let's move on to the next question. That is question number 13. Identify the type of joint has been shown in this image, whether it is symphysis, syndesmosis, synchondrosis or synostosis. So here I just want everybody to look on these areas. So everyone should look on this area and then you can give me the right answer. So that means you have to identify this part of the joint and then you can give me the right answer. So that is an articulation between radius and ulna. It is not superiorly, it is not inferiorly. So which joint is this? This is middle radio-ulnar joint. Which joint is this? This is middle radio-ulnar joint. This is middle radio-ulnar joint. This is middle radio-ulnar joint. So exactly, we have to identify the joint, which we have already done. It is middle radio-ulnar joint. Now you have to tell me whether it is a type of joint symphysis, whether it is a type of joint that is syndesmosis, whether it is synchondrosis or synostosis. So in this case, the right answer will be syndesmosis. It's a type of fibrous joint. Which type? It is the type of, sorry, it's a type of syndesmosis type of joint. So syndesmosis is a it's a syndesmosis is the joint which is slightly movable, and it is composed of interosseous membrane. So the middle part, if I talk about the middle part of radius and ulna, the middle part of radius and ulna is connected by interosseous ligament. It is connected by which ligament? It is connected by interosseous membrane, and that interosseous membrane connection is forming middle radio-ulnar joint, which is a type of syndesmosis type of joint. It's a syndesmosis type of joint. And here you already know the middle radio-ulnar joint is syndesmosis. It is syndesmosis type of joint. If I talk about superior, if I talk about superior radio-ulnar joint, the superior radio-ulnar joint is pivot type of synovial joint. Inferior radio-ulnar joint, again the inferior radio-ulnar joint. The inferior radio-ulnar joint is a type of pivot type of synovial joint. Pivot type of synovial joint. Okay, now done with this. Now let's talk about the other options. So why other options are wrong? So if I talk about symphysis, symphysis is a type of fibrocartilaginous fusion. Okay, so all the symphysis joint, which is a type of cartilaginous joint, which is having hyaline cartilage in between, we have got fibrocartilage in it, and these are the midline joints. So it's a type of secondary cartilaginous joint, so it is not the right answer. So the joints which is lying in the midline in our body, like intervertebral disc, pubic symphysis, manubrosturni, all such kind of joint is a type of symphysis or secondary cartilaginous joint. Synchondrosis, if I talk about synchondrosis, sorry. So we are talking about synchondrosis, the joint which is having the articulation with hyaline cartilages. So the bones are connected with a hyaline cartilage and is united by a hyaline cartilage. It's not having the fibrocartilage, and later in the life it gets fused and it is forming synostosis. So the example of primary cartilaginous joint or synchondrosis is the epiphyseal growth plate. It's the epiphyseal growth plate. The next is synostosis. The bony fusion which takes place in the bone of the skull is called a synostosis. So again, synostosis is also not the right answer. Now, my dear students, let's come up with the next question. That is, a man is brought to the emergency department. The man is brought to the emergency department after falling from a height with its hands outstretched. Okay, with its hands outstretched. Okay, so the man is brought to the emergency department after falling from a height when he or she is falling down. They are falling with an outstretched hand. An X-ray shows a clavicular fracture. The clavicle is fractured. What would be the right location of the clavicular fracture? Whether what is it, A, B, C, and D? Whether it is junction between medial 2/3 and lateral 1/3, whether the junction is between medial 1/3 and lateral 2/3, whether the junction is between middle 1/3 and medial 1/3, or middle of the clavicle. Actually, again, for understanding this, I just want everybody to understand this. Actually, if you want, I can have a clavicle for it. So just a minute, I will just, sorry for it. I just want to show you a clavicle also. We can show. Yeah, I have got it. So just a minute. Okay, so exactly what I'm showing you is the clavicle. Okay, this is the clavicle bone, which is a long bone, but it is atypical. Why it is atypical, I will tell you. The reason why it is atypical is that because it is lying horizontally in our body. So this is the clavicle bone, as you can see. Yeah, this is the clavicle bone. Now, when you see the clavicle bone, I am holding it in the right position, and I just want you to show this clavicle bone like this. So if you will see this clavicle bone, this is the medial end and this is the lateral end. Now, if you will see it more correctly, what you can see, I am holding like this. What you can see, this is convex. So it is convex medially. What you can see, it is convex in the medial part, and it is convex in the medial 2/3 part, and it is concave in the lateral 1/3 part. So the junction of medial 2/3 and the junction of lateral 1/3, if I talk about this part is the weakest point of the clavicle which can get fractured. That is the junction of that is the junction of medial 2/3 and lateral 1/3. So the right answer in this case will be junction of medial 2/3 and lateral 1/3 is the weakest point and commonly injured in the case of clavicle fracture. So that is the right answer. Clavicle fracture most commonly occurs at the junction of medial 2/3 and lateral 1/3 due to its superficial location. So the clavicle bone is more superficially located, and because it is superficially located, it can be palpable along its entire length. That is an atypical feature of the clavicle bone, and it has got numerous ligaments in the muscle attached to it. It is a atypical bone because this is a type of long bone, but it is lying horizontally in our body. It is pierced by intermediate or middle supraclavicular nerves, and the most common site of being fractured is medial 2/3 and lateral 1/3. It is having two primary centers of ossification, and this is one of the bone which is most earliest to ossify, and the primary center of ossification appears by about 5th week of intrauterine life. So that is an important point about this, and so only the other options is absolutely wrong. So let's move on to the next, that is question number 50. So what is the vertebral level that corresponds to the given structure? So we have got A, B, C, D. We have got 4 options. So exactly what is the vertebral level? So you can see here the umbilicus has been shown. So this is the umbilicus, as you can see. And so this is a very simple question. You have to just identify the location of umbilicus in this case. So you have to identify the location of umbilicus, and we know that the location of umbilicus is corresponding to L3 and L4 lumbar vertebra. It is located in between L3 and L4 lumbar vertebra. So that is, and dermatomal distribution corresponds to T10. So the answer will be L3 and L4 lumbar vertebra. But for better understanding what I want everybody to have a precise revision of important anatomical landmarks. So I'm just enlarging this image. So when I'm enlarging this image, you can have a so you can have a look. You can see this is the xiphoid process. As you can see, this is the costal margin which is seen. Now, exactly as I told you, this is the transpyloric plane. Which plane is this? So just a minute. This is the transpyloric plane. This is the subcostal plane. This is the transtubercular plane. As in the same type of question I have described previously also, but this is important. So these 3 planes location you can see, and this is the location of umbilicus which you are seeing. This is the location of umbilicus. So exactly you can see umbilicus is located between L3 and L4 lumbar vertebra. Transpyloric plane, adjacent planes at the level of L1. Subcostal plane at the level of L3. Transtubercular plane at the level of L5. Also, the highest point of iliac crest, it is also important for you to know the highest point of iliac crest corresponds to the level of L4 lumbar vertebra. Highest is also important for you to know. Highest point of iliac crest is corresponding to L4 lumbar vertebra. So definitely the correct level of umbilicus being located will be in between L3 and L4 lumbar vertebra. So it's a very easy one, and I think most of you are knowing it. So we will move on to the next question, that is question number 60. Okay, dear, let's move on to the next one. Okay, so this is a question. This MCQ is again from the previous year of FMGE examination. This is again an image-based question. What is the name of dural venous arrow identified in this radiograph? Whether it is straight sinus, whether it is superior sagittal sinus, whether it is inferior sagittal sinus, whether it is confluences of sinus. So I just want to enlarge this image. So when I'm enlarging this image, you can see the horizontal view of the brain section, and you can you have to identify the red color arrow. So here I am talking about this arrow, that is the red color arrow. You have to identify what this structure is. So also in this case, the hint is that you can see the ventricles of the brain, and you can have a correct location of this sinus. So exactly this sinus is the straight sinus. The correct answer is straight sinus, and I would like to show you the similar kind of image with an identification mark of important structures being visible, so that there is no doubt about the correct answer. So let's go with that. So marked structure is the straight sinus. As I told you, this marked structure which you have seen is the straight sinus. Here, this marked structure is the straight sinus. This marked structure which you are seeing is the straight sinus. Now, the marked structure is the straight sinus. I want you to see this image in correlation with the other important structures of this horizontal section. So see here, I want everybody to just see this horizontal section. of the brain, and this will help you to understand the marked structures being seen. So here you can see this is the straight sinus, no doubt about that. Here is the great cerebral vein of Galen. You can see, as I told you, this cavity which you are seeing, this is the cavity which you are seeing, and as I told you, these cavities are of lateral ventricle, anterior horn of the lateral ventricle. Also you can see the internal capsule here. So this area which, sorry, we will, this marking which you are seeing in the horizontal section, this is the part of internal capsule. So what is this? This is the part of internal capsule which you are seeing. That is a type of projection fibers. Also the part of thalamus is seen. Occipital lobe is seen. So here also you can see spaces filled with cerebrospinal fluid and the white matter. So all these are seen in the cross section. You can see, if you are seeing all these fibers, these are the fibers which you are seeing. These are all the fibers of white matters, and here this are white matter. So this is exactly the internal capsule which is seen. Okay, so done with the right answer here. So here let's B, C, D, and all. So here if I talk about, so B, C, D was not marked, only the straight sinus has been marked. So the right answer is straight sinus. Also, you have to know, if I talk about the other sinuses, so straight sinus is shown in this horizontal section. Superior sagittal sinus is not the right answer. Why? It will be seen in the upper attached border of flux cerebri. Inferior will be seen in the free borders, and the important sinuses meeting point at the level of trochlear hierophyly, actually it is at the level of occipital crest, and exactly that is the level where the transverse sinus, occipital sinus, superior sagittal sinus, straight sinus are meeting. That area is called as confluences of sinus. So definitely the correct answer in this case, will be straight sinus. So done. Let's move on to the next question. That is question number 17. Cruras of the diaphragms are musculo-tendinous bundles that arises from. Cruras of the diaphragms are musculo-tendinous bundles that arises from. So the options are posterior longitudinal ligaments, sternum, bodies of lumbar vertebra, that is L1, L2 and L3, and renal fascia. So if I talk about the diaphragm has got its origin. If I talk about the diaphragm is having its origin from the so if I talk about the diaphragm is having its origin from the sternum, posterior aspect of the xiphoid process of sternum, that is sternal origin. Also from the ribs, costal cartilages, lower ribs and their costal cartilages. Also from the vertebrae, from the anterior aspect of vertebrae in the right side in the form of right crux, from the anterior aspect of L1, L2 and L3 lumbar vertebrae, and that of the intervertebral disc, and from the left crux from the anterior aspect of L1 and L2. So the bodies, the cruras of diaphragms are basically arising from the bodies of lumbar vertebra L1, L2 and L3. For the better understanding and the location of the origin of cruras of the diaphragm, I would like to show you an image. So just a minute. So this is, here you can see, this is the musculotendinous, it is the muscular, what is diaphragm? So if you will see, this is exactly the diaphragm which you are seeing. And if I talk about the diaphragm, this part which is the central tendon of diaphragm. What is this part? This is called as the central tendon of diaphragm, which is the insertion part of the diaphragm, which is trifoliate. This is trifoliate and inserting and meeting with the fibrous. This merges with the fibrous pericardium of the heart. Fibrous pericardium of the heart. Okay, this merges with the fibrous pericardium of the heart. Other than that, if I talk about right crux and the left crux, so you can say right crux. If I talk about the right crux, you can see this is the right crux and this is the left crux. So the origin of the right crux is, if I talk about the origin of right crux, it is from the L1, L2, L3 lumbar vertebra anteriorly and adjoining intervertebral discs. The left crux is from L1 and L2 and adjoining intervertebral disc. And the meeting of right and the left crux, this part is called as, the meeting of right and the left crux, this part is called as median arcuate ligament. What is it called as? It is called as median arcuate ligament. This is called as median arcuate ligament. So डेफिनेटली अदर देन दैट सो एग्जैक्टली अगर हम डायफ्राम के ओरिजिन की बात करें, डायफ्राम इज एन इंपॉर्टेंट टॉपिक. सो इट इज हैविंग एन ओरिजिन, it is having an origin that is sternal origin, that is from the xiphoid. So it is having sternal origin from the posterior aspect of the xiphoid process of sternum. It is having costal origin, that is from the lower ribs, costochondral junctions, lower 6 ribs, and it is having a lumbar origin or vertebral origin, you can say vertebral origin in the form of right and the left crux, and also it is originating from arcuate ligament. So there is 3 arcuate ligament: median arcuate ligament, that is connecting the right and the left crux of the diaphragm. Posterior to it lies the aortic opening of the diaphragm. We have got medial, 2 medial arcuate ligaments are there. 2 medial arcuate ligaments are there, and there are 2 lateral arcuate ligaments. There is lateral 2 arcuate ligaments. So that means there is 2 medial and there is 2 lateral arcuate ligaments. Together we will have 5 arcuate ligaments. Together we will have 5 arcuate ligaments, from which the diaphragm origin takes place. So we have got 5 arcuate ligaments from which diaphragm origin takes place from the posterior aspect of the xiphoid process of the sternum, from the costal slips, and from the vertebrae. So these are about origin, and as I told you, insertion part की बात करें, it is inserting into which structure? It is inserting into central tendon of diaphragm trifoliate merging with fibrous pericardium of the heart. So now let's move on to the next question. So it is slightly over. It's a very important question, question number 18. So let me just go with one more file, whether in that file it is easy to identify. Let me see. No, not this one. Yeah. I'm just coming to that question. Okay. Now coming to the same thing that so exactly if you will see here, if I talk about which of the following correctly describe the flow. So if you will see the question number 1. So अगर ये question की बात करते हैं तो ये CSF circulation के बारे में. What is this question is about? So there is slightly overlap only. Don't worry. So I will write it. So this question is about what is the correct order of CSF flow. So the question is about the correct order of CSF flow. So we know that if we are talking about cerebrospinal fluid flow, if we are talking about the cerebrospinal fluid, that is the that is exactly, if we talk about the maximum amount of cerebrospinal fluid is formed from the lateral ventricle of, that is formed from the lateral ventricle. Okay. Maximum amount of CSF is formed from the lateral ventricles. So lateral ventricles of brain, lateral ventricles of brain forms maximum lateral ventricles of brain form maximum amount of CSF. Okay, maximum amount of CSF is formed by lateral ventricles of the brain. The tila choroidea, actually choroid plexus, this is done by the choroid plexus. So the choroid plexus of lateral ventricle of brain is forming the maximum amount of CSF. From here, the CSF will move to third ventricle. And how it happens? It happens via interventricular foramen of Monro. And from third ventricle, it will go to fourth ventricle, and this happens via aqueduct of Sylvius. This happens via aqueduct of Sylvius. And when we are talking about from fourth ventricle, actually the roof of fourth ventricle is having foramen of Mesendi and foramen of Luschka. From here, it will pass towards the space. So exactly, I will like to show you this in this flow chart. So you can just, or firstly come to the flow chart. So see here, lateral ventricle. What is the role of lateral ventricle? It is forming the maximum amount. Lateral ventricle choroid plexus is forming the maximum amount of CSF. From here, the CSF will flow via foramen of Monro to the third ventricle. From third ventricle via aqueduct of Sylvis, it will flow to the fourth ventricle. From fourth ventricle via foramen of mesenchyme and Lusca, it will pass to subarachnoid space and the area around the brain and spinal cord, and it will be reabsorbed in the venous sinuses. Mainly it is reabsorbed by superior sagittal sinus arachnoid granulation. So it is absorbed by superior sagittal sinus arachnoid granulation. So this is the flow chart of circulation of CSF. This is exactly the flow chart of circulation of CSF. So this is showing you CSF circulation. This flow chart is showing you CSF circulation. Now, other than that, can you see this image? Here also, this is an image which is helping you to understand the CSF circulation. So the maximum amount. So see here. So exactly, this is the corpus callosum. Below it, this area is the lateral ventricle. So choroid plexus of the lateral ventricle will form maximum amount of CSF. From here, it will pass to interventricular foramen of Monro. Then it will pass to third ventricle. Then it will pass through cerebral aqueduct and it will reach the fourth ventricle. It will reach the fourth ventricle. From the fourth ventricle roof, there is lateral and median aperture, which will lead to the CSF going to the central canal and to that of the subarachnoid space. So this is how an absorption will be taken by arachnoid granulation of superior sagittal sinus. So exactly this is how the circulation of CSF takes place. So this is important to understand the correct order of CSF circulation, and you have to know how it is proceeding, how it is moving and circulating through the different part of ventricles and ultimately reaching to the subarachnoid space where the absorption of CSFs takes place via the arachnoid villi and granulations of superior sagittal sinus. Okay. Now let's move on to the next question, that is question number 19. Which of the following is true statement about stylo-mastoid foramen? Which of the following statement is true statement about stylo-mastoid foramen? So if I talk about stylo-mastoid foramen, true statement, so the options are located. Stylo-mastoid foramen is located between styloid process and the mastoid process of sphenoid bone. Stylo-mastoid foramen, through it passes the fifth cranial nerve, is transmitted through it. Okay. So we have to pick the correct one. So first thing is that you have to understand about stylo-mastoid foramen, location, structures, traversing, and then you can mark the right answer. It is sensory nerves of the facial nerve is traveling through it. Stylo-mastoid branch of posterior auricular artery is traveling through it. So you have to mark the correct answer. Question number 19. So if I talk about stylo-mastoid foramen, so first thing is that either for making a correct answer, so how you're going to approach to the correct answer, either you can go, the approach for the correct answer is either you can go via the correct answer if you're knowing it, or you can go via striking out the wrong option. These are the two options, these are the two categorization how you approach to the correct answer. So yahan pe, what is the name of foramen? Stylo-mastoid foramen. So if I'm talking about the name of the foramen, this stylo-mastoid foramen should be located between the styloid process of temporal bone, the styloid process of temporal bone and the mastoid process of temporal bone. So that means exactly it will be located in between styloid process of temporal bone and mastoid process of temporal bone. So here sphenoid bone is used, to definitely A is wrong option. Cranial nerve 5 is transmitting through it is absolutely wrong, because stylo-mastoid foramen से कौन सा nerve emerge out होता है? 7th cranial nerve, that is the facial nerve. So that is absolutely wrong. Now sensory area of the face. My dear students, sensory area of the face or sensation of the face is done by trigeminal nerve, 3 divisions: ophthalmic, maxillary and mandibular. So definitely if trigeminal nerve is not passing through the stylo-mastoid foramen, so how can be it the right answer? So C is also wrong. So now we have come to the correct answer. The correct answer is stylo-mastoid branch of posterior auricular artery. So you have to mark the right answer, and my dear students, the right answer is stylo-mastoid branch of posterior auricular artery is traveling through it. Stylo-mastoid branch of posterior auricular artery is traversing through it. The reason why is this the correct answer is the reason why, because we know that seventh cranial nerve is traversing through it along with the stylo-mastoid branch of posterior auricular artery. So definitely D is the right answer. Now, the stylo-mastoid branch, the stylo-mastoid foramen is located between styloid process and the mastoid process of temporal bone, and it terminates the, what are the structures passing through it? Two structures passing through this foramen is facial nerve and stylo-mastoid artery. Stylo-mastoid artery and facial nerve is traversing through the stylo-mastoid foramen. So definitely we will have the fourth one, that is stylo-mastoid branch of posterior auricular artery. Stylo-mastoid artery is a branch of posterior auricular artery which is passing through it. Now I just want everybody to locate stylo-mastoid foramen. So I am enlarging this. Actually this diagram is showing you, this diagram, if I talk about this diagram is showing you the skull bone from the basal aspect. So when you see the skull bone from the basal aspect, you can see this is the styloid process. What is it? This is the styloid process. And this is the mastoid process. What is this? This is the mastoid. Let me just... So I have just highlighted this structure. So what you can see, this is mastoid process of the temporal bone, and this is the styloid process of temporal bone, and as I told you, these are the parts of which bone? Temporal bone. And there is a foramen. Can you see there is a foramen? This foramen is stylo-mastoid foramen. So the exact location of this foramen will be in between styloid and mastoid process of temporal bone and not sphenoid bone. So that is the reason the first option was wrong. So I hope you are understanding this. The location, इसमें कोई doubt नहीं है. Structures passing through it is already told you, that is the seventh cranial nerve and stylo-mastoid artery, branch of posterior auricular artery. Done. Now I would like to show you another image. So just see it. This is the real skull bone, and the view which you are seeing. The view which you are seeing is the inferior aspect. What you are seeing is the inferior aspect of the skull from the basal aspect, and you can see the foramen, and you can locate the foramen in between the styloid process and the mastoid process. So you can see here, this is the styloid process, this is the mastoid process. This is the mastoid and this is the styloid process. Of which bone? Of temporal bone. Which bone we are talking about? We are talking about temporal bone. Now, and exactly the foramen which you are seeing here, my dear students, the foramen which is shown by this yellow color arrow is which foramen? This foramen is stylo-mastoid foramen. So now I hope you are clear with the location of stylo-mastoid foramen. Everybody is clear with the location of stylo-mastoid foramen, and I hope there will be no doubt about this. Structures passing through it is already told to you. Structures traversing through it is already told to you. So let's move on with the next question. Can we go to the next question? Is it okay? Okay, so let's move on to the next question. Question number 19 we have done. Now I want everybody to focus on next question, that is question number 20. Now, all of the following are example of traction epiphysis except. All of the following is an example of traction epiphysis except. So that means for solving this question correctly, it is important that you have an idea of all type of epiphysis. You have an idea of all type of epiphysis, where it is located, what are the types of epiphysis, and then you can mark the right answer. The options which is given to you for question number 20 is whether it is a type of mastoid process, whether the traction epiphysis example is mastoid process, greater trochanter of the femur, lesser trochanter of the femur, deltoid tuberosity. All of the following are example of traction epiphysis except. Okay. So exactly, अगर हम epiphysis की बात करते हैं तो epiphysis is the part of long bone at the end. So epiphysis, अगर long bone की बात करते हैं तो it is having the parts upper and lower end is epiphysis, the middle or the shaft part is diaphysis, and the area which is lying in between epiphysis diaphysis is the metaphysis. So diaphysis is the strongest part of the bone, epiphysis is the part of the bone where secondary center of ossification appears, and metaphysis is the most vascular part of the bone. So exactly अगर इस question को solve करें so it's very easy to solve because the question is being asked about traction epiphysis, that is one of the type of epiphysis. यहाँ पे जो question ask किया गया है वो traction epiphysis के बारे में है. And if we talk about epiphysis, we have got four. We have got pressure epiphysis. Pressure epiphysis के बारे में बात करें तो pressure epiphysis are formed by those part of the bone which is actually taking part in the formation of joint. Okay, like ends of the bone, for example, head of humerus and the scapula glenoid cavity is joining. So they are exactly, head of humerus will be the part of pressure epiphysis, head of femur will be part of pressure epiphysis because they are involved in weight transmission and they are exactly involved in the formation of joint. Traction epiphysis की बात करते हैं तो traction epiphysis is not taking part, they are non-articular part of the bone, they are not taking part in the bone formation, but they are formed by the pull of muscles and ligaments. Okay, and they are lying close to the pressure epiphysis, but they are not pressure epiphysis, they are not articulating part of the bone, they are non-articulating part of the bone located near the pressure epiphysis. The example of traction epiphysis will be the greater and the lesser tubercle of the humerus, greater and lesser trochanter of the femur. So that means greater and lesser trochanter of femur is the parts of pressure epiphysis. So ये भी pressure epiphysis हो गया. So ये भी pressure epiphysis, sorry, ये भी traction epiphysis हो गया. और mastoid, अगर हम mastoid process की बात करते हैं, mastoid process पे अगर outer aspect ये mastoid process है तो वहां पे भी pull of muscles होते हैं. So it is also an example of traction epiphysis. So the correct answer will be deltoid tuberosity. Why? Because deltoid tuberosity, if you have an idea of humerus bone, so again, if you want, let me just show you one of the bone, that is the humerus bone. So let me just focus to that. Please wait. Okay, just a minute. I want you to show the humerus bone. Okay. Okay. So exactly आपको ये explain करना है कि deltoid tuberosity being a part. So let's see. So if I'm talking about deltoid tuberosity, why deltoid tuberosity is not a part of epiphysis? That is important for you to understand. The reason is that if I talk about the reason is that, let's see, this is a humerus bone, no doubt about this. This is a humerus bone. Okay, this is a humerus bone. Here the head will lie medially forward, upward, and this is the lower condyles of the humerus bone. So just yeah, can you see? This is the humerus bone. Now, if I talk about the humerus bone, if I'm talking about the humerus bone, in the middle part of the humerus bone here, the rough part is seen. Okay, so V-shaped roughened end is seen. So if I see here, यहाँ पे V-shaped roughened end है, यहाँ पे deltoid tuberosity. So that is called as this rough part V-shaped we are seeing. That is called as the, see here, this is the deltoid tuberosity, and deltoid muscle will insert on this area. Deltoid muscle is inserting on this area. So if you will see this bone, these are ends of the bone. Yani head of humerus is pressure epiphysis, condyles of the humerus is also pressure epiphysis, but not the epicondyles because they are traction epiphysis. But अगर deltoid tuberosity की बात करते हैं जहां पे deltoid muscle का insertion होता है, that is lying in the middle part or in the shaft of humerus bone, so it is a part of diaphysis. It's not a part of epiphysis. Is it okay? So that means, coming to that point, deltoid tuberosity so just a minute. So that means deltoid tuberosity is located on the diaphysis part of the bone. So definitely the correct answer is deltoid tuberosity, which is not kind of any type. It's not a kind of epiphysis only. It's a diaphysis. So यहाँ पे अगर हम देखते हैं तो head of the femur will be a part of pressure epiphysis. Condyles. So अगर हम condyles, not the lateral and medial epicondyle, traction epiphysis होगा. और ये जो deltoid tuberosity है, which is the roughened part in the shaft of the bone, that is an example of diaphysis. So in brief, you should understand about epiphysis also. So I just want, yeah, I have included. So definitely we have got traction epiphysis So I just want everybody to have, actually this is a part of general anatomy, and it is important that you should have a quick recapitulation of this topic. So I would like everybody to have a recapitulation of this topic. Okay. So traction epiphysis is actually the region of the long bone which is non-articular, and it is involved in joint formation. It is not involved in joint formation. Unlike pressure epiphysis, traction epiphysis is not involved in weight transmission. It will lie close to pressure epiphysis. Ligaments, muscle, tendons are attached to it. Traction epiphysis will ossify later than the pressure epiphysis, and the example of traction epiphysis are like the trochanters of the femur, the tubercles of the humerus bone, mastoid process of the temporal bone. Deltoid, if I talk about deltoid tuberosity, it is the part which is lying in diaphysis, so it is the correct answer. Now, just going through the quick revision of different kind of epiphysis, their location and for understanding. So you can just see this. Here we have got a pressure epiphysis which is actually taking part in the formation of joint. So example will be head of femur, head of humerus, condyles of humerus, femurs, tibia. In other words, you can tell all the parts of the bone which is taking part in the formation of joint is an example of pressure epiphysis. Traction epiphysis formed by the pull of ligaments, muscles, tendons. The example, the lesser and the greater trochanter and tubercles of the humerus. It is also medial epicondyle and lateral epicondyle. So also by lateral and medial epicondyles of the humerus and the femur bones. Now also there is so this becomes first, this becomes the second, and we have got third and fourth variety of epiphysis. So one of the epiphysis, aberrant epiphysis. So when I am talking about aberrant epiphysis, it means the location of epiphysis is abnormal location. So it is not normal location. The example of such kind of epiphysis is present at the head of first metacarpal and the base of other metacarpals. Atavistic epiphysis के दो example होते हैं. The word atavistic means in lower animals, if you will see such kind of epiphysis, it is present in lower animals. So if we talk about such kind of epiphysis, it is present as a separate bone. But if we are taking an example of human beings, they are combining with one bone. For example, os trigonum or posterior tubercle of talus is an example of atavistic epiphysis. Coracoid process of an scapula is also an example of atavistic epiphysis. Okay. So done with this. Now let's move on to the next question. So let's move on to the next one. That is question number 21. During an attempted, so this is a clinical question. Let's start with the discussion of this. During an attempted suicide, a depressed young woman slashes her wrist with a straight razor. She cuts proximal to the pisiform bone to the depth of superficial aspect of flexor retinaculum. So that is a very important key point. The injury is happening proximal to pisiform bone. The injury is happening proximal to pisiform bone to the depth of superficial aspect of flexor retinaculum. That means the structure which will be injured will pass superficial to flexor retinaculum. And as a result, when she see the blood, so she was attempting the suicide, and as a result, she was having a neuromuscular deficit. So she has injured an important structure which is passing superficial part of the flexor retinaculum, and she has injured it. So can you tell me what will be the clinical feature or presenting sign and symptoms in this girl? The options are weakness of pronation, inability to abduct the thumb, weakness in the flexion of the thumb, and inability to adduct the thumb. So 4 options are there. As you can see, 4 options are there, and you have to go with the most right answer here. So definitely for the correct answer, you have to go with the most right answer in this case. So here, if we talk about the most right answer is the correct answer will be inability to adduct the thumb. I will tell you why. Because we know that the structure which is injured in this case is passing superficial to flexor retinaculum. And what is flexor retinaculum? Flexor retinaculum is a modification of deep fascia. Flexor retinaculum, what is flexor retinaculum? It's a modification of deep fascia, and this flexor retinaculum is having ulnar nerve and ulnar artery which is passing superficial to it. The structure which is passing deep to it is the tendons of flexor digitorum profundus, flexor digitorum superficialis, and also the medial nerve and flexor pollicis longus. Ulnar nerve, ulnar artery, and palmaris longus are the structures which is passing superficial to flexor retinaculum. So what we can see, I am just enlarging this image. So if you will see here, I will use green color. So this structure which you are seeing is the flexor retinaculum. The other name of flexor retinaculum is, so here you can see this is the flexor retinaculum, and the other name of flexor retinaculum is transverse carpal ligament. It is called as transverse carpal ligament. So this is called as transverse carpal ligament, flexor retinaculum. Now what you can see here, the two structures, can you see here, this is ulnar nerve and ulnar artery. So ulnar nerve and ulnar artery is passing superficial to it. Actually it is covered by a superficial slip. So it is slightly covered by a superficial slip of the flexor retinaculum which is called as volar carpal ligament. But this two structures is passing superficial to flexor retinaculum. And here you can see medial nerve is passing deep to it. Also the palmar branch of medial nerve, palmar branch of ulnar nerve will pass superficial to it. Also a tendon that is flexor, that is palmaris longus will pass superficial to it. And other than that, you can see tendons of flexor pollicis longus, flexor digitorum superficialis, and profundus are passing deep to it. Now, one more question which has been asked in the previous year of NEET-PG exam also is that flexor carpi radialis is a structure tendon which is neither passing superficial to it nor passing deep to it. It is passing in between flexor retinaculum. So for that, I will write it for you. Now here I just want to show you another diagram where, my dear students, you can see this is the medial nerve which is passing deep to flexor retinaculum, and this is the this is flexor retinaculum. And this is volar carpal ligament, that is superficial slip of flexor retinaculum. Beneath it, which we have got ulnar nerve and ulnar artery passing. And we know that ulnar nerve is giving innervation. Ulnar nerve is an important nerve which is giving innervation to the important muscles or intrinsic muscles of the hand. So basically, major muscles of the hand, that is the muscles of hypothenar region, that is abductor digiti minimi, flexor digiti minimi, opponens digiti minimi, the medial lumbricals, the all of the palmar interossei, dorsal interossei, palmaris brevis muscle, and also the adductor pollicis muscle. Actually, adductor pollicis muscle is the graveyard of ulnar nerve. So that means adductor pollicis muscle, which is getting innervation from ulnar nerve, is damaged here or paralyzed. Why? Because ulnar nerve is cut. Agar ulnar nerve ही कट गया तो innervation of adductor pollicis gone, and when adductor pollicis means thumb. So अगर adductor pollicis muscle paralyzed हो गया तो adduction of thumb is not possible. Why? This happens due to cutting of ulnar nerve. And we know that ulnar nerve is giving innervation to adductor pollicis muscle. Adductor pollicis muscle, which is considered to be, adductor pollicis muscle is considered to be the graveyard. The adductor pollicis muscle is considered to be the graveyard of ulnar nerve. Now, it's better that you should also understand the structures passing superficial and deep to flexor retinaculum. So quickly, please write it. Then we will move on to the next question. So write down structures passing superficial to, structures passing superficial to flexor retinaculum of hand. So that structures are ulnar nerve, ulnar artery, palmar cutaneous branch of ulnar nerve, palmar cutaneous branch of ulnar nerve, palmaris longus tendon, the degenerating muscle, palmaris longus tendon, palmar cutaneous branch of medial nerve, palmar cutaneous branch of medial nerve. So that means these are the 5 structures which is passing superficial to flexor retinaculum. So that means definitely the ulnar nerve is injured in this case. Other than that, I want everybody to note down the structures passing deep to flexor retinaculum. It's also important that you should know. So let me just write that for you. Okay, so just write on. Structures passing deep to flexor retinaculum. Structures passing deep to flexor retinaculum. So if I talk about structures passing deep to flexor retinaculum of hand and wrist, that space is called as carpal tunnel. That space is called as carpal tunnel. And it is important that you should know all the structures passing deep to it, so that it's important. It has been asked several times in the MCQs also. Then the structures are medial nerve. So only medial nerve is compressed in carpal tunnel, causing carpal tunnel syndrome. The other structures are tendons of flexor digitorum superficialis, flexor digitorum superficialis, tendons of flexor digitorum profundus, tendons of flexor digitorum profundus, and flexor pollicis longus tendon, flexor pollicis longus tendon. So actually these are the structures which is passing in the carpal tunnel deep to flexor retinaculum. I just want to add on one more note point here. Flexor carpi radialis tendon. Flexor carpi radialis tendon. So exactly अगर flexor carpi radialis tendon की बात करते हैं, so it is an odd man out and has been asked in the NEET-PG exam. It is neither passing superficial nor passing deep to flexor retinaculum. It is passing between the slip of flexor retinaculum. Actually, when you will see the cross section, you can appreciate the flexor retinaculum is Y-shaped, and if it is Y-shaped, in between that Y slip, the tendon which is passing is flexor carpi radialis. So flexor carpi radialis passes through flexor retinaculum, That means it is passing neither above and nor below the flexor retinaculum. So done with this. Now let's move on to the next question. That is question number 22. Question number 22. Okay, let's start with this. So a 35-year-old man is admitted to the hospital with indirect inguinal hernia. Okay, with an indirect inguinal hernia. During an open hernioplasty, in contrast to the laparoscopic procedure, the spermatic cord and the internal abdominal oblique muscles are identified. Which component of the spermatic cord is derived from the internal abdominal oblique muscle? Okay, dear. So exactly ये clinical question में the most important point which you have to understand here, let me just highlight this. So यहाँ पे हमें क्या जानना है कि which layer of the spermatic cord is derived from internal oblique muscle. So this, in this clinical question, we have to know actually the layers of the abdominal wall muscle. If we talk about the layers of abdominal wall muscle, it continues in the scrotum, forming an outer covering. So if it forms an outer covering as you proceed from outside to inside. So we have got external oblique muscle, we have got internal oblique muscle, we have got transverse abdominis and fascia transversalis. So when this layer traversing into the pelvic perineal region, the scrotum region, it forms the covering for the scrotum, and it will form the external spermatic cord. It will form a covering for the external spermatic layers. So 3 layers of the structures is formed by this continuation. So you have to give me the right answer. The continuation of internal oblique muscle will form which structures in relation to the spermatic cord? The correct answer is cremaster muscle. The correct answer in this case is cremaster muscle. So for the proper understanding of this, I just want to enlarge this image. So when I am enlarging this, so we will use different colors for the continuation of abdominal muscle with that of scrotum covering. So let me use a green color for it. Yeah. So if you will see, this is the external oblique muscle. So this external oblique muscle, when goes towards the scrotum, as you can see, it is forming this layer, which is shown in the green layer. What it forms? That means external oblique muscle is forming external spermatic fascia. Now coming to the internal oblique muscle. So if I talk about internal oblique muscle, see here, this is the internal oblique muscle, and the continuation which you are seeing lower down here, this is forming cremaster muscle. This is forming cremaster muscle. Now, one more important point is here, this is transverse abdominis muscle, and here you can see transverse abdominis muscle is forming no layer. Transverse abdominis muscle is forming no continuation in the scrotum, but it is the fascia transversalis. So we will use another color. Let me use red color only. Here we can see this is the transversalis fascia, which will continue in the scrotum, and it will form the internal spermatic fascia. It will form the internal spermatic fascia. So exactly this continuation is very important for you to understand. This continuation is very important for you to understand. I will write it for you. External oblique muscle. So we have explained this, and you can see external oblique muscle continues to form the external spermatic fascia. So external oblique muscle continues to form external spermatic fascia in the scrotum. Internal oblique muscle form cremaster muscle and the fascia, and transversalis fascia, not the transverse abdominis muscle, is forming internal spermatic fascia. The same thing is also shown here when you can see the cross. So what I'm enlarging, this is showing the cross section of spermatic cord. And here, my dear students, you can see the structures inside the spermatic cord, that is vas deferens, that is ductus deferens, that is testicular artery, cremaster artery, artery to vas deferens, pampniform plexus of veins. All these structures has been shown here, which is lying inside the transverse section of this, spermatic cord. So here you can see the internal spermatic fascia derived from transversalis fascia. Cremaster muscle and fascia derived from internal oblique and part of transverse abdomen, but mainly the internal oblique muscle only. And external spermatic fascia is derived from external oblique muscle, which has been shown to you. The same covering and the layers has been shown here also. External spermatic fascia continues with the, it is formed from external oblique muscle. Cremaster muscle is derived from internal oblique muscle. It is derived from internal oblique muscle. And internal spermatic fascia is derived from fascia transversalis. It is formed from fascia transversalis. Done? Now let's move on to the next one. That is question number 23. Let's move on to question number 23. This part of vertebral artery is related to which of the following structure? This part of vertebral artery is related to which of the following structure? So we have got here. So here we have got four options. Third part of vertebral artery is related to which of the following structure? We have got option A, B, C, and D. So if I talk about the third part of vertebral artery, is related to which structure? We have got foramen transverse cerium, we have got anterior arch, we have got superior articular fasciitis, we have got posterior arch of atlas. Okay. So when we are talking about, actually the vertebral artery has got a location, important location. If I talk about the third part of vertebral artery, it is located in suboccipital triangle, and that suboccipital triangle floor is formed by posterior arch of atlas, and definitely the third part of vertebral artery is related to posterior arch of atlas. So let me show you this. So as you can see here, okay, let me just take water. Okay, let me explain to you. So the triangular space which you are seeing, if I talk about the triangular space which you are seeing, it's the suboccipital triangle. Okay, so what you can see, this image is showing the floor of suboccipital triangle. So this image is showing the floor of suboccipital triangle, and the floor of suboccipital triangle is having posterior arch of C1 cervical vertebra, and also having posterior atlanto-occipital membrane. So the green color structure which you are seeing, two structures are forming the floor of suboccipital triangle, and one is the posterior atlanto-occipital membrane, and the other structure is posterior arch of C1 cervical vertebra. And the third part of vertebral artery is residing over this. This is forming the floor of suboccipital triangle. Now, I also want you to know about the boundaries and the content of suboccipital triangles. So, I will write it for you. Before that, I just want everybody to know this. So, here you can see this is the muscle. This three muscles which has been shown in this image is forming the boundary for this triangular area. So, just see this triangular area. So, when I am talking about this triangular area, we have got three muscles. So, here rectus capitis posterior major is forming supromedial boundary. We have got obliquus capitis inferior, which is forming inferior boundary of suboccipital triangle, and we have got obliquus capitis superior as the suprolateral boundary. I will write it for you, don't worry. And these are the three boundaries, and inside you can see the artery has been shown. You can see this is the artery which has been shown, and this is the vertebral artery third part, which is the content. And we have got the nerves. So we have got the nerves which is also forming the content, that is suboccipital nerve is there, which is residing. Suboccipital venous plexus is also residing inside. So I just want everybody to write it, then we can move on to the next question. So write down boundaries of suboccipital triangle. Boundaries of suboccipital triangle. Boundaries of suboccipital triangle. So if I talk about the boundaries of suboccipital triangle, we have got suprolateral boundary. So supralaterally it is bounded by obliquus capitis superior muscle. Obliquus capitis superior muscle. This is forming supralateral boundary. Supromedial boundary or medially it is bounded by rectus capitis posterior major muscle. Rectus capitis posterior major muscle. And if I talk about inferior boundary, inferiorly it is bounded by obliquus capitis inferior muscle. Obliquus capitis inferior muscle. Okay. Now it is important. So we have done with the boundaries of suboccipital triangle. We have done with the boundaries of suboccipital triangle. And what is next is to know the content. So if I talk about the content of suboccipital triangle is, it contains suboccipital nerve. It contains suboccipital nerve. It contains suboccipital venous plexus. And it contains third part of vertebral artery. Third part of vertebral artery. So the third part of vertebral artery is resting over the floor structures. And what is the floor structure formed? If I talk about that, the floor structure is formed by the posterior arch of C1 cervical vertebra and posterior atlanto-occipital membrane. So we have got D as the correct answer. So my dear students, let's move on to the next question. Question number 24. While exposing the kidney from behind, when we expose the kidney from behind, all of the following nerves are liable to injury except when we are exposing the kidney as seen from behind, the following nerves are liable to injury except. So we have got four nerves in this category. We have got lateral cutaneous nerve of thigh, we have got ilioinguinal nerve, we have got subcostal nerve, and we have got iliohypogastric nerve. So that means for solving this MCQ correct, you have to know the structures related on the posterior aspect. You have to definitely know the structures which is related on the posterior surface of the kidney. So four options are there. Okay. Lateral cutaneous nerve, ilioinguinal, subcostal nerve, and iliohypogastric nerve. Actually, for the correct answer, that is the lateral cutaneous nerve of thigh, which is not lying in the relation on the posterior surface of the kidney. So that is the right answer. Next, other than that, if I talk about ilioinguinal nerve, which we talk about subcostal nerves and the vessels, iliohypogastric nerve, all these structures are related in the posterior surface of the kidney. So I would like to show you an image for it. So if you will see this, I am showing you the right and the left kidney, as you can see. So this is a diagram which is showing the relations of posterior surface of kidney. So I am showing the relation of posterior surface of both the kidneys, right and the left. So this is left and this is right. So exactly only the difference of the posterior relation lies in the respective ribs. Why? Because the right kidney is lower than the left kidney, because we have got a liver on the right side. So we have got here, if you will see this, you can see this is the 12th rib. And this is the 11th and 12th rib. This is 11th and 12th rib. So you can see this is the 11th and this is the 12th rib. So if I talk about the relations on the posterior surface, we have got both 11th and 12th. But if I talk about the relations posteriorly, in terms of the left kidney, it is 11th and 12th rib, but in the right kidney, it is only the 12th rib. Now, three muscles are related. So I just want to use brown color for showing you the muscle relation. So we have got three muscles related. Medially, we have got the psoas major muscle. On the posterior surface, okay, this is the psoas major muscle. I just want to highlight it. Now, intermediate area, if we talk about intermediate area, it is related with the quadratus lumborum. It is related with quadratus lumborum. So you are seeing it. This is the quadratus lumborum muscle, QL. This is QL, quadratus lumborum muscle. And more laterally, if you will see more laterally, we have got transverse abdominis muscle. This is which muscle? This is transverse abdominis muscle. So this muscle I am highlighting, this is transverse abdominis muscle. So done with all the three muscles, superiorly there will be the diaphragm also related on both the side, corresponding diaphragm part of right and the left side. But what about the nerves and the vessels? So see the nerves and the vessels, subcostal nerves and the vessels, iliohypogastric and ilioinguinal nerves. So these are all the structures which is related on the posterior surface. Lateral cutaneous nerve of thigh, which compression causes meralgia paresthetica, is not involved in this case. So if you want, you can write it also. Write on the heading. You can write the heading posterior relation. Posterior relations of kidneys. So posterior relations of kidneys. So if I talk about posterior relations of kidney, we have got following relations. Posterior relation, ribs. So we have got ribs. So 11th and 12th rib is related in case of left kidney. So both 11th and 12th rib is related in relation to the posterior aspect of left kidney, and only 11th rib is related in the case of right kidney. Because right kidney is lying slightly lower than the left kidney. Now if I talk about the muscles, so the muscles related for is similar for both the right and the left kidney. The muscles are corresponding area of diaphragm is there. Then we have got psoas major muscle. Then we have got transverse abdominis. We have got quadratus lumborum and transverse abdominis muscle. Quadratus lumborum and we have got transverse abdominis muscle. Okay. Now we have done with this. Now coming to the nerves and the vessels. So in case of nerves and vessels, we have got subcostal nerves and vessels, and only nerves, that is iliohypogastric and ilioinguinal nerve. So we have got iliohypogastric and ilioinguinal nerve. Other than that, we have got iliohypogastric nerve and ilioinguinal nerves So all these structures which I have written is the relations of the posterior aspect of the kidney which has been done. Done? Now let's talk about next question, that is question number 25. Let me read it for you. Okay. Coming to this question, actually this is a very important question surgically also. Let's start with this question number 25. A 42-year-old male was having a complaint of severe pain in the lower abdominal region. The pain starts in the loin region, radiates down the groin region. Recently, he was diagnosed with ureteric stone. On the examination in the nephrology department, what do you think is the most liable site of stone to get impacted in the ureter? Got it? So we have question number 25. 42-year-old male having a complaint of severe pain in the lower abdominal region. The pain starts in the, so key factor is that we have to know the area of constriction of the ureter, which is generally involved in case of ureteric stones. So got it? So just a minute. Yeah. So we have to diagnose the case which is having ureteric stone impacted in this location. So the options given is the point of crossing of ureter by broad ligament of uterus, okay, while passing on the tip of transverse process of the vertebra, by enlargement of uterine artery, point of crossing of ureter by ductus deferens. So we can see 4 options are there and we have to mark the right answer. So exactly हमें ये ध्यान देना है कि site of construction commonly क्या होता है. Actually this becomes an easy question. Why? Because यहाँ पे gender बताया हुआ है, ये मेल पेशेंट है. सो डेफिनेटली नो डाउट कि यहाँ पे तो ब्रॉड लिगामेंट होगा ही नहीं, यूट्राइन आर्टरी होगा ही नहीं. नाउ द करेक्ट आंसर इज पॉइंट ऑफ क्रॉसिंग बाय डक्टस डिफरेंस और वास डिफरेंस. दैट इज वन ऑफ द साइट ऑफ कंस्ट्रक्शन. एक्चुअली I would like to show you an image where all the sites of constructions can be appreciated. So you can just see here. This is the ureter and here you can see, if I just enlarge this image, what you can appreciate here. यहाँ पे आप appreciate कर सकते हो कि ये pelvic ureteric junction है, that is the first site of constriction, that is the renal pelvis. Then we have got a second constriction at the level of pelvic brim where the bifurcation of common iliac artery takes place. The third is ureteric orifice when it enters the when it enters the urinary bladder. The fourth is by crossing of vas deferens in case of males and through the broad ligament in case of females. So already I have told you is यहाँ पे doubt ही नहीं है कि broad ligament right answer हो सकता है, क्योंकि the case is of the patient के बारे में जिसके बारे में हम बात कर रहे हैं, the patient which is here is the male patient, it's not the female one. So the right answer will be crossing of vas deferens or crossing by the ductus deferens. So here again you can see the important sites of constriction will be pelvic-ureteric junction, the pelvic brim, bifurcation of common iliac artery, uretrovesical junction, and also vas deferens crossing. Vas deferens crossing in case of males and in case of females broad ligament. So definitely after this discussion it's quite clear. The right answer will be point of crossing by vas deferens, which is an important area of getting constriction or ureteric stone formation. So yes, dear, so let's move on to the next question. That is question number 26. Let's start with the next one, question number 26. A 23-year student presents in the OPD. If I talk about 23-year students, so can we have a slightly stand and then we can take a session also? Is it okay? I am able to, okay, slide. Now, so let's talk about this question. So 26, so that is important. A 26-year student in the OPD is having a nasal discharge. So when the examination is done by the physician, he noticed a purulent discharge is coming from superior nasal meatus. A purulent discharge is coming from superior nasal meatus. Which of the following sinuses is most likely to be infected in this case? So 4 sinuses are mentioned. In this case, 4 sinuses are mentioned, as you can see. These are frontal sinus. These are maxillary sinus. So we have got 4 sinuses which is mentioned in this case. And we can clearly see the 4 sinuses which is mentioned here. Yeah. So if I talk about the 4 sinuses which is mentioned, frontal, maxillary, sphenoidal and ethmoidal. What is the key factor which has to be kept in mind? If I talk about the key factor which has to be kept in mind is the secretion is happening from superior nasal meatus. So this is a question not only of anatomy, it's an important question also for your ENT part. So यहाँ पे क्या landmark mentioned है already? The landmark which is mentioned is the drainage is occurring in the superior nasal meatus. So we have to know which of these sinuses are opening in superior nasal meatus. Actually, the correct answer will be posterior ethmoidal sinus. So we have got D as the right answer. That means we have got D as the right answer in this case. So definitely D is the right answer. Now I just want to show you this image. Can you see this image? When you are seeing this image, you can see the openings here. So you can clearly appreciate the openings here, and you will be able to understand the structures opening in the lateral wall of the nasal cavity. So what I want everybody, you have the, okay, coming to this. So as you can see here, we can see the lateral wall of the nose and we can see the sinuses and important sinuses opening here. So exactly, अगर हम इसकी बात करें तो we can just, okay, is it okay? Yeah. So we have to know about the sinuses. So here, just a quick revision of the sinuses opening here. So I just want to show you, I'm just enlarging it slightly. Okay. तो जब हम enlarge करते हैं तो सारे sinuses, we can see all the important sinuses. So what we can see here, the structure opening in the inferior meatus is the nasolacrimal duct, which is lying below the inferior turbinate, which is a separate bone in the lateral wall of the nose. Now the structure opening in the superior meatus, which was asked in the MCQ, and the correct answer is posterior ethmoidal air sinus. Structure opening in the middle meatus. So if I talk about the middle meatus, it is having an elevation that is called as bulla ethmoidalis. What is it called as? It is called as bulla ethmoidalis. And on the bulla ethmoidalis, we have got an opening of. So just see here, on the bulla ethmoidalis, we have got the opening of middle ethmoidal air sinuses. And below bulla ethmoidalis, if I talk about the area which is lying below bulla ethmoidalis, which is called as hiatus semilunaris, the structures opening in hiatus semilunaris, as you can see here, we have got from anterior to posterior frontal sinus, anterior ethmoidal sinus, and maxillary sinus. That means anterior ethmoidal that means frontal sinus, anterior ethmoidal sinus, and maxillary sinus are opening into the hiatus semilunaris. Now talking about the structures opening in the sphenoethmoidal recesses, which is lying above the superior meatus, the structure opening is sphenoidal air sinus. So this is a quick revision of all the paranasal sinuses openings in the lateral wall or the meatus of the lateral wall of the nose. So that is clear, my dear students. We have done with the question number 26. Let's move on to the next question. That is question number 27. So let's start with question number 27. Okay, question number 27. A 34-year-old female presents to the emergency room after falling in the bathroom. Okay, she complains of a wrist pain and numbness in her right palm. Based on her symptoms, you suspect that she has dislocated the lunate bone in the wrist. Okay, so identify the lunate bone in the X-ray. So you have to identify the lunate bone in this X-ray. So exactly, this is a clinical question in which you can see the history of that female patient has been given. She has fallen down in her bathroom. She is having wrist pain and she is also having lunate bone fracture or dislocation. Sorry, fracture नहीं है, dislocation है. तो आपको बताना है इस image में, which I will enlarge. Then you have to tell me what is A, B, C, and D. So I'm just enlarging it. So see here. Yeah, I'm enlarging this. As you can see here, I'm just enlarging this. So now you can tell me which is the lunate bone. So it's a very easy one. You have to just identify the lunate bone. So exactly ये radiological image में हमें ये तो पता चल रहा है. This is the radius bone, the lateral bone. This is the thumb. Okay. So this is the radius bone of the forearm and this is the ulna bone. Now that means from lateral to medial. If I talk about lateral to medial, there is a mnemonic. Carpal bones. So there is a mnemonic, that is carpal bones from lateral to medial. There is a mnemonic that for the proximal and distal row. So firstly, I would like to talk about proximal row. That is C looks too pretty. That is C looks too pretty. C looks too pretty. So here C looks too pretty. S for scaphoid, L for lunate, T for tricuteral, and P for pisiform. P for pisiform. Got it? C looks too pretty. Try to catch her. So here S for, so here lateral to medial, S for lunate, S for scaphoid, L for lunate, tricuteral and pisiform. And the other one is distal row के लिए बात करें, distal row के लिए try to catch her. Try to catch her. So here T for trapezium, another T for trapezoid, C for capitate, and H for hamate. Okay, got it? So we have got all the bones from lateral to medial in the proximal and distal row. Now coming to this image now. Now just focus on this image. So we have got two rows here that we already know. So this is the first row. So let's start with the first row now. So this is the proximal row. So here C is scaphoid, D is lunate, and this E is pisiform, and this is tricuteral. This is what? This is tricuteral. This is tricuteral. Got? This is P for the proximal row, and this is D for distal row. Now coming to the distal row, the most lateral one is trapezium. So we will have T for trapezium, and close to it, this will be the part of trapezoid. B for capitate, the largest, C for the capitate, largest carpal bone, and this is hook of hamate. H for hook of hamate. So got it. So we have got all the carpal bones in the distal and the proximal row. So the correct answer will be, we have got D as the lunate bone. So the correct answer will be D as the lunate bone. So is it okay? That is how you are going to identify the bone. So we have got D as the lunate bone. So we have got D as the lunate bone for question number 27. Okay. Now let's move on to the next. So I just want to give you a better view of the radiological image, and here exactly you can see, I am just enlarging this. You can see the radius bone, you can see the ulnar bone, and you can see the scaphoid, lunate, tricuterum, pisiform, trapezium, trapezoid, capitate, and the hamate. So this will give you an idea of identification of the proximal and distal row of carpal bone. The mnemonic is C looks too pretty, try to catch her. What is the mnemonic? So we know that the mnemonic is C looks too pretty, try to catch her, which will help you to understand the correct answer. Okay. Now, my dear students, let's move on to the next question. Question number 28. Question number 28. A 24-year-old mountain climber, so this is a clinical question, presents to the emergency room with a right shoulder pain following a fall. He was climbing a cliff at a nearby national park where he lost his grip and fell approximately 5 meters onto the boulders. कहाँ पे fell down हुआ? Boulders पे. He says that he landed on his right arm and heard a bone snap. Okay. Physical examination reveals total instability to extend the wrist. Extension of the wrist is gone. So that is a hint which is given. क्या injury हुआ है यहाँ पे? What was the injury which has happened here? The injury is that a bone snap is heard and the patient is having a total instability of extension of the right wrist. The X-ray reveals a fracture of right humeral shaft. So this is a case of shaft of humerus fracture. This is a case of shaft of humerus fracture. Humerus bone shaft is fractured, and you have to tell me which of the following structure is involved in this patient. The options are anterior circumflex humeral artery, brachial artery, common interosseous artery, and deep brachial artery. Question number 28. We have got following options. We have got anterior circumflex humeral artery, brachial artery, common interosseous artery, and deep brachial artery. So these are the four options which is giving us the hint to approach the right answer. So first thing to approach this as a right answer, I will tell you the loss of action which is seen in this case. The loss of action which is which is exactly seen in this case, is that the patient is not able to extend the wrist. The wrist drop hai. Extension of wrist is not possible, wrist drop hai. We know that extension of wrist is done by the function of radial nerve. Radial nerve is giving innervation to all the extensor group of muscle, और उसका action यहाँ पे involved है. That means extension action is going to, definitely the right answer here will be radial nerve being involved. The other hint which is provided to you is radial nerve is running along with which artery? Radial nerve will run along with the profunda brachii artery. And the other name of profunda brachii artery is a very important branch from the brachial artery, and it is also called as deep artery of arm. So profunda brachii artery along with radial artery, which is coming out through the lower triangular space, is related to the shaft of humerus. So the right answer is deep brachial artery. So now see here, if I talk about mid shaft of the humerus, it is associated with the injury of radial nerve along with the deep brachial artery. So अगर हम radial nerve की बात करें तो radial nerve is giving innervation to all extensor group of muscles of the forearm, all extensor muscles, and radial nerve is related to radial groove or spiral groove along with the deep branch or deep artery of arm, which is called as profunda brachii artery, which is a branch of brachial artery. So definitely you can see this image where you can see this is the area of radial groove where we have got radial nerve and the profunda brachii artery. So only in the patient we have got loss of extension movements of the forearm. Now anterior circumflex, let us rule out the other option. So यहाँ पे anterior circumflex humeral artery is not the right answer. Why? Because it is related to surgical neck of humerus. It anastomosis with the posterior circumflex humeral artery, which is related to surgical neck of humerus, not related to the spiral groove of humerus. So definitely, अगर surgical neck of humerus की injury होती है, if in the case we have got an injury of surgical neck of humerus, then only there will be injury of anterior circumflex humeral artery. Now, other than that, if I talk about common intraosseous artery, this is also the wrong answer, because we know that common intraosseous artery, if I talk about common intraosseous artery, we know that it is a branch of ulnar artery, and ulnar artery is a terminal branch of brachial artery. So common intraosseous artery is exactly here we have got the ulnar artery, and ulnar artery and radial artery is given below. Ulnar artery, if you will see this image, you can see ulnar artery and radial arteries are the two terminal branch of the brachial artery, which is given below elbow joint. It is given at the level of neck of radius. So below it only we have got the common intraosseous artery, because common intraosseous artery is a branch of ulnar artery. So definitely that is also wrong option. Brachial artery is of course the wrong answer. Why? I will tell you. Brachial artery is a very important artery for the arm, but it is related in the bicipital groove. Actually, if I talk about brachial artery, the more common reason where it is getting injured is supracondylar fracture. So exactly just above the condyles of the humerus. So what is this? This is the humerus condyle. So here we have got the medial and lateral condyles of the humerus. So just above this, brachial artery is more commonly injured, and it will lead to a complication that is called as Volkmann ischemic contracture. So supracondylar fracture is the reason of injury of brachial artery. Now, if I talk about the injury of radial collateral artery, that is definitely wrong. We know that radial collateral artery. In this diagram, you can see radial collateral artery is a branch of profunda brachii artery, which is given lower down. It is not injured at this location. So, important branches of brachial artery and important branches of profunda brachii or deep artery of arm has been shown. You can give a quick revision to it. So, definitely after this discussion, we are quite clear that the right answer in this case will be deep artery of arm, called as profunda brachii artery, related to radial nerve in the spiral groove, and that is the reason of loss of extension of the wrist. Now let's move on to question number 29. So this is again an image based question and a clinical question for you. Okay, let me read it for you. A 56-year-old man comes to the emergency department because of persistent left wrist pain while walking his dog 5 hours ago, fell forward to the ground and landed on outstretched left hand. Examination shows mild swelling over the dorsum of left hand with preserved range of motion. There is point of tenderness present over the anatomical snuff box. Okay. An X-ray of his left wrist is shown below. The patient is at greatest risk of developing which of the following complications? Which of the following complications? So exactly The key point which has to be pay attention to this is we have got point of tenderness over anatomical snuff box. The patient is having point of tenderness over anatomical snuff box. Okay. And we know that in anatomical snuff box, floor is formed by scaphoid bone. So what will happen in this clinical scenario? अगर यहाँ पे injury होती है तो greatest risk patient में क्या देखने को मिलेगा? What we will see in the patient, the greater risk of injury will be scaphoid bone. So in short, जब भी हम एनाटॉमिकल स्नफ बॉक्स की टेंडरनेस की बात करते हैं, पेन की बात करते हैं आफ्टर एन इंजुरी और फ्रैक्चर इन दिस केस दैट इज द स्केफॉइड बोन फ्रैक्चर, द कॉम्प्लिकेशन व्हिच इज सीन इज avascular necrosis. So exactly this is the image which I am showing you. So exactly this is the image which is provided in this clinical question, and let me just highlight it. So I just want to highlight this. Again, you are knowing this is the radius bone and this is the ulnar bone. This is the ulnar bone and this is the radius bone. So by seeing this, you get an idea of this is the lateral side and you get an idea of this is the medial side of the four bones. So that means this will be the scaphoid bone. This is S for scaphoid bone. This is L for lunate bone. This is the tricuteral, and over this is the pisiform bone. Okay. This is again the trapezium and trapezoid. This is again trapezium and trapezoid and trapezium. This is the C for capitate, and this is the hook off, and this is the hamate bone. So what you can get, you can see the crack. You can see the crack which is seen in this case. The crack which is appreciated in this case, or the injury is scaphoid bone fracture. So definitely this is a case of fracture of scaphoid bone, and scaphoid bone is a very particular bone. Why? In terms of blood supply. Why? I will tell you. The reason is that it is receiving its blood supply from dorsal aspect. So if you will see, the dorsal scaphoid branch of radial artery is supplying most of the scaphoid bone, and it is entering from the distal pole of the bone. That means if there is an injury or fracture, the blood supply to the proximal bone, which is traversing in retrograde manner, the fracture will lead to will lead to the reduced blood supply or nutrition to the bone, and ultimately if quick measures are not taken for the treatment of this case, it will lead to avascular necrosis and non-union of scaphoid bone. So I just want to show you this scaphoid bone, avascular scaphoid necrosis. So you can see this is the radial artery which is giving dorsal scaphoid bone. This is the scaphoid bone fracture, and you can see the blood supply is affected in case of scaphoid fracture, which is coming through the distal pole, and this will lead to non-union or avascular necrosis in long-lasting cases because the blood supply is coming from dorsal aspect. So the most common complication which will be seen in this condition is avascular necrosis of the scaphoid bone. Now, I would also like to rule out the other option. So let's come with that. Carpal tunnel syndrome is not the right answer. Just before this, I have described one of the MCQ, and I told you carpal tunnel is the space lying below flexor retinaculum. And we know the nerve which is passing through the carpal tunnel is the median nerve. So medial nerve is compressed, and medial nerve is compressed in the case of diabetes mellitus, hypothyroidism, rheumatoid arthritis, which is not this condition. So this is the wrong option. One of the another condition which is there is the compartment syndrome, which occurs when there is excessive pressure build up. So compartment syndrome is the condition जहाँ पे excessive pressure build up होता है closed space में. Compartment syndrome में generally एक history होती है bleeding और swelling की, और fracture of leg or forearm bones is definitely seen in this case. So definitely this is also not the right answer. One more option which was given was Dupuytren contracture. Dupuytren contracture is also not the right answer because it is a slowly progressive fibroproliferative disorder which is seen in the case of palmar fascia. So mainly in this case, palmar fascia is involved and not related with scaphoid bone fracture. So this is also not the condition or the right answer. Osteomyelitis is commonly resulting from either hematogenous seeding of the bone, which happens due to bacteria or the infection done by the bacteria involved. Unexposed part of the bone can develop osteomyelitis, and this most common organism which is involved in this case of osteomyelitis is by hematogenous spread is the Staphylococcus aureus, that is a bacterial infection. Such kind of history was again not provided, so definitely we will not mark this as the right answer. The correct answer is fracture of scaphoid bone in the in the anatomical snuff box flowed, leading to avascular necrosis of the bone. Now let's solve one of the clinical question here. Which of the following option is correctly labeled in this image? So actually in this image, I will like to show you the skull coverings and the meningeal coverings. So firstly, you have to identify that coverings and then we can approach to the right answer. So see here, I have enlarged this image and you have to identify the layers of the scalp and the meningeal covering, which is 1, 2, 3 and 4. So here one is, so the hint which is, why you are going to identify one? How? The hint is that ये scalp के layer है और जबकि हम scalp के layers की बात करते हैं, that is CALP. S for so S for the skin, A for so we have got CALP. So CALP. S for skin, C for connective tissue, A for aponeurosis of occipitofrontalis belly, L for loose connective tissue, and P for pericranium. So here one stands for, as you can see, this is the muscle which is seen. This is the muscle belly. So this is giving us the hint that this will be the aponeurotic layer. This will be the aponeurotic layer of occipitofrontalis belly. So what will be this? This will be the aponeurotic layer of occipitofrontalis muscle belly, and 2 will be the pericranium, the part of the bone. This will be the pericranium or perosteum covering. Then 3 will be the dura mater, and 4 will be the arachnoid mater. 4 will be the arachnoid mater. So we have got the identification of the 4 layers in this image. Now we will come up with a correct explanation. So coming to this, epicranial aponeurosis is the first. Yes. Cranium is second, yes. Dura mater is 3 and 4 is the arachnoid mater. So definitely we have got first as the right option. So I just want to show you this image once again so that you have the identification of all the layers. So in this image you can see anterior and posterior part. So we have got the scalp layer, we have got the epicranial aponeurosis. The hint is that why it is aponeurotic layer, because it is showing the muscle belly. This is the, आगे में कौन से muscle belly होगी? Frontal muscle belly होगी और posteriorly क्या होगा? Occipital muscle belly होगा. This is the loose connective tissue which was not asked. This is the cranium of the skull. This is the dura mater which is tough and adherent. This is the A for arachnoid matter. This is the arachnoid matter which has been asked in the MCQ, and the subarachnoid space, and lastly over the cerebral hemisphere. So over the brain surface or the cerebral hemisphere, the adherent cerebral cortex is covered by which layer? So it is covered by pia mater. Which layer? It is covered by the pia mater, which is very difficult. If I talk about the pia mater, it is very difficult to be removed from the brain surface. So the innermost layer will be that of the pia mater. Okay, dear. So this is how we are going to identify all these layers of the scalp. So I want everybody to go through this image and be able to identify all the layers covering which is forming the scalp and also the meningeal layer. If I talk about the meningeals of the brain from outside to inside, it is dura mater, it is arachnoid mater, and it is the pia mater. Arachnoid and pia is together called as leptomeninges, a previous year question of FMGE examination. So done with this. So my dear students, so we have started this session 3 hours back. So I think we should have a break now. Is it okay? So what I will do, I will write break. I will write a session of break. I will take a break of 15 minutes and then again I will start with the session, because today we have to cover 100 MCQs that and 100 topics, important topics. So that is a session of 1 day. So I will take a break right now, and we will so all of you be attentive in the session, be live so that you can understand better the session. So I will just write it for you that now the break is going on. If you want, I will just write it for you. Wait a minute. Yeah, I'm coming to the first slide where I will write the break. Okay. Yeah. So here I will just write now break. Break of 15 minutes. So I just given a break of 15 minutes. Is it okay? Then we will resume it. Okay. So just a break of 15 minutes. Thank you. So hello everyone, am I audible? So we are, I'm back with this session, and let's start with the MCQs. So till now we have discussed 30 MCQs, and today's target is to discuss 100 MCQs with 100 topics. So that is the target, that is 100 MCQs discuss करेंगे और number लाएंगे more than 150. Okay, so let's start. So I would like to just drag that. So till now we have discussed all these things. Now I would like to come up with the So I hope everything is fine. I am audible. The screen is clear. So we will come up with the next question. That is question number 31. So let's start. So this is again an image-based question. So this is the question number 31. So let's start. Okay. So when I'm talking about question number 31, okay, let me just, yeah. So exactly अभी हम question number 31 की बात करेंगे. So let me read it for you. It is again an image-based question. I was just checking as everything is all right or not. So all of the following statement is correct regarding the marked structure in the image. That means firstly, I would like to enlarge this image. So when I enlarge this image, you get an idea of all these cadaveric images and the structures lying inside. So I just want to enlarge it. So when I have enlarged this, as you can see here, so you can see a red color arrow is marked on one of the structures. So you have to identify that red color arrow marks. So can you see this green color triangular area? So this green color triangular area is the femoral triangle. What is it? This is femoral triangle. This area is femoral triangle. Okay. So this area is femoral triangle. And if I talk about its boundaries, so you can see here, this is the base which is formed by inguinal ligament. We have got adductor longus muscle and the sartorius muscle as the boundary. So that is okay. So we are now having an idea that हमने करेक्टली ये तो जान ही लिया है कि ये femoral triangle है. अभी हमें ये arrow mark structure को identify करना है. So this arrow mark structure is the most lateral structures along this femoral vessels, and also if you will see this, if I enlarge it, I just like to shade it with different color. So this will be the nerve with yellow color. This will be the artery with the red color. And then we will have the blue colors for the vein. So this is vein. So exactly here, that means this structure is femoral vein. This structure is femoral artery. And the arrow structure is the femoral nerve. Now, the boundaries. If I talk about the boundaries, so we have got adductor longus muscle. The pectineus muscle is lying here. Then we have got I for iliacus, and behind this there will be psoas tendon. And this muscle which you are seeing is the S for sartorius. So a sartorius and adductor longus is forming medial and lateral boundary for this triangular reason. Okay, for this triangular reason. So exactly, abhi hame boundaries janna. So if I talk about the boundaries here, so all of the following is the correct statement regarding the marked structure in the image. So 4 options are there. So now we are very much clear that the structure which has been identified here and with the black arrow, what is that structure? So that structure is quite clear to you, that structure is the, so that is quite clear to you that structure is the femoral nerve. Now we have to know the A option is root value of femoral nerve will be L2, L3 and L4. So that is absolutely correct. Okay. Now supplies the muscles of anterior compartment of thigh. So that is also known to us, and we know that all the muscles of anterior compartment of thigh is innervated by the nerve of anterior compartment of thigh, that is femoral nerve. Give saphenous nerve as a branch from anterior division. That is wrong, and the correct answer, because saphenous nerve is a branch of femoral nerve which is given from posterior division, not anterior division. Gives innervation to pectineus muscle is also correct. Femoral nerve trunk gives innervation to pectineus muscle. So that is also correct. So let's come up with the femoral nerve. So here, if you see the femoral nerve, you can see femoral nerve root value is L2, L3 and L4. It is formed from the dorsal division, ventral rami of L2, L3 and L4. Okay. Now here again you can see here the branches which is given from the trunk. So it is giving innervation to iliacus, and also it gives from the trunk only, it gives innervation to pectineus muscle. Now below the inguinal ligament, so here I want to mark a landmark here. This is the inguinal ligament. Below the inguinal ligament, the femoral nerve is dividing into anterior and posterior division. So iske beneath it is dividing into anterior and posterior. Anterior division will give innervation to sartorius muscle and two cutaneous nerve, medial cutaneous nerve of thigh and the intermediate femoral cutaneous nerve. And the posterior division will give innervation to quadriceps femoris muscle and also will give innervation by saphenous nerve, which is a cutaneous branch, which is a branch from the posterior division. So that was the wrong statement. So let's write that branches. So all of you can just write down branches of femoral nerve. Branches of femoral nerve. Branches of femoral nerve. So if I talk about branches of femoral nerve, here we will talk about the branches. So branch from the trunk. So from the trunk, it gives innervation to iliacus muscle and it gives innervation to pectineus muscle. From anterior division, the femoral nerve is giving innervation to just one muscle, that is sartorius muscle, and it gives two cutaneous branch. It gives two cutaneous branch. The name is medial cutaneous nerve thigh and that of intermediate cutaneous nerve. Now let's talk about the branches of, so we have talked about this. Now branches from the anterior. So we have done with the branches of anterior division. What is next is to know the branches from posterior division. So if I talk about branches from posterior division, the branches are, it is giving innervation to quadriceps femoris muscle. It is giving innervation to quadriceps femoris muscle. It is giving innervation to quadriceps femoris muscle. And if I talk about quadriceps femoris muscle, so अगर हम quadriceps femoris muscle की बात करेंगे, so let me just so, okay, if I talk about posterior division, so if I talk about the posterior division branches are, if I talk about the posterior division branches, so the posterior division branches are giving innervation to quadriceps femoris muscle. And when I talk about quadriceps femoris muscle, I mean to tell four muscles in this category. We have got vastus medialis, vastus lateralis, vastus intermedius, and one cutaneous nerve, that is saphenous nerve. So that means in this question, we have got saphenous nerve is a branch from the femoral nerve, which is not from anterior division, but it is a branch from posterior division. It's a branch from posterior division. So the right answer is this for the question number 31. Okay. Okay, everyone. Now let's move on to question number 32. Let's move on to the question number 32. Now coming to the question number 32, let me read it for you. Identify the marked structure in the image. You have to identify this marked structure in the image. So actually this image is showing you the medial sagittal section of the brain. So I would like to just enlarge this image. So when I'm enlarging this image, as you can see here, so when I enlarge this image, what you can see, this is the medial sagittal section of the brain. And in the medial sagittal section of the brain, what you can appreciate, we have got the red color arrow is there, and the red color arrow is over which of the foramen. So the key point here you can see, this is the part of, this is corpus callosum. What is this? This is corpus callosum. Here, this area which you are seeing will be the part of LV. What is LV? Lateral ventricle. So if we talk about this area, this is exactly LV, means lateral ventricle. And this arrow marked area is interventricular foramen of Monro. This is interventricular. This is interventricular foramen of Monro. This is interventricular foramen of Monro, which is forming a communication. So that is forming a communication between lateral ventricle and that of third ventricle. Third ventricle is forming communication with that of fourth ventricle via cerebral aqueduct of Sylvius. So exactly the marked structure in this image will be interventricular foramen of Monro. So what is that? That is interventricular foramen of Monro, which is forming the communication between that of the lateral ventricle and that of third ventricle. So I would like to show you an image once more. So if you will see this image, I am enlarging this image. So you can see this is the lateral ventricle, and the lateral ventricle will form a communication via foramen of Monro, interventricular foramen of Monro, with that of third ventricle. With that of third ventricle. Third ventricle will form communication with that of fourth ventricle. So what is it? This is the fourth ventricle, and this communication occurs via aqueduct of Sylvius. Aqueduct of Sylvius. So this is how ventricles of the brain is communicating. This is how the ventricles of the brain is communicating. Now one more cadaveric image is there. So once more, when you see the cadaveric image, you can just appreciate the corpus callosum, and below the corpus callosum we have got the cavity here. So below the corpus callosum, this space which you are seeing is the lateral ventricular, covered by septum pellucidum, and below it we have got interventricular foramen. This is the septum pellucidum, which is covering the lateral ventricle space. So this area is lateral ventricle covered by septum pellucidum. This is thalamus T, this is H for hypothalamus, and in relation to diencephalon, thalamus and hypothalamus, we have got third ventricle. The communication of lateral ventricle and third ventricle happens via interventricular foramen of Monro, and this third ventricle will communicate with the fourth ventricle via cerebral aqueduct. So done with this. Now let's move on to question number 33. All of the following structures passes from the marked structure in the image. So this is again an image based question in which you have to identify the yellow color opening of the diaphragm. So you have to identify the yellow color opening of the diaphragm, and then you can come up with the right answer. So four options are there: esophagus, anterior posterior vagal trunk, esophageal branch of left gastric artery, and superior epigastric vessel. So again, I would like, with the enlargement of this, I am just enlarging this cadaveric image. So when I enlarge this cadaveric image, you can see the diaphragm has been pulled up. And from the inferior aspect, you can see the openings of the diaphragm, and you have to identify the yellow color marked opening of the diaphragm. So if I talk about this yellow color marked opening of the diaphragm, this is the esophageal opening. This is esophageal opening of the diaphragm, which is at the level of T10 thoracic vertebra. T10 thoracic vertebra पे है, और ये जो opening दिख रही है, this is at the level of aortic opening of diaphragm. This is aortic opening of the diaphragm, and aortic opening of diaphragm is at the level of T12, and this opening which you are seeing is the vena cava opening of the diaphragm. Vena cava opening of the diaphragm, and vena cava opening of the diaphragm is at the level of T8. So that means we have seen three openings of the diaphragm, and we are correctly seeing the level of these openings. So we have identified about the openings which has been told. Now we have to know the structures which is passing through this opening. So yellow color opening is esophageal opening of the diaphragm, and we know the structures passing through the esophageal opening of the diaphragm is what? So that opening is the esophagus. So we have got the right answer here. So again, here the question is asking about all the structures passing through this opening except. So esophagus is passing through it. Anterior, posterior, vagal trunk is passing. Esophageal branch of left gastric artery is also passing through esophageal opening. What not passes through is the superior epigastric vessel. So the odd man out and the right answer is superior epigastric vessel. So just correlating this image with the diagram here, which is a schematic diagram showing you the central tendon, showing you the vena cava opening, showing you the esophageal hiatus and the aortic opening. So that is absolutely important for you, and it is important that you should know about these openings, where it is located and the structures traversing. Now, other than that, I just want to enlarge this image. Why? Because you have already, I have explained in one more MCQ about the important structures opening, but I just want to enlarge it so that you can appreciate the hiatus. So esophageal hiatus is there, and the structure passing through esophageal hiatus is the vagal trunk, esophageal branch of left gastric artery, and the esophagus, which has been marked. The foramen of Morgagni is the space which is lying on the anterior aspect, and the foramen of Morgagni is lying on the anterior aspect in between the sternal origin and the seventh costal cartilage origin, slip of the diaphragm, and through it passes superior epigastric vessels. Caval hiatus, the inferior vena cava and right phrenic nerve passes. Aortic hiatus, the aorta, the thoracic duct and azygous vein, and minor apertures are for the greater, lesser and least splanchnic nerve. So definitely, if we talk about the superior epigastric vessel, it is passing through foramen of Morgagni, which lies anteromedially between the slip of origin of sternum. So that is the sternal slip and the costal slip. So seventh costal slip origin. So between the seventh costal slip origin and the sternum slip origin, we have got the superior epigastric vessel traversing through it. Okay. So that is the correct answer in the odd man out, which is not passing through the esophageal opening of the diaphragm. So after that, let's move on to the next question. So question number 34. So let's move on to the question number 34. So let me read the MCQ for you. All of the following statements are true regarding the arrow mark structure marked in the image. So that means in this cadaveric image, again, you have to identify the arrow mark structure, not the green highlighted area. Not the green highlighted area, but you have to mark the arrow mark structure, and then you have to come up with the right answer. So the options are, so we will come to the option reading, but before that, I want you to, I will enlarge this image so that you have an idea of this area. So let me just enlarge this. Okay, so I have just enlarged this image. When I am enlarging this image, what you can see, the green color area is the flux cerebri. What is that? That is the flux cerebri. Now we know that flux cerebri is a dural fold. It's a dural fold or dural septa, which is lying between the two cerebral hemisphere in the longitudinal groove. And here we can see it is sickle shaped. So very nicely you can appreciate it is sickle shaped, no doubt about this. And we have to now see which are the incorrect statement about the arrow mark structure. So we are now knowing the green area, but the question has been asked about the arrow marked area. So I just like to highlight this arrow marked area. So this is the arrow marked area. So that means the question is being asked with this area. So this area I will use another color so that you are not confused. So can you see I have highlighted with red color this dural fold, and what is this dural fold which has been asked? It is a tent-like dural fold which is separating the upper and the lower part. So exactly the tent-like dural fold which we are talking, it is lying between, it is separating the cranial cavity into supratentorial compartment and infratentorial compartment. What it? Into supratentorial and infratentorial compartment. So if I talk about This structure, this is tentorium cerebelli. This is tentorium cerebelli. That means the question is asked about tentorium cerebelli. यानी ये इस एमसीक्यू में और इस कैडवरिक इमेज में जो भी एमसीक्यू फ्रेम किया गया है उसमें हमारे पास जो क्वेश्चन अराइज है, इट इज अबाउट द टेंटोरियम सेरिबेली. इट इज अबाउट टेंटोरियम सेरिबेली. So let me just come up with this question. So exactly the option is its anterior border is free and concave. Okay, it encloses the transverse sinus, it encloses the sigmoid sinus. It is an extension of dura mater that separates the cerebellum from the anterior portion of occipital lobes. Okay, so exactly अगर हम बात करें टेंटोरियम सेरिबेली की, तो टेंटोरियम सेरिबेली is separating, it is a partition between supra and infratentorial compartment, and it is protecting the cerebellum not to be crushed by the occipital lobe of cerebral hemisphere. So exactly it is not enclosing sigmoid sinus. So this is the wrong statement. Other option, it is enclosing transverse sinus, is correct. Its anterior margin is free and concave is also correct. Well, that will form tentorial notch through which midbrain will pass, connecting forebrain and hindbrain. It is an extension of dura mater which is separating cerebellum from occipital lobe is also correct. So for proper understanding, I just want to show you few images. So exactly जो question पूछा गया था वो tentorium cerebelli से था. So you can appreciate this. This is the tentorium cerebelli. So this is exactly the tentorium cerebelli. And superiorly we have got, if we talk about the superior aspect, superiorly, as I told you, we have got the flux cerebri. Okay, so this is flux cerebri, and flux cerebri is resting over tentorium cerebri. Now you can see this is the anterior margin. This is the anterior aspect which is concave and free, and the posterior aspect is the attached border of tentorium cerebelli. Now, so this is clear that these are the correct statement about it. Now the next important is the sinuses enclosed by it. So now I want you to show another image where you can see the superior view of tentorium cerebelli. So this whole structure which you are seeing, so I am shading the tentorium cerebelli of one side. So this whole structure which you are seeing is the tentorium cerebelli. This is tentorium cerebelli of one side. This is tentorium cerebelli of other side. So above it, the occipital lobe of cerebral hemisphere reside. And here itself, you have to pay attention to the, so you can see sinuses. Here one sinus is enclosed and this is the other sinus which is enclosed in the tentorium cerebelli. So here, the sinus which is enclosed here is superior petrosal sinus. And here on the attached border is the TS. TS means transverse sinus, and you can see anterior margin is, anteriorly it is concave margin which is free, and posteriorly is the attached margin. So that means it is clearly seen that it is not enclosing sigmoid sinus. The sinus is enclosed by tentorium cerebelli. If you want, you can write it also. Tentorium cerebelli encloses two dural venous sinuses. It is enclosing two dural venous sinuses. And what are these sinuses enclosed? There are two sinuses which is transverse sinus. One is the transverse sinus which is enclosed, and the other is superior petrosal sinus. Other is superior petrosal sinus. So we have got superior petrosal sinus which is enclosed by it, and transverse sinus, not the sigmoid sinus. So that is the wrong answer. Now let's move on to the next. That is question number 35. The following image shows the blood supply of which part of the gut? The following image shows us the blood supply of which part of the gut. So exactly you have to identify this image. This is a schematic diagram which is showing. You just pay your attention and identify this image. Okay. Whether it is a part of which loop of intestine or other part or whichever, so there are options which will help you to come to the right answer. So आपको identify करना है ये जो भी loop है, or the arterial arcades and vasa recta as seen. So here I just want to show the correct identification point lies here. So you can see here, wait a minute. So here you can see this is the arterial arcades. So this is just one or two arterial arcades are there, and these straight arteries are called as vasa recta. So exactly in this schematic diagram, or this is an intestinal loop, and this is a loop of ileum. Why it is a loop of ileum? Because this is PW. What is PW? PW means peritoneal window. What do you mean by PW? PW means peritoneal window. PW means peritoneal window, and peritoneal window is the space which is lying between the vasa recta arteries. Arterial arcades are just one or two rows, and this is long. Vasa recta is long, and the space between the vasa rectas are peritoneal, which is semi-translucent. So the image which you are seeing is of ileum. So here the right answer will be of sorry. Okay, this is of jejunum. So sorry, I have written wrong. This is jejunum. My dear students, please mark a correction. So it was just a slip of tongue. It is jejunum loop. If I talk about ileum, ileum is having 5 or 6 arterial arcades. It is not having peritoneal window. This is jejunum, which is having the peritoneal window. The space which is lying between the vasa recta is the jejunum loop, and we have got the jejunum which is having semi-translucent peritoneal window. Ileum में semi-translucent peritoneal window नहीं होता है, लेकिन jejunum में peritoneal window is present and it is seen. Okay. So the right answer is jejunum. Now I just want you to show the two loops. So you can see long vasa rectas and arterial arcade just 1 and 2 is the jejunum loop. Actually, when you see the interior of jejunum loop, and if the surgeon is going for any surgery, and how he or she is identifying that loop can be done by seeing that loop, and interiorly you can see the vasa recta. Long vasa recta, 1 or 2 arterial arcades are there. That is the characteristic feature of jejunum. If I talk about ileum, there is 3 to 5 arterial arcades are there, and there is no peritoneal window and it is opaque. So that is ileum loop. So this is how you can differentiate the loop of jejunum and ileum. Now there are basically, again you can see jejunum loop having long vasa recta, translucent area. Vasa rectas are closely arranged in case of ileum, and arterial arcades are 5 or 6, but arterial arcades are just 1 or 2 in this condition of jejunum. Now, other important features and differentiating features of both of these will be just told to you. Don't worry. So, अगर हम interior देखते हैं तो Pierce patches. What is Pierce patches? If you will see the Pierce patches, this is the lymphatic aggregation. This is lymphatic aggregation. This is called as lymphatic aggregation. So, if I talk about Pierce patches, which is having lymphatic aggregation, this is a key feature for identification of ileum. So अगर distal part of ileum की बात करें, more distally if you go in the ileum, the concentration of Pierce patches increases, and if you go more proximally, the Pierce patches is not there. Jejunum is not having Pierce patches, but Pierce patches is present in ileum. In ileum also more distally the Pierce patches is present. 4 or 5 rows of arterial arcades in case of ileum, 1 or 2 arterial arcades in jejunum. In the interior of jejunum, the mucous fold, that is valve of Kerckering, will be present. Peritoneal window is transparent. Peritoneal window is opaque in case of ileum. Now, so that is the reason of difference. Now, also stomach is not the right answer. Exactly, duodenum and stomach, because duodenum and stomach we can see it will be lying in continuity with the stomach. So I just want to go to the other option. So basically जो हमारा doubt था वो jejunum ileum में ही था. Duodenum is not the right answer. Duodenum is not having such arrangement of the vessels which has been shown. This loop which has been shown is the loop of jejunum, and jejunum will have the following differentiating features of from the ileum. So अगर histologically बात करें तो jejunum is not having Pierce patches. It is having all the layers of GI tract, that is mucosa, that is the submucosa muscularis externa and serosa. If I talk about ileum, the characteristic feature of identification is fierce patches lymphatic aggregation in the lamina propria of mucosa which can extend into submucosa. Duodenum में characteristic feature और histologically हम बोले तो it is having venous gland in the submucosal layer. But अगर surgeons operate करता है तो उस वक्त that time he or she has to identify that loop. That can be done by seeing the loop, arterial arcade, semilucent transparency of peritoneal window and vasa recta, which is prominent in jejunum, having only one or two arterial arcades. Peritoneal window is transparent. I think after this explanation, it must be clear to you, and no question from these topic will be not solved by you. Okay, so let's move on to the next question. That is question number 36. Coming to the question number 36. A 14-year-old boy comes to an emergency department. Her father told that during the football game, he had met an injury, and after that, he was complaining of severe pain on the posterior abdominal wall of right side, mainly in the hypochondriac and the lumbar region. On examination, the doctor found tenderness in the area below 12th rib and pain increases during pressing this area. So what is the diagnosis of this area? So the key features which is mentioned here, if I talk about the key feature which is mentioned here, so what you can see about this key features, just to highlight the key features. The pain is on the right side. Okay, the pain is on the right side in the hypochondriac lumbar region. So the pain is in the hypochondriac and lumbar region, and basically the tenderness is found below the 12th rib and increases in this region. So exactly in relation to the right side 12th rib, we have got an area which is called as renal angle. So it is quite clear the correct answer will be renal angle. Now to differentiate whether it is on the left side or right side, the correct answer will be injury to the right kidney. Why? Because it is telling about the right side. Why? Because right side has been mentioned, and 12th rib ke below or in between erector spinae we have got a renal angle. So as you can see this image, you can see here, this is the 12th rib, this is the erector spinae muscle, and this is the renal angle. So in between the 12th rib and that of erector spinae muscle, we have got the renal angle. So in this case, if we have to go with the one correct answer, the correct answer is renal angle, right side. Left side is not the right answer because left side pain nahi tha. Spleen is also not the right answer. It is more on the left side. Also pancreas will be more towards the left hand side. So exactly, if I talk about spleen, it is mainly in the left region. Pancreas is also an elongated structure. Its tail is extending into the hilum of spleen. So definitely these are also not the right answer. So if I have to choose the one right answer, definitely I will go with the injury to the right kidney as the right answer. So done with this, let's move on to the next question. That is question number 37. Okay, question number 37. A developmental neurobiologist surgically removes the neural crest in the thoracic region of the chicken embryo immediately after the closure of neural tube. Okay. So which of the following cell type is most likely to be affected in this condition? The options are cardiac muscle cells, autonomic ganglia in the thoracic cavity, epithelial cells lining the lower respiratory tract, bone cells in the ribs. Okay, so my dear aspirants, actually, if we have to go with the right answer, I just want to tell that the neural crest cells is already mentioned. The key point is neural crest cells in the thoracic region has been mentioned. So जब neural tube का closure होता है, neural crest cells migrate from this region and can lead to, and it can lead to the origin to give rise to many of the structures. List of structures which are derived from neural crest cells is very important embryological question, and all of you must know this. Okay, so the option provided is cardiac muscle, bones and epithelial lining of lower respiratory tract are not derived from neural crest cells. So definitely the correct answer will be autonomic ganglia in the thoracic cavity. The correct answer is autonomic ganglia in the thoracic cavity. So what you can see here, this is the neural plate having depression as the neural groove. The neural fold, so the neural plate is depressed in the middle and the neural groove will come together in the midline so that neural tube is formed, and further down, when the further growth happens, neural tube is a cylindrical tube which leads to the formation of central nervous system part. In this condition, the cells migrate, and this migrating cells are neural crest cells. So it's very important for your upcoming exam of FMG examination that आपको neural crest cells के derivatives पता होना चाहिए. So it's very important. So we have to know about the neural crest cells derivative. So I just want everybody to go through this neural crest cells derivative mnemonic. The mnemonic is composed. So, and the structures derived here. C is for chromaffin tissues, adrenal medulla, arachnoid matter, melanocytes of the skin, also the pia matter. O for odontoblast, S for squamous cell, sympathetic neuroganglia. So all that ganglia cell, dorsal root ganglia, spinal dorsal root ganglia, ganglions of 5, 7, 8, 9, 10, 11, 9, 10 cranial nerve, dental, papilla, and dorsal spinal root. So exactly all these structures which has been shown in this box. So these all structures are actually the neural crest derivatives. All these structures are neural crest derivatives. So it's very important that you should know all the derivatives of neural crest will be asked so many times in your upcoming exam. So that is highly important for you. That is highly important for you. Okay, dear? Okay. So all other structures are not derived from the neural crest. So they are the wrong option. They are not derived. So they are not the right answers. Now coming to the next question, question number 38. So it is again an image-based question. Which of the following is not supplying the marked area in the heart? So the options are right coronary artery, anterior interventricular artery, marginal artery, and diagonal artery. Okay. So we have got 4 options and we have to identify the structures not marked, not marked in this area. That means firstly you have to identify the arrow marked structure. Then you have to identify which part of the heart is this, and then you have to which part of the heart is this or chamber of the heart is this, and which is not receiving blood supply from which of the following sources. So I just want to enlarge this image. So when I am enlarging this image, you can see this is the specimen of the heart, cadaveric specimen of the heart. So this part you can see, this is a superior vena cava part which has been shown. So this is giving us the most important hint that this is the right atrium chamber. We know that superior vena cava is opening into the right atrial chamber. So this is the right atrial chamber. This is the right ventricle. And this part which you are seeing is the left ventricle. This part is the left ventricle. Now it is quite clear that the arrow is over the right ventricle. Then it is quite clear the arrow is over right ventricle. Now we have to mark the right answer, that which of the following arteries which is mentioned in the MCQ is not giving arterial supply to right ventricle. That the right ventricular chamber of the heart. That has been asked. So let's see here. So if I talk about 4 options which has been given here, the options are right coronary artery, anterior interventricular artery, marginal artery, and diagonal arteries have been mentioned. So here the correct answer in this question will be diagonal artery. The diagonal artery. Why I will tell. Actually, diagonal artery is a branch of left coronary artery and it is giving only arterial supply to left ventricle. It is not giving arterial supply to right ventricle. So you have to note down. Diagonal artery is branch of left coronary artery. It's a branch of left coronary artery and it is giving arterial supply only to left ventricle, not to the right ventricular area. Right ventricular area. So I just want you to show this another image where you can have the idea of the arteries, coronary arteries. So if I slightly enlarge this. Okay. So what you can see here, that this is the left ventricular chamber, this is the right ventricular chamber, this is the right atrium chamber, and here you can see actually the coronary arteries overlap for example, one of the most important artery is posterior descending artery. Posterior descending artery, what is the other name of posterior descending artery? The other name of posterior descending artery is posterior interventricular artery. And posterior interventricular artery is an important source of arterial supply for the major part of the heart. So it is called as the artery of dominance. And in most of the cases, in 90% of the cases, posterior interventricular artery is a branch of right coronary artery. So we have got right dominant arteries. But in some of the cases, it can be a branch of left coronary artery also. And that is called left dominant artery. तो यहाँ पे अगर हम बात करते हैं लेफ्ट सर्कमफ्लेक्स और लेफ्ट एंटीरियर डिसेंडिंग, सो लेफ्ट सर्कमफ्लेक्स एंड लेफ्ट एंटीरियर डिसेंडिंग आर्टरी की बात करते हैं, तो लेफ्ट एंटीरियर डिसेंडिंग विच इज ऑल्सो कॉल्ड एज anterior interventricular arteries branches will give blood supply to left ventricle, also the part of right ventricle. But we have one of the branch which is called as diagonal artery. You can see this is the diagonal artery. And if I talk about diagonal artery, see this image. If I talk about diagonal artery, it is concentrated in giving blood supply only to the left ventricle. It is giving blood supply only to the left ventricular chamber of the heart. So the odd man out here, and the correct answer will be diagonal artery. So in this arrow, we can see right ventricle has been identified, and right ventricle is not getting its blood supply from which part? From the diagonal artery. So definitely D is the right answer. Let's move on to the next question. That is question number 39. Which of the following given muscle is not supplied by marked nerve in the given section? Options are inferior oblique, superior oblique, medial rectus and superior rectus. So we have got 4 options and we have to mark the right answer. So I just want to enlarge this image. So when I'm enlarging this image, you can see the cranial cavity, and you can also appreciate the nerves which is coming out from the cranial cavity. Now what has been asked in this image, I just want, the arrow is marked on this nerve. So the first thing is that you have to identify this arrow marked nerve. So which nerve is this? So actually this is the third cranial nerve. So which nerve is this? This nerve is the third cranial nerve. And then we have to come up with it. So actually in this cranial cavity, for this question, I am going in the explanation of all the cranial cavities identification. But before that, the other way, if you are able to identify the nerve, then also you can give the right answer, which you have already identified. Otherwise, which of the following is not supplied by marked nerve? So you are also knowing that inferior oblique is supplied by oculomotor nerve. You are knowing superior rectus is also supplied by oculomotor nerve. You are also knowing medial rectus is supplied by oculomotor nerve. So the odd man out, and the correct answer will be superior oblique. Why? Because superior oblique is the muscle which is supplied by trochlear nerve. So here superior oblique is the muscle which is supplied by SO4, trochlear nerve. So we know that all the extraocular muscle is supplied by third cranial nerve except LR6 and SO4. So if you are knowing that also, you can give the right answer, because we already know inferior oblique, medial rectus, superior rectus, and that of inferior rectus. All these are the muscles which is supplied by oculomotor or third cranial nerve, except lateral rectus by the it is supplied by the abduction nerve, and superior oblique is supplied by the trochlear nerve. Also levator palpable superioris is supplied by third cranial nerve. So that is also the way that will help you to come to the right answer. The other way is identification of the nerve and then coming to the right answer. So let's come on with the identification of the nerves in the cranial cavity. So for that, I will just like to enlarge this image. So I have enlarged this image, as you can see here. You can just have this. So can you see here? So I have just enlarged this image. Now I want everybody to identify the nerves. Now here, this nerve is coming out through cribriform plate of ethmoid bone. So this nerve is olfactory nerve. This is olfactory nerve. That is the first cranial nerve. This is the optic nerve, which is coming from the along with the ophthalmic artery. So this is the optic nerve, the second cranial nerve. So this is the third. This is the first cranial nerve. This is the second cranial nerve, and this is the pituitary stalk which you are seeing. This is the pituitary stalk, And this nerve which you are seeing here, which has been identified, is the oculomotor nerve, which is the third cranial nerve. And this is the trigeminal nerve. This is the trigeminal nerve, which is the fifth cranial nerve. And close to it, the smaller nerve is the fourth cranial nerve, that is trochlear nerve. And this nerve which you are seeing is the abduction nerve. This is the sixth cranial nerve or the abduction nerve. Okay, done with the identification. Other than that, you can see this is internal. So you can see this is internal acoustic meter. So this nerves will be seventh and eighth cranial nerve. That is facial nerve and that of vestibulocochlear nerve coming out for internal acoustic meatus. And this nerve which you are seeing here is the 12th cranial nerve, which is coming out through the hypoglossal canal. And here these nerves which are 9th, 10th and 11th. So 9th, 10th and 11th. 9th, 10th and 11th cranial nerve which is traversing through the jugular foramen. So we have done, other than that also you can see this is BA for basilar artery. These are the vertebral arteries, VA for the vertebral arteries of the both the side. So important, all the nerves had been understood here, and we are coming with the identification of all the nerves in the cranial cavity, because another image based question can come in which you have to identify the other nerves which is coming out from these cranial cavity, and you can identify by comparing the location of the bony prominences which are shown inside the cranial cavity. So done with this. So we are very clear why the question has got superior oblique as the right answer. Let's move on to the next question. That is question number. So let's move with the next question. That is question number 40. All of the following are branches of marked structure in the image. So the first thing for identifying this as a correct answer is that you have to identify this structure. So you have to identify this red color structure. Okay. So that arrow is marked there, and that will give you a hint in identification. And then you have to tell which of the following arteries is not the branch of the arrow marked area. So you can just come with the identification of the structure. So what we are seeing the abdominal wall, posterior abdominal wall, and the structures traversing here. So we can see here, this is the abdominal aorta. That means we have to know all the branches of abdominal aorta for coming with the correct answer. This is a very important topic, that you should know the branches of abdominal aorta. You should know the branches of internal iliac artery also. So if I come to this image once again in this question. Yeah. So all of the following are the branches of marked structure except, so we have got the right answer as uterine artery. I will tell you why uterine artery is the right answer. The reason is that uterine artery is a branch of internal iliac artery. Uterine artery is a branch of anterior division of internal iliac artery. But other than that, renal artery, ovarian artery, superior mesenteric artery, all these are the branches of abdominal aorta. So we are knowing this as an abdominal aorta. We have to know its branches. Before that, I want you to show this image. So you can see the branches. So you can see the abdominal aorta and three ventral branches. We have got the celiac trunk. We have got the superior mesenteric artery. We have got the inferior mesenteric artery. Okay, so here we have got celiac trunk exactly at the level of T12, superior mesenteric at the level of L1, inferior mesenteric at the level of L3 lumbar vertebra. Pair branches of 4 pairs of lumbar artery, gonadal, renal arteries are there. Terminal branches are the common iliac artery, median sacral artery, and also one more branch, that is inferior phrenic artery, which has been shown in this diagram. So here we have got 4 pairs of lumbar arteries are there. We have got gonadal, renal, and middle suprarenal artery is also. If I talk about middle suprarenal artery, it is also directly the branch of abdominal aorta along with inferior phrenic artery. So what I want everybody, will come to the next question, but before that I want everybody to write down all the branches of abdominal aorta. So please write it. Okay, so write down heading branches of abdominal aorta. Branches of abdominal aorta. So the branches of abdominal aorta is following. We have got 3 direct ventral branches, that is celiac trunk. We have got superior mesenteric artery. We have got inferior mesenteric artery. Now other branches are inferior phrenic artery. Other branches are inferior phrenic artery. Middle suprarenal artery. Middle suprarenal arteries. Renal arteries. Gonadal arteries, that means ovarian and testicular arteries. So other than that, we have got gonadal arteries. 4 pairs of lumbar arteries. Other than that, 4 pairs of lumbar arteries. So moving more. So here the branches of abdominal aorta. So 8-1, 4 pairs of lumbar arteries. 4 pairs of lumbar arteries. And other than that, we have got right and the left common iliac arteries and median sacral arteries. So we have got right and left common iliac arteries. That is the bifurcation of the abdominal aorta. Right and left common iliac arteries. And other than that, we have got the median sacral arteries. The median sacral arteries. So all these are the branches of abdominal aorta. So we have got all these are the branches of abdominal aorta. So all these are the branches of abdominal aorta. Here we have got the branches of abdominal aorta. Okay, these are the branches of abdomen. All these are the branches of abdominal aorta. So done with this. Now, why uterine artery is not the branches? Because it is a branches from internal iliac artery. So I just want to enlarge this image and show you. Actually, internal iliac artery. अगर common iliac artery terminate करता है right and the left common iliac artery, if you can see, the common iliac artery again forms internal iliac artery and external iliac artery. So if I just enlarge this image, you can see this is the common iliac artery. This is abdominal aorta. और ये जो एब्डोमिनल ऑर्टा है ये 2 कॉमन iliac artery बनाता है. कॉमन iliac artery, in short I have written. Then one is internal iliac artery which will go into the pelvic region, and below the inguinal ligament the external iliac artery will continue as the femoral artery. Common iliac artery will divide into 2 branches. One is external iliac artery, another is internal iliac artery. External iliac artery will traverse down the inguinal ligament and will continue as the femoral artery. Internal iliac artery will traverse in the pelvis. And we have to know the branches of internal iliac artery. So if I talk about the branches, obliterated umbilical artery forming median umbilical ligament, superior vesical, obturator artery, inferior vesical artery, and that of vaginal artery, uterine artery, artery to ductus deferens, middle rectal artery, internal pudendal artery, inferior gluteal artery. The branches from posterior division is just 3. We have got a mnemonic, that is SIL. Superior gluteal, lateral sacral, and iliolumbar. These are the branches from posterior division of internal iliac artery. So what is important for us? So please write down. So I just want everybody to write down the heading branches of. So you can just write branches of internal iliac artery. Branches of internal iliac artery. So if I talk about branches of internal iliac artery, which is itself is a branch of common iliac artery, which is giving major branches in the pelvic region. So I want to tell it divides into 2 divisions. One is anterior division and the other is posterior division. So coming to the branches of anterior division, we have got obliterated umbilical artery. The obliterated umbilical artery will form. If I talk about obliterated umbilical artery, the obliterated umbilical artery will form medial umbilical ligament. It will form medial umbilical ligament, because this is also medial umbilical ligament, which is also asked in an MCQ. So obliterated umbilical artery is the medial umbilical ligament. And this remnant is asked in the MCQ. The other is uterine artery, obturator artery, superior inferior vesical artery. We have got other branches as superior vesical artery, inferior vesical artery, inferior vesical artery, inferior gluteal artery, then we have got also the branch as vaginal artery, internal pudendal artery, internal pudendal artery, middle rectal artery. Artery to vas deferens is a branch of inferior vesicle. So all these which I have written, these are the branches from which division of internal iliac artery? These are the branches from anterior division of internal iliac artery. These are the branches of anterior division of internal iliac artery. And let's concentrate on the branches from posterior division. So we will talk about the branches. So this is from the anterior division, and let's write branches from the posterior division of internal iliac artery. So write down branches from the posterior division of internal iliac artery. Branches from the posterior division of internal iliac artery. So there is a mnemonic for understanding the branches from posterior division of posterior division of internal iliac artery, and that mnemonic is SIL. SIL. So here S for superior gluteal artery, I stands for iliolumbar artery, and L stands for lateral sacral artery. L stands for lateral sacral artery. L stands for lateral sacral artery. So done. These are the branches from posterior division of internal iliac artery. Got it, dear? Okay. Now we have done with this. Now, so we have done with till question number 40 has been done. I would like to change the slide, and I would like to go to the second part of the 100 MCQ session. So let's come to the second part. So coming to the second part. So yes, let's come to the second part of the 100 MCQ, which is the so top 100 MCQs for the targeting the subject of anatomy, so that you can score a better rank in the FMGE examination. That is 100 question or Abki baar 150 Paar. Okay, so that is the thing. So let's start with this question number 41. So let me read it for you. So this is again an image based question. Okay. Superior border of arrow mark structure is formed by. Superior border of arrow mark structure is formed by. The options are caudate lobe, hepatic artery, bile duct, inferior vena cava. Superior border of arrow mark structure is formed by caudate lobe, hepatic artery, bile duct, and inferior vena cava. So the thing is that here I just want to identify what you can appreciate. So यहाँ पे ये है lesser curve. What is this? This is the lesser curvature, and what is this? This is the greater curvature of the stomach, and this is duodenum. This is duodenum part. This is pyloric part of the stomach, and this is F for funduct part. This is the body part of the stomach. So what we are seeing here, this is the greater curvature of the stomach. This is the greater curvature of stomach. And this part is the lesser curvature of the stomach. This is the lesser curvature of stomach. Now from the lesser curvature of the stomach, I just want to mark here we have got the lesser omentum. So what you can see, this is the lesser omentum. So this is the lesser omentum. This is the lesser omentum, and behind the lesser omentum, the arrow is marked. The arrow, if we see the direction of the arrow, it is behind the lesser omentum, and that space, if we talk about the space which is lying behind the lesser omentum, that space is called as that arrow is pointing towards the foramen of Winslow or epiploic foramen. Foramen of Winslow or epiploic foramen, which forms a communication between greater and lesser sac. Okay, so that is foramen of, so that means we are now knowing the arrow to be, so the arrow is targeting which area the arrow is targeting. If I talk about this arrow which has been marked in this image, so the arrow is targeted on the foramen of Winslow. What is the other name of foramen of Winslow? It is also called as epiploic foramen. It is also called as epiploic foramen. And foramen, epiploic foramen is forming, or foramen of Winslow is forming a communication between greater and the lesser sac. So we have to know the boundaries of epiploic foramen, and definitely the right answer is caudate lobe of the liver. Why caudate lobe of the liver? Because it is forming superior boundary of the epiploic foramen. So for that, I would like to show you another diagram. So here in this diagram, this is a schematic diagram which is showing you the boundaries of epiploic foramen, which is showing you the boundaries of epiploic foramen. So here we can see the boundaries of epiploic foramen, and we can clearly appreciate here that the caudate process of the liver is forming the superior boundary. We can clearly see here that inferior vena cava is related posteriorly in case of epiploic foramen, and we can clearly see here that the first part of duodenum is lying in the inferior aspect of the epiploic foramen, and the structure which is lying in the anterior relation is the free margin of the lesser omentum, and the free margin of the lesser omentum is containing three important structure which has been shown. So you can see this is the free margin of the lesser omentum which is containing portal vein, hepatic artery and bile duct. So for that I just want to show you this. So we can see here, and here my dears, you can see this green color structure which you are seeing is the bile duct. What is it? This is the bile duct. This is the portal vein. And this is the hepatic artery. So that means these three, along with the lymphatics and nerves. So bile duct, portal vein and hepatic artery is located in the free margin of the lesser omentum, that is in the part of hepatoduodenal ligament. And if you want to understand the relation of these three structures, if you want to understand the relation of these three structures in the lesser omentum free part, hepatoduodenal ligament, portal vein is lying posteriorly, bile duct is lying anteriorly and to the right side, and hepatic artery is lying anteriorly and to the left side. So the relation, so free margin of lesser omentum is containing three structures. So if you want, please write on. Free margin of lesser omentum. Actually, lesser omentum is connecting the lesser curvature of the stomach with the portal region of the liver, and actually it is having two parts. It is having hepatogastric part and hepatoduodenal part. अगर hepatogastric part की बात करते हैं तो hepatogastric part is having the anastomosis of right and the left gastric artery. If I am talking about hepatoduodenal part, it is having three structures. So its free margin or hepatoduodenal ligament is having three important structures relation along with the nerves and the autonomic nerves plexus and the lymphatics. It is having portal vein which is lying posterior in this relation. It is having bile duct which is lying anteriorly and to the right side, anteriorly and to the right side, and it is having hepatic artery anteriorly and to the left side. Hepatic artery is also lying on the anterior aspect and it is lying on the left side. It is lying on the left side. Okay, done. Now we will talk about the next MCQ. So let's move on to the next MCQ, that is question number 42. Okay. Let's talk about question number 42. All of the following forms the boundary of marked area in the image except. All of the following is forming the boundary of marked area in the image except. So the options provided is coronary sinus, tendon of Toradado, septal leaflet of tricuspid valve, superior vena cava opening. Superior vena cava opening. So we have got 4 structures which is mentioned here. Okay. So 4 structures are mentioned and we have to see which of the following structure is not taking part in formation of the boundary of marked area. So I am just enlarging this image. So when I enlarge this image, you can see black color triangular area. So very nicely, you can appreciate the black color triangular area, and this black color triangular area is triangle of Koch. Okay, so अगर हम triangle of Koch की बात करते हैं, triangle of Koch is only seen when you open up the right atrium. So right atrium, in the interior of right atrium, you can see the triangle of Koch, and you have to understand the boundaries of triangle of Koch and what is the importance of triangle of Koch. The importance of triangle of Koch is location of AV node is lying here. AV node is lying here. So here we have got the location of AV node and the boundaries are. So here superiorly we will have tendon of Toradado, which is subendocardial thickening. This structure which lies inferiorly, that is the opening of coronary sinus. Opening of CS means coronary sinus, and anteriorly we have got tricuspid leaflets. Tricuspid leaflets. Tricuspid leaflets. So septal leaflet of tricuspid valve. So definitely superior vena cava opening is not related to triangle of Koch, and it is not important for the boundary of triangle of Koch. And if I talk about the sulcus terminalis, which is running from the externally from superior to inferior vena cava, on superior aspect we have got the SA node. Triangle of Koch is important for the location of AV node. So I just want once again for you to see this image where you can see the boundaries of triangle of Koch. So the cavity which is opened up is the right atrium. This is showing muscular pectinity. So this structure is muscular pectinity. Rough part, this is the oval opening of fossa ovalis. This is fossa ovalis. And here superiorly we have got tendon of Toradado, which is subendocardial thickening. Tricuspid valve leaflet anteriorly. Coronary sinus opening is inferiorly. Okay. And this triangular area which has been highlighted, which I will highlight in this image. This triangular area which is highlighted in this image is showing the triangle of Koch, which has got an important location of which structure? AV node. It is important. What is the importance of triangle of Koch? It contains AV node. Now, other than that, it's also important to know the location of SA node, which I told you. SA node, if we will see on exterior aspect, this is the superior vena cava, this will be the inferior vena cava. So on external aspect, sulcus terminalis is the groove which is running from superior to inferior vena cava. Close to superior vena cava, here on the upper or proximal part of sulcus terminalis, we have got SA node location. These are the SA node is the pacemaker of the heart, and these are the parts of conducting system of the heart. I would also like to show you another cadaveric image in which in more elaborate view you can identify the boundaries of triangle of Koch, which is seen in the interior of right atrium of the heart. So I just want to enlarge this image. So what I have done, I have enlarged this image, as you can see. And here we are seeing triangle of Koch. The boundaries are coronary sinus is lying below, postero-inferiorly opening. So actually most of the veins of the heart, great cardiac vein, middle cardiac vein, small cardiac vein, marginal vein, many veins, all the important veins of the heart is draining into coronary sinus, and coronary sinus is opening in the interior of the heart. Anteriorly, we have got tricuspid valve, leaflet, septal leaflet, tendon of Toradado, subendocardial thickening as the superior. And this triangular area is triangle of Koch, which contains AV node. This is fossa ovalis. Okay. So done with this. Now let's move on to the next question. That is question number 43. Now, which of the following structure crosses the arrow marked structure in the given image? So exactly, you have to identify that arrow mark structure here, and then you have to know about all the structures being crossed by this except. So first thing is that I will just show you this image in which you can see this is the outer part. So this is showing the hostrations, and you are very clear that this will be transverse colon, T colon, this will be ascending colon, this will be descending colon. That means these are the parts of large intestine. Interior to it, you can see the loops are being shown. So you can see the loops are being shown, and this will be the loops of small intestine. So small intestinal loop, mainly the ileum and jejunum, the part of the peritoneal fold, the part of the peritoneum which is containing, which is holding this loop, that is the loops of small intestine, mainly the jejunum and ileum. This arrow mark structure is called as mesentery. This is called as mesentery, and we have to know what are the structures crossed by the mesentery. So which of the following structure crosses the root of mesentery? If I talk about mesentery, it is actually having an attached border, and it is having, if I talk about the mesentery, so अगर हम mesentery की बात करें तो it is having an attached border and it is having a free border. So attached border or the root of mesentery, the other name which is given for the attached border is the root of mesentery, which is 15 to 20 centimeters in length. And many structures are crossed by the root of mesentery. If I talk about the free margins of free border, it is 6 meters in the length. And let's see the important structures crossed by it. So exactly the horizontal part of duodenum is the right answer. I will also show you an image. If you see this image, you can have an idea of all the structures being crossed by the root of mesentery. Another important point which has been shown in this image is the attachment of the root of mesentery. So what I want everybody, so I just want to use green color for it. Okay, so this is duodenojejunal flexor, junction of duodenum and jejunum. This is ileocecal junction. So this is on to the left side. So from left side to that of the right side, the attachment of root of mesentery is there. So here exactly, you can see this part which I am shading here is exactly this part which I'm shading here is the attached root of mesentery. So root of mesentery is extending from left to right hand side, it is extending from duodenum and jejunum junction to that of ileocecal junction on the right side. In this attached border, which is called as the root of mesentery, which is approximately 20 centimeters, 15 to 20 centimeters, many of the structures is crossed. The structures crossed by root of mesentery is following. It crosses horizontal part of duodenum. It is crossing abdominal aorta. It is crossing inferior vena cava. It is crossing right gonadal vessel. It is crossing right ureter and right psoas major muscle. So these are the structures which are being crossed by the root of mesentery. We have got horizontal part of duodenum which is crossed. We have got abdominal aorta which is crossed. We have got inferior vena cava which is crossed. Right gonadal vessels, right ureter and right psoas major. So these are the list of structures which are being crossed by the attached border of the mesentery, that is root of mesentery. So definitely horizontal part of duodenum is the right answer. So from left hand side, it has to reach the right hand side at the level of ileocecal junction. And what does it contain? It contains loop of intestine, that is mainly jejunum and ileum, and contains the branches of superior mesenteric artery in it. So done with this. So let's move on to the next question. That is question number 44. So, okay, I just want to take water. So just 30 seconds. I just want to have water. Okay. So now coming to the next question. Let's move on to the next question. That is question number 44. So all of the following muscles are supplied by the marked structure in the image except. So again, this is an image based question. The first thing is that you have to identify this arrow marked structure. So for that, I want everybody to see an enlarged view of this image. So see here. So I have enlarged this image and you can see the arrow is on the yellow color loop. So can you see here? This is the yellow color loop which you are seeing. So the arrow is exactly on this yellow color loop. And you can see the structures which is lying in here. So here we can have this is the vein. Close to it also we have got the artery. So here we have got the artery which you are seeing and a nerve which is also being seen. So exactly अभी हमें hint मिल गया कि एक important vein and artery which is lying close to each other, on the anterior wall of it the loop is lying. So actually this nerve loop is ansa cervicalis. What is it? This nerve loop is ansa cervicalis. So this nerve loop is ansa cervicalis. So the question is asking, actually ansa cervicalis is a nerve loop which is having superior root and inferior root, descending part and ascending part, and it is giving innervation to all infrahyoid muscle. So exactly the question is having, it is giving innervation to all infrahyoid muscle except. So the correct answer is thyroid. Thyroid is a muscle which is not innervated. If I talk about thyroid muscle, it is not innervated by. It is not innervated by. So the correct answer is thyroid muscle, which is not innervated by ansa cervicalis loop. Other than that, all infrahyoid muscle, omohyoid, sternothyroid, all is innervated by ansa cervicalis loop. So I just want everybody to identify this nerve loop in a cadaveric image. So let's see here. I am just enlarging this image. So what you are seeing here is the nerve loop. So what is, how you are going to identify? So I just want, so first I am using red color for the common carotid arteries. So this is the common carotid artery which has been shown here, the carotid arteries. Done. Now we have got the veins. So we have got the internal jugular vein also here, and we have got the nerve. So this is the vagus nerve. So three important structures has been shown here, and we know that common carotid artery, V for vagus nerve, and IGV. These are the three important contents. These are the three important contents which is lying in the carotid sheath. So if we talk about, this is the vagus nerve. If we talk about, this is the IJV. If we talk about, this is the common carotid artery. And anterior to these three structures, we have got a nerve loop which is residing here. So the nerve loop which you are seeing here is this. So this is the nerve loop which we are talking. So once more, sorry. So just I rub this. Okay, this is the red color artery and this is the nerve. Now I just want to highlight the nerve loop. So you can see this is exactly the nerve loop. This is exactly the nerve loop which I have highlighted. And here SR means superior root and IR. So here SR means superior root of ansa cervicalis. SR means superior root of ansa cervicalis. IR means inferior root of ansa cervicalis. And the nerve loop is lying on the anterior wall or sheath of carotid sheath, and it is giving innervation to all the infrahyoid muscle except that of thyroid, which should be clear to you. It's not giving innervation to any kind of thyroid muscle. So that is the right answer. So I just want you to show this. This is the ansa cervicalis loop and how it is formed. So ansa cervicalis loop is embedded in the anterior wall of, it is embedded in the anterior wall of carotid sheath. It is embedded in the anterior wall of carotid sheath. It is having C1 which is forming the superior root. It is having C2 and C3 which is forming the lower root, and this is the upper root of ansa cervicalis. C1 is running along with hypoglossal nerve, and only with the C1 fibers we have got the innervation of thyroid muscle, not with the loop. So you can see here, this is the thyroid muscle which is innervated by the C1 nerve fibers. It is innervated by C1 nerve fibers which is running close to which nerve? Hypoglossal nerve. If I talk about this loop, if I am just talking about this loop, that is the loop of ansa cervicalis. This loop is giving innervation to superior belly of omohyoid, sternohyoid, sternothyroid, and inferior belly of omohyoid. Got it? Got it? So this loop is giving innervation to these muscles: superior belly of omohyoid, sternohyoid, sternothyroid, inferior belly of omohyoid. Done with this? Question number 44 we have done. So can we move on to the next question? That is question number 45. Marked structure receives blood from all of the following source except. So you have to firstly identify the marked structure. So let's come to this. So marked structure receive bloods from all of the following source except. So that means I will highlight this image. So I'm just highlighting this image. In this you can see the cranial cavity. यहाँ पे क्या दिख रहा है आपको? cranial cavity दिख रहा है, which is the interior. So inside the cranial cavity, can you see the red color highlighted structure? That is cavernous sinus. What is it? This is the cavernous sinus. So that means the question is being asked for which sinus? Cavernous sinus. This question is asking about cavernous sinus, and the question is telling that ये जो MCQs है, it is actually cavernous sinus is very important topic for FMG exam, also for NEET-PG exam. So you have to study it very well. If I talk about this cavernous sinus, the question is being asked, marked structure receive blood from all of the following except. Receive blood from all of the following except. Okay, so 4 options are there. A, superior inferior petrosal sinus, superior ophthalmic vein, sphenoparietal sinus, and superficial middle cerebral vein. Actually, this question is targeting about, basically targeting about the tributaries of cavernous sinus. So you have to know among these which are the direct tributaries of cavernous sinus. So exactly, if I talk about the direct tributaries of cavernous sinus take blood directly from the source of orbit, from the source of meninges, from the source of brain. So here superficial middle cerebral vein is a direct tributary from brain. Sphenoparietal sinus is a direct tributary from meninges. It's a direct tributary from meninges. It's a direct tributary from brain. Superior ophthalmic vein is a direct tributary from the orbit. But if I talk about the first option, that is superior inferior petrosal sinus, these are not direct tributary of cavernous sinus, but these are communications of the cavernous sinus. What are they? They are the communications of the cavernous sinus. Rest all B, C, D की बात करें तो they are the direct tributaries or direct source of blood for the cavernous sinus. But if you are talking about middle, if I are talking about superior inferior petrosal sinus, these are communications. So my dear students, I just want everybody to concentrate on this image. If you will see this image, you can have a quick recapitulation of the tributaries which the cavernous sinus, the blood draining into the cavernous sinus directly. We have got 3 sources in it. So just see this image. I'm just enlarging this image. And when I have enlarged this image, you can see the source. So we have got a source from the orbit. So 3 sources are there. From the orbit, from the meninges, and from the brain. So that means these are the direct source of blood draining into the cavernous sinus. So from the orbit, we have got a source of superior, inferior ophthalmic vein and central vein of the retina. So 3 veins, superior ophthalmic vein, inferior ophthalmic vein and central vein of retina. These are the direct source of blood draining into cavernous sinus. The source is from the orbit. If I talk about the source of meninges, we have got 2 veins, sphenoparietal sinus and middle meningeal vein. Sphenoparietal sinus and middle meningeal vein is also draining blood directly from the source of meninges to cavernous sinus. We have got 2 veins from the brain, that is inferior cerebral vein and superficial middle cerebral vein. So inferior cerebral vein and superficial middle cerebral vein is again draining blood from the brain directly to cavernous sinus. In this diagram, you can see the source of communications, like facial vein is a communication which will carry infections from the danger triangular area of the face to the deep facial vein, communication via pterygoid venous flex and emissary vein, and ultimately causing cavernous sinus thrombosis. Basilar venous plexus form communication via internal vertebral venous flex. Draining channels are, so we have a superior inferior petrosal sinus draining channels for forming the communications with that of sigmoid sinus transverse sinus. And 2 sides of cavernous sinus will communicate via intercavernous sinus, anterior and posterior. So this is an important point. Actually, before proceeding to the next question, I want quickly to show you how the infections from the face can drain into the interior, of the cavernous sinus. So for that, see this image. So exactly, we have got supratrochlear, supraorbital vein, then we form angular vein. So here we have got the facial vein. Facial vein will carry infection from the triangular area, that is dangerous triangular area of the face, via deep facial vein. It will communicate. So you can see this is the facial vein. It will communicate with the deep facial vein, then it will communicate with pterygoid venous plexus, and via emissary vein the infection will reach the cavernous sinus. So this is an important source of the venous communication. Actually, we know that cavernous sinus, all the dural venous sinuses are valvulous. They are valvulous, and so the infection is communicating in either direction. So infection from the superficial aspect of the face can drain into cavernous sinus, leading to cavernous sinus thrombosis. So done with this, let's move on to the next question. That is question number 46. So all of the following structure passes through the question marked fissure of the image except. So what you can see in this image, we have got superior orbital fissure and we have got an optic canal. So in this case, we can see the superior orbital fissure is there, which is retort shape as shown, and we have got the optic canal. So we have to tell about the structures which is not passing through this fissure, and the options which is provided is oculomotor nerve, trochlear nerve, abduction nerve, and maxillary nerve. Okay. So actually the odd man out, we know that maxillary nerve is the right answer. Why? I will tell you, because maxillary nerve, if I talk about the maxillary nerve, it passes through foramen rotundum. Maxillary nerve passes through foramen rotundum. Other than that, oculomotor nerve, trochlear, abduction, all these structures will pass through superior orbital fissure. All will pass through the superior orbital fissure. Now I just want you to show this image. So when you are seeing this image, you can see this is a schematic diagram showing the, which is showing the superior orbital fissure. So you can see here, this is the superior orbital fissure, which is retort shape, and in the middle, what you can see, we have got the circular ring. What is this? This is tendinous ring of Gin. This is annulus of Gin, tendinous ring, from which the recti muscles, extraocular muscles originate. Now, this will divide the whole of the part of superior orbital fissure into three parts. Okay, this is the lateral part, this is the intermediate or middle part, this is the below part or the medial part. So the structures passing from the lateral part or the superior part of the superior orbital fissure, we have got LFT. LFT stands for lacrimal frontal trochlear, along with its superior ophthalmic vein. Meningeal artery branches also go, and inside the intermediate part or the middle part of superior orbital fissure, or you can say inside the annulus tendinous ring of Gin, we have got oculomotor nerve superior inferior division, oculomotor nerve superior and inferior division. We have got abduction nerve and we have got nasociliary nerve. And in the lower part or the medial aspect of superior orbital fissure, we have got inferior ophthalmic vein. So all these structures which has been shown here are passing through superior orbital fissure, and we can definitely see maxillary nerve is not passing through superior orbital fissure. That is the correct answer, or odd man out, because maxillary nerve is passing through foramen rotundum. So I just want that quickly you can just write this information also. So this arrow mark structure is superior orbital fissure, and the important structure, so already I have shown you the image for this, but important structure passing through it will be LFT, lacrimal frontal, okay, so sorry, yeah, lacrimal frontal and trochlear. Lacrimal frontal trochlear. So these lacrimal frontal branch of ophthalmic division of trigeminal nerve. These are the nerves which is passing. Other than that, superior ophthalmic vein. Superior ophthalmic vein will pass. Then other structures which is passing is upper division of oculomotor nerve, lower division of oculomotor nerve, lower division of oculomotor nerve, upper division of oculomotor nerve, lower division of oculomotor nerve, and upper division of oculomotor nerve and the lower division of oculomotor nerve. Other than that, we have got also abduction nerve, nasociliary nerve, which is passing through it. We have got nasociliary nerve passing through it. And we have got inferior ophthalmic vein. And we have got inferior ophthalmic vein. Ophthalmic vein. So all these structures which I have written is passing through the superior orbital fissure. Done with this. So we have done with this. And what about the maxillary nerve? If I talk about the maxillary nerve, it is passing through foramen rotundum of, maxillary nerve is passing through foramen rotundum of the cranial cavity. Done with this. Let's move on to the next. That is question number 47. Okay. Which of the following sensation is not perceived by spinal nucleus of trigeminal nerve? Which of the following sensation is not perceived by spinal nucleus of trigeminal nerve? So this is again a very important topic, cranial nerve nuclei. Actually, it's very important that you should have an understanding of functional component and the cranial nerve nuclei. So if I talk about trigeminal nerve, sensory component is having three nuclei. One is the motor nucleus of trigeminal nerve, which is giving innervation to the muscles of mastication. Other than that, if I talk about the sensory nucleus of trigeminal nerve, it is having three parts. It is having spinal nucleus of trigeminal nerve, it is having chief sensory nucleus, it is having mesencephalic nucleus of trigeminal nerve. और अगर हम proprioceptive sensation की बात करें तो it is primarily carried by mesencephalic nucleus of trigeminal nerve. So that is the right answer. Pain, touch, temperature can be traversed by the spinal nucleus of or perceived by spinal nucleus of trigeminal nerve. So you can clearly see this in the diagram. So let's see this image. So if we talk about this diagram, so let's see here. Okay, so here the three principal or sensory nucleus of trigeminal nerve, which is located in pons. Mesencephalic nucleus of trigeminal nerve, which will extend in the midbrain. And the spinal nucleus of trigeminal nerve, which will extend into the medulla and to the till the level of second cervical segment, till the level of second cervical segment of spinal cord. So it is extending till the level of second cervical segment. It is extending till the level of second cervical segment of the spinal cord. So these are the three sensory nucleuses of trigeminal which have got three different functions to perform. So you can see here the mesencephalic, the chief sensory, and the spinal nucleus of trigeminal nerve. I just want everybody to write about this, the function. So please write down. Chief sensory nucleus of trigeminal nerve. Chief sensory nucleus of trigeminal nerve has got a function of touch and pressure. Mainly. Spinal nucleus of trigeminal nerve, which is mainly pain and temperature, which has got a sensation or function of pain and temperature sensation, but also it can perceive the touch sensation. So pain and temperature sensation. And if I talk about the mesencephalic nucleus of trigeminal nerve, mesencephalic nucleus of trigeminal nerve. So if I talk about mesencephalic nucleus of trigeminal nerve, the major function performed by the mesencephalic nucleus of trigeminal nerve is proprioceptive sensation. Proprioceptive sensation. It performs a function of proprioceptive sensation. So the right answer in this case will be the proprioceptive sensation. 47. The right answer in this case will be D, proprioceptive sensation. So let's talk about the next one, that is question number 48. Damage to the following nerves. Damage to the following nerves leads to the loss of sensation of adjacent slides of the greater and the lesser toes and impaired dorsiflexion of the foot. So if I talk about the damage of the nerve, so exactly the key point which is given in this MCQ is that, if I talk about the key point which is given here, is the loss of sensation is there. There is a sensory loss on the adjacent side of the great toe and that of second toe. So it is exactly the sensory sensation, loss of sensation in the great toe and that of second toe. So impaired dorsiflexion of the foot. What will be, and also there the dorsiflexion is impaired. So it is dorsiflexion is impaired. So you have to mark the right answer in this case. So my dear students or my dear aspirants, I would like to share an image with you. In that you can see the sensory innervation in the areas of the dorsum of the foot and the leg. So in that you can appreciate the adjacent to the great toe and the adjacent second toe, the sensory innervation is carried via deep peroneal nerve. So definitely the right answer here will be deep peroneal nerve. Got it? Deep peroneal nerve. So I just, and also we know all the muscles. If I talk, so also we know all the muscles of anterior compartment. So exactly the right answer is deep peroneal nerve. And why the deep peroneal nerve is the right answer? Because deep peroneal nerve is the nerve of anterior compartment of leg. It is the nerve of anterior compartment of leg. And that means it is giving innervation to all the muscles of anterior compartment of leg. It is giving innervation to all the muscles of anterior compartment of leg, which is consist of extensor hallucis longus, tibialis anterior, extensor digitorum longus, and peroneus tertius. And all these has got a function of dorsiflexion of the ankle joint, and the function of dorsiflexion of ankle joint will be impaired if there is an injury of deep peroneal. Got it? Is it clear to you? So, and also a small area of cutaneous sensation which is on the adjacent side of great and little toe is done by the deep peroneal nerve. So you can see this image and you can very nicely appreciate the deep peroneal nerve. If you see the deep peroneal nerve, the cutaneous sensation, the sensory sensation adjacent to the great toe and that of adjacent toe is traversed by deep peroneal nerve. This is the area of superficial peroneal nerve, sensory distribution, saphenous nerve, which is on the medial aspect of the leg, and it will go till the level of great toe. Medially, it will go till the level of great toe. Common peroneal nerve, sensory distribution is also so. So after that, it is quite clear the right answer in this case will be definitely deep peroneal nerve. Now let us move on to the next question, that is question number 49. All of the following pairs, actually I have told you in the previous part that if we talk about the neural columns and if we talk about the functional component and neural columns, functional columns, the pairing of the functional component along with the nuclei associated with it is very, very important for you to know. It's very important for you to know. So this is a match the following kind of question. The options provided is hypoglossal nucleus. So if I talk about hypoglossal nucleus, the functional component is given general somatic efferents. Okay. General somatic efferent, what do you mean by that? It means that it is giving innervation to all the muscles which is derived from the somites. Okay. So in that context, yes, it's quite right. We know that occipital somites are giving rise to the, embryologically it's giving rise to the muscles of tongue. So all the muscles or hypoglossal nerve is a nerve of general somatic efferent. So if I talk about nucleus ambiguous, it's a composite nucleus for the 9th, 10th and 11th nerve, and it is giving innervation to the muscles of pharynx, larynx and soft palate, and it is carrying special visceral efferent, that is branchial efferent. So definitely it is also the right answer, and it is also the right pairing. Dorsal nucleus of vagus, they have written it is general visceral afferent. It is not correct, because general visceral afferent, actually dorsal nucleus of vagus is paired with general visceral efferent. It is efferent, not afferent. It is carrying preganglionic parasympathetic cranial outflow. It is not general somatic. It's not afferent. It is efferent. So the odd man out, or the wrong pairing, is by the C. Nucleus, NTS. What is the full form of NTS? Nucleus of tractus solitarius. Absolutely correct. It has got a pair of special visceral afferent. Special visceral afferent is definitely the right answer. That is carrying the sensation of taste. So now coming to the next one. So let's talk about the next one. So we have done with this now. So I just want that you should give a quick recapitulation of all the cranial nerve nucleated in this. So this column is very important for you to understand. So exactly one by one, I will tell you about the functional component and cranial nerve nuclei located in this contest. So if I talk about general somatic efferent, as I told you, if we are talking about general somatic efferent, it is giving innervation to the muscles derived from the somites. So 4 nucleuses are included in this category. That is oculomotor motor nucleus, trochlear motor nucleus. We have got the abducent nerve motor nucleus. We have got the hypoglossal motor nerve nucleus. If we got a special visceral, that is giving innervation to all the muscles derived from pharyngeal arches. So we have got motor nucleus of trigeminal nerve, the nerve of first pharyngeal arch, trigeminal nerve. It is giving innervation to all the muscles derived from the first pharyngeal arch. Motor nucleus of facial nerve, which is giving innervation to all the muscles derived from the second pharyngeal. Nucleus ambiguous, it is a composite nucleus which is giving innervation to all the muscles derived from that of 4th and 6th pharyngeal arch, and it is a composite nucleus for 9th, 10th and 11th nerve, giving innervation to the muscles of pharynx, larynx and soft palate. If I talk about general column, if I talk about general visceral efferent, again general visceral efferent column की बात करते हैं. So general visceral efferent column, if I talk about, it is carrying preganglionic nucleus is for important for the secretion from parotid gland, dorsal nucleus of vagus located in important secretion for the abdominal thoracic region. If I talk about general visceral and special visceral afferent, it's very important for you to note down these two functional component is having just one cranial nerve nuclei in this content, that is NT. What is NT? Nucleus of tractus solitarius, which has got the sensation for the general sensation of distension, ischemia, and for the taste sensation for the tongue. Now, if I talk about general somatic afferent carrying the sensation of exteroceptive, proprioceptive sensation, in this category, we have included sensory nuclei of trigeminal nerve, and the sensory nuclei of trigeminal nerve is again having 3 components: chief sensory located in the pons, mesencephalic located in the midbrain, spinal trigeminal nucleus located in the extending in the medulla and extend till the level of cervical segment, cervical spinal segment. Second. So C2, that means C2 cervical segment. Special somatic afferent is carrying special sensation for the balancing and hearing, and the nuclei in relation to it is vestibular and cochlear nuclei. So done with this, now I would like to talk with the, I would like to explain the next MCQ in relation to this, that is the 50th question. So we have approached to the half century of our 100 MCQs. Half century हमने कर लिया, but I would like to cover up 60 MCQs before that lunch break. Now, root value of common peroneal nerve. So we know that common peroneal nerve is the smaller terminal branch of sciatic nerve, which is winding around the neck of fibula. If we talk about common peroneal nerve, it is winding around the neck of fibula, and its root value is, so it's a direct question. We know that common peroneal nerve root value is dorsal branch ventral rami of L4, L5, S1 and S2. So we have got C as the right answer. So it is the smaller terminal branch of sciatic nerve, dorsal branch of ventral rami of L4, L5, S1, S2 is the right answer. The larger branch of sciatic nerve is tibial nerve. Tibial nerve is formed by ventral branch, ventral rami of L4, L5, S1 and S2. So here you can see this is the sciatic nerve, and the 2 branches of sciatic nerve has been shown to you. One is dorsal and actually one is tibial nerve and other is common peroneal nerve. What is important for you is to understand the root value of common peroneal nerve also, and understand the root value of tibial nerve also. So I have already written the common peroneal nerve root value. but I want also for you to write the root value of tibial nerve. So please write down root value of tibial nerve. So tibial nerve root value. Tibial nerve, which is a nerve of posterior compartment of the leg. So if I talk about tibial nerve, it is formed by ventral division, ventral ramayo. It is formed by ventral division, ventral ramayo. It is formed by ventral division, ventral ramayo. L4, L5, S1, S2, and S3. So done with this. Now let's move on to the next question. Okay, so this is a clinical question. Let me first read it for you, and then you can come up. So you take your time for solving this question. I will just few seconds. I will wait for you to mark the right answer here. So coming to question number 51. A 40-year-old man comes to the office for evaluation of neck lump. So the function which is performed here is neck lump. The patient they come with a complaint of the patient has come with a complaint of neck lump. He first noticed the lump is of 4 months ago while he was. So first thing which he noticed about the neck lump is that he has seen this neck lump 4 months ago while he was shaving, and says that it seems to be growing in size thereafter. Physical examination shows a nodular mass in the left thyroid lobe. He also has he has no pain, no shortness of breath, cough, hoarseness, or difficulty in swallowing. Serum TSH level, that is the level of thyroid stimulating hormone level, is normal. Fine needle aspiration biopsy is consistent with the papillary thyroid cancer. A total thyroidectomy is performed. And while attempting to ligate the inferior thyroid artery, the surgeon accidentally damages a structure which is lying close to it. So can you tell me the right answer, or which nerve is lying in close proximity to inferior thyroid artery in this case? The option is ansa cervicalis, accessory nerves, superior laryngeal nerve, or recurrent laryngeal nerve. So the key point is that total thyroidectomy operation has been performed, and the ligation of the artery which is done is inferior thyroid artery. The surgeon accidentally damages a structure which is lying close to it, and the structure which is lying close to it, close to inferior thyroid artery, is recurrent laryngeal nerve. So my dear students, the correct answer will be recurrent laryngeal nerve. So this is very important question, not only for your ENT part, not also for surgical part, also for your anatomy part. So actually thyroidectomy is an operation which can be done for nodular cancers or for thyroid cancers. So the surgeon should be especially keep this point, that they should ligate superior thyroid artery and inferior thyroid artery with utmost care and precision. Why? Because we know that superior thyroid artery is running close to external laryngeal nerve, and it gives blood through the apical part of thyroid gland. And if I talk about inferior thyroid artery, the inferior thyroid artery, if I talk about, it is running close to recurrent laryngeal nerve. So if the ligation is done on inferior thyroid artery, there can be a chance of injury of recurrent laryngeal nerve. Now if the recurrent laryngeal nerve is injured, what will happen? All the muscles of larynx is paralyzed, and this is a grave condition. If the external laryngeal nerve is injured, one of the muscle of the larynx, intrinsic muscle of larynx, that is cricothyroid, will be paralyzed. So see here, recurrent laryngeal nerve is a branch of vagus nerve which is looping along the arch of aorta in the left side and on the subclavian artery on the right side. It is very important. Why? Because it is giving innervation to all the intrinsic muscles of the larynx. All the intrinsic muscles of the larynx are innervated by the recurrent laryngeal nerve except cricothyroid. During thyroid operation, due to the close proximity of recurrent laryngeal nerve and inferior thyroid artery, there can be chance of injury of recurrent laryngeal nerve. Unilateral injury of recurrent laryngeal nerve will lead to the hoarseness of voice, whereas bilateral injury will cause respiratory stridor, and this is respiratory distress, and this is a very grave condition. So as quickly as possible, endotracheal intubation should be done to save the patient. Why? Because if both the side, the patient will have asphyxia, he or she will not able to breathe, and bilateral recurrent laryngeal nerve injury is a very emergency condition. Now, I just want you to show this image where you can see left recurrent laryngeal nerve is winding around the arch of aorta, and that of the right recurrent laryngeal nerve is winding around subclavian artery. Now, important relation. So all of you see this image, because if you see this image, you can understand the important blood supply and nerve relation in case of thyroid gland. So what you can see here, this is the outline of thyroid gland. Okay, this is the outline of thyroid gland. So in this diagram itself, what you can appreciate, and this one is, what is one? One is the apical part of thyroid gland where superior thyroid artery and external laryngeal nerve is lying close to it. So you can see utmost care should, so you can see the superior thyroid artery, if ligated, if utmost care is not taken, and by accidentally the surgeon can injure external laryngeal nerve, which will lead to the paralysis of only one muscle, that is cricothyroid muscle, which is having the tensioning effect on the larynx. The other towards the basal aspect. So this is second, and towards the basal aspect, the blood supply is via inferior thyroid artery, and inferior thyroid artery is running close to recurrent laryngeal nerve. And recurrent laryngeal nerve gives paralysis to all the muscles of larynx, intrinsic muscles of the larynx. And we know that one of the very important muscle is posterior cricoarytenoid. So if posterior cricoarytenoid is paralyzed, what will happen? Abduction of vocal cord is not done, and when the abduction of vocal cord is affected, that means the bilateral, if it is bilateral, then the vocal cords will be in paramedian position and it will lead to asphyxia. Otherwise, unilateral also slight difficulty in breathing can occur. So it's care should be taken whenever the operation is performed in this area. Now, why spinal accessory is not the right answer, my dear students? Spinal accessory is a important nerve, that is 11th cranial nerve, which is traversing from the jugular foramen and traversing through foramen. Actually, this is an important nerve which is located in the posterior triangle of the neck. If we talk about spinal accessory nerve, the location is in the posterior triangle of the neck. And if there is a lump in the posterior triangle of the neck, and surgery has to be done for that lump, at most care should be taken. Why at most care should be taken? Because spinal accessory nerve is traversing, passing between investing layer of deep cervical fascia and that of prevertebral layer of deep cervical. So exactly it is traversing between the roof, which is formed by investing layer of deep cervical fascia, and the floor, which is formed by prevertebral layer of deep cervical fascia. So in that category, it can be injured and it can lead to the paralysis of two important muscles, sternocleidomastoid and trapezius muscle. So if clinical question is framed, they will tell you that sternocleidomastoid paralyzed है तो neck movement affected है. अगर trapezius muscle paralyzed है तो overhead abduction of arm is affected. Ansa cervicalis is not the right answer, because we know that ansa cervicalis is located on the anterior wall or sheath of carotid sheath, and it is giving innervation to infrahyoid muscle, which was not paralyzed in this condition. Superior laryngeal nerve is also not the right answer. We know that superior laryngeal nerve is a branch from vagus nerve which is dividing into external laryngeal nerve and internal laryngeal nerve. So if I talk about external laryngeal nerve, it is giving innervation to the cricothyroid muscle, and if I talk about internal laryngeal nerve, it is giving innervation, mucus, it is giving sensory innervation to the mucosa of the vocal cord upper part. So that is absolutely clear that these are the wrong option, and we will come up with the right answer, that is the injury of recurrent laryngeal nerve, because it is running in close to inferior thyroid artery. Now, this is a histological question. And in this MCQ, that is question number 52, you have to identify the histological slide. Whether it is a slide of lip, whether it is a slide of fungiform papilla, whether it is a slide of circumvallate papilla or filiform papilla. So I just want to enlarge this image. So if I enlarge it, you can have an idea of this reason. You can see the histological features, and then you can come up with the right answer. Okay, so this is circumvallate papillae. So this is circumvallate papillae, and if I talk about the circumvallate papillae, why it is? Because you can see it is have a truncated dome-like appearance. So you can see superiorly the lining epithelium of the tongue, as we know, is stratified squamous non-keratinized. It is stratified squamous non-keratinized epithelium. So it is stratified squamous non-keratinized epithelium. And in the lateral wall, can you see this? These are the taste buds. So what are these? These are the taste buds. So I have got another image of the enlarged view. So you can just see these are the taste bud, and we know that taste bud is maximum in number and located in the lateral wall. On this are the taste buds. These are the taste buds. So taste buds are located in the lateral wall, and this is what? These are the deep trench. These are the deep trench on either side of this moat-like structure, which is circumvallate papilla. This is circumvallate papilla. The circumvallate papilla is the largest papilla of the tongue, and it is located just anterior to sulcus terminalis. Circumvallate papilla is innervated by glossopharyngeal nerve, and this is why important, because it contains so many of taste buds having gustatory cells and supporting cells and basal cells lying in the lateral wall or moat of the circumvallate papilla. So the best correct, and why it is a slide of tongue, I will tell you, because lining epithelium has been shown, which is stratified squamous. This is stratified squamous non-keratinized epithelium. So it is stratified squamous non-keratinized epithelium. These are the cut section. These are glands. These are cut section of muscles. These are von Ebner's gland. Von Ebner's gland. These are the cut section of muscle, because tongue itself is a muscle. So that is an important hint which is giving us the hint that this is a histological. These are the identifying features by which you can identify this is a slide of tongue. Now, so we have got the right answer here also. If I talk about lip, no, it can be lip because that is having mucocutaneous junction. Filiform papilla is not the right answer. If I talk about filiform papilla, it is tiny and it will have the shape like this. Filiform papilla. And if I talk fungiform papilla, it will be mushroom shape like this. And the circumvallate papilla will have a truncated appearance. If I talk about the correct answer, it is circumvallate papilla. And other important point which I want to talk about filiform papilla is that filiform papilla is the odd man out here. Why? Because filiform papilla is the papilla which is not having any kind of taste bud, and it is having the lining epithelium of stratified squamous keratinized epithelium. So it is a very important point for you to note down. Please note down this. All the papillas of tongue have presence of taste bud, have the presence of taste bud, except filiform papillae, except filiform papillae. Okay. And this filiform papilla is also odd man out because lining epithelium. In case of filiform papillae, the lining epithelium is not like the rest part of the tongue. The lining epithelium of filiform papillae is stratified squamous keratinized epithelium. Stratified squamous. It is stratified squamous keratinized epithelium. And rest whole part of the tongue is stratified squamous non-keratinized epithelium. So that is very important for you to note down. So done with this, now we will talk about the next question, that is question number 53. Now we will talk about the next question, that is question number 53. So let's talk about the next one. Okay, let me read it for you. So let me just read it for you. So I would like to read this MCQ for you. So common carotid artery pulse. So common carotid artery pulse can be taken at which level? Okay, so this is the direct MCQ. Common carotid artery pulse is taken at which level? The options given is, if I talk about the option given is cricoid cartilage, laryngeal prominences, suprasternal notch, or angle of mandible. So we have got 4 options and you have to mark the right answer. Common carotid artery pulse is taken at which level? So A, B, C, D is there. And actually the correct answer is cricoid cartilage. So it's important to know the correct answer here. So common carotid artery pulsation is taken at the level of cricoid cartilage. Let me explain it why. So when I talk about the right answer, that is cricoid cartilage, common carotid artery which can bifurcate as external and internal carotid artery. External carotid artery will give arterial supply to the head and neck region. And if I talk about internal carotid artery, it is mainly giving blood supply to the brain. So exactly अगर कॉमन कैरोटिड आर्टरी की बाइफर्केशन की बात करते हैं तो दैट इज एग्जैक्टली occurring at the C4 level. And if I talk about common carotid artery pulsation, it can be palpated at the level of cricoid cartilage. What is cricoid cartilage? It is one of the laryngeal cartilage. The carotid artery pulsation usually is examined by the patient to be in the supine position, and then the trunk of the patient body slightly elevated. The patient chin should be elevated so as easy palpation can be done. The pulsation of common carotid artery can be done by compressing the artery against carotid tubercle. Actually, what is carotid tubercle? Carotid tubercle is formed by the transverse tubercle of C6 cervical vertebra. Carotid tubercle is formed by transverse process of C6 cervical vertebra, and the exact location of this is corresponding to cricoid cartilage. Where it lies? It lies at the level of cricoid cartilage. Now let's talk about the other option. So let's talk about the other option. If I talk about the other option, laryngeal prominence is not the right answer, because if we talk about laryngeal prominence, we know that larynx is made of cartilages. There are 9 cartilage in respect to larynx. We have got 3 paired and 3 unpaired. The 3 paired one is arytenoid, corniculate and cuneiform. 3 unpaired is epiglottis, thyroid and cricoid cartilage. So total we have got 6. Total we have got 9. So Adam's sample is by the thyroid cartilage prominence in the midline, where the 2 laminas of thyroid cartilage is meeting. Suprasternal notch is a visible dip which is seen in the neck. Actually, this suprasternal space is lying between the 2 clavicle, and it is lying above the manubrium sterni. Exactly, it is lying at the level of T2 and T3 vertebra. So this is also not the right answer for the palpation of carotid artery. Angle of mandible is definitely not the right answer, because angle of mandible is the curvature. So angle of mandible is the area where we have got around this area anterior to ear, we have got the great auricular nerve giving innervation, and actually this is the area which is not having common carotid artery location there. So definitely this is the wrong option. Right common carotid artery in the neck. So I also want everybody to understand there are 2 carotid arteries. Right is a branch from brachiocephalic trunk, and left one is, if I talk about right common carotid artery, please note down it is a branch from brachiocephalic trunk. And left common carotid artery is a branch from aortic arch. It's a branch from aortic arch. Now the external and internal carotid artery, as I told you, this is also very important for MCQ, has been asked so many times in the previous year of examination. What is the level of bifurcation of common carotid artery into external and internal carotid artery? So if I talk about the bifurcation of common carotid artery into external and internal, this happens at the level of 4 cervical vertebra at the level of thyroid cartilage. So this gives us the right answer. Let's move on to the next question. That is question number 54. Okay, just a minute. I will just take few water. So actually this is an image based question. Let me slightly enlarge it. So here the proximal part of the femur has been shown. As you can see, the proximal part of the femur. You can see the femoral head here. You can see the femoral head. Okay, you can see the femoral head. You can see the femoral neck. You can also see the greater trochanter and the lesser trochanter. So the arrow is marked. In this case, the arrow is marked over the lesser trochanter. Okay, now you have to tell the muscle which is inserting into the lesser trochanter. So I would like to mark here A for psoas major, B for psoas minor, C for obturator internus, and D for piriformis muscle. So that means it is a question being asked for the osteology part. And so that is, if I talk about the osteology part, you have to know the muscles together inserting into the lesser trochanter of the femur. So the muscle which is together inserting into the lesser trochanter of femur is psoas major and iliacus muscle, is the psoas major and that of iliacus muscle which is inserting here. So exactly here I just want the right answer will be psoas major muscle here. Now, my dear, we have to talk about the explanation part. If I talk about psoas major muscle, it is divided into superficial and deep part. Okay, the superficial and deep part. So superficial deep part is arising from the lumbar vertebrae, that is from the transverse process of lumbar vertebra L1, L2, L3, and L4 and 5. Superficial is from L1, L2. Surfaces of the superficial is originating from lateral aspect of the last thoracic and also from L1 to L4 intervertebral disc. Now together, if I talk about psoas major and iliacus muscle, what about iliacus muscle? Iliacus muscle is originating from the iliac fossa of the hip bone, and together these two muscles having the origin above in the abdominal region here from the lumbar vertebrae and the hip bone, they will insert into the lesser trochanter of femur forming together forming together as the iliopsoas tendon. So these together inserts into, that means iliacus muscle plus the psoas major muscle tendon. This together inserts into the lesser trochanter of femur. So lesser trochanter of femur, so definitely the right answer is psoas major. Okay. Now, my dear, I just want you to show the another image for it so that you have a better idea for it. So you can see this is the, so let me just highlight. So you can see here, this is the, this is I for iliacus muscle. As you can see, this muscle is the psoas major, PM for psoas major muscle. So this muscle which you are seeing is the PM psoas major muscle, and this is the iliacus. Together they are inserting at this region. So together you can see it is inserting at this region. And what is this level called as? This is called as lesser trochanter of femur. This is called as lesser trochanter of femur, and that is the right answer. Now, let's move on to the incorrect options. I would also like to tell you about the incorrect option. So let's come up with the other options which is incorrect. Psoas minor, if I talk about psoas minor, it is not the right answer. What is the reason why it is not the right answer? Psoas major muscle originate from, it is originating from the thoracic and first lumbar vertebra, and insertion is occurring in the iliopectineal eminences. So it is not the right answer. If I talk about obturator internus muscle, it is the muscle which is actually arising from obturator membrane foramen, and it is traversing down, passing through the lesser sciatic foramen, ultimately inserts into the greater trochanter of femur, not into the lesser trochanter of femur which has been asked. It is inserting into the greater trochanter of femur, so it is also wrong. If I talk about piriformis muscle is the muscle which is aligned on the lesser pelvis, and it will insert also onto the greater trochanter, but it will insert into the greater trochanter superior aspect. So what we can see, piriformis muscle, obturator internus muscle is inserting to greater trochanter, not the lesser trochanter. So the wrong answer. Psoas minor is inserting along with the in iliopectineal eminences. So it is also wrong. So we have got the right answer, that is the psoas major muscle along with iliacus inserts onto the lesser trochanter of femur. Now I want everybody to concentrate for the next MCQ related to this topic, that is question number 55. So let's move on to the next question, that is question number 55. Mention the type of joint which is present in the marked region. So you have to mention the joint which is present in the marked region. So actually here again I will write A for ellipsoid, B for condylar, C for plane, and D for saddle. Now that means this is the arrow which has been, so you can see this is the yellow color arrow which has been shown. So you can see this is the yellow color arrow which has been marked in this joint, and this is which joint? This is the, this is actually first, this is actually first carpo, this is actually first carpo-metacarpal joint. So actually this is the first carpo-metacarpal joint, which is also called as the joint of thumb. So this is the thumb joint, first carpo-metacarpal joint, and the first carpo-metacarpal joint or the thumb joint is a type of saddle type of synovial joint. What type of joint is it? It is a saddle type of synovial joint. It is saddle type of synovial joint. So it is saddle type of synovial joint. So the right answer in this case will be definitely the saddle type of synovial joint. So we have got saddle type of synovial as the right answer. Ellipsoid is not the right answer. The best example ellipsoid joint is the wrist joint. Condylar, the condylar articulation between the medial and lateral femoral condyles of tibia and fibula. Also bicondylar joint is the TM joint. Plain type of joint is the intercarpal joint, intertarsal joint, acromioclavicular joint. So here the first carpo-metacarpal joint is the or we can say carpo-metacarpal joint of thumb, and it is the type of saddle type of synovial joint. Which type of joint is this? This is saddle type of synovial joint. Now it is also important for your examination that you should know the example of all type of joint. If I talk about saddle type of synovial joint, you should know other examples also, like sternoclavicular joint. Like incus and malleus articulation is an example of saddle type of articulation. So please write down. First carpo-metacarpal joint is the odd man out, which is saddle type of articulation. Rest all carpo-metacarpal joint is that of plain type of synovial joint. So that is written here. Now moving to the next option, I just want everybody to write down the example of saddle type of synovial joint. Examples of saddle type of synovial joint. Examples of saddle type of synovial joint. So if I talk about the examples of saddle type of synovial joint, the examples are following. So one of the example which was given in the MCQ, the other examples are, so we have got sternoclavicular joint, we have got sternoclavicular joint, we have got sternoclavicular joint, we have got, so the sternoclavicular joint is an example of it. Other joint are first carpo-metacarpal joint, first carpo-metacarpal joint, first carpo-metacarpal joint. Then we have got incudo-malleolar joint, incudo-malleolar joint. This is also the example of saddle type of articulation. And calcaneocuboid is also roughly saddle type of articulation. So also calcaneocuboid joint is also an example of roughly saddle type of articulation. These are the examples of saddle type of joints and articulation which you should know. So done with this. Now after that, let's talk about the next question. Okay, before that, I just want to strike out the wrong option. So why the other options are not correct? So you can see ellipsoid is not the right answer. The reason is that ellipsoid is a biaxial joint. Okay, so it is causing angular movement. And if I talk about ellipsoid joint, the basic example is the wrist joint, the metacarpophalangeal joint, the metatarsophalangeal joint. Condylar joint is basically similar to that of condylized joints of the TM joint, bicondylar joint, the knee joint, in which the condylar articulation. If I talk about whole of the compound complex knee joint, it is modified hinge joint. But if I talk only of condyloid articulation of femur and tibia, it is condylar joint. Plain type is not the right answer. The reason is that if I talk about plain type of synovial joint, the gliding movement is taking place in plain type of synovial joint. And the best example is acromioclavicular joint, intercarpal joint, and intertarsal joint. So done with this. Now let's move on to the next question. That is question number 56. So let's start with the question number 56. Now before that, yes, one more thing I just, before proceeding to the next one. Okay, so if I talk about the next one, so let's come up with this. So if I talk about the next MCQ, so it is important that you should know the classification of joints. So if I talk about the classing, let me just enlarge this. So we have got structural classification, we have got functional classification. So if I talk about structural classification of joint, we have got fibrous joint, we have got cartilaginous joint, we have got synovial joint. So we have got three categories. We have got synovial joint here, we have got cartilaginous joint, and we have got fibrous joint. Fibrous joint are non-mobile joint, and they are type of sutures of the skull are immobile joints. Slight movement can be occur in syndesmosis. So we have got three categories of we have got three categories, so just focus on this. So we have got three categories of structural fibrous joint. We have got sutural joints in the skull. We have got syndesmosis, like that is middle radio-ulnar joint, inferior tibiofibular joint. We have got gum forces also. Pagan socket joint, cartilaginous joint. We have got two varieties. We have got primary cartilaginous joint and we have got secondary cartilaginous joint. Primary cartilaginous joint, that is the articulation between epiphysis and diaphysis. If we talk about secondary cartilaginous joint, it is the pubic symphysis, intervertebral disc, all the joints in the midline. We have got synovial joint. In this, we have got highly mobile joints, and we have got gliding, hinge joint, ball and socket pivot. So example of gliding joints, plain type of synovial joint, intercarpal, intertarsal, hinge joint, elbow joint, ball and socket, glenohumeral joint, gleno hip joint. And the example of ball and socket like incus and stapes. Then we have got plantar calcaneonavicular joint also. Pivot joint, superior inferior radio-ulnar joint, atlantoaxial joint, ellipsoid joint, wrist joint, metacarpophalangeal joint, saddle joint. Just now I have already talked about sternoclavicular joint, first carpometacarpal joint. Now we have got diarthrosis, means they are highly mobile joint. Amphi means they can slightly move. Synarthrosis means not mobile joint. So done with this. Now let's move on to the next question. That is question number. So we will start with the next question. That is question number 56. Okay. So in this image, can you tell me the tendon being marked by the arrow? So there is an arrow which is marked on one of the tendons. So you can give me the right answer. In this image, the tendon is marked by the arrow. So you can see here, this is the black color arrow which is marked on this tendon, and it is more laterally. The hint is that it is more laterally because thumb, you can see it is laterally. So you have to identify this tendon, and the option is flexor carpi radialis, flexor carpi ulnaris, flexor digitorum profundus, palmaris longus. So definitely the right answer is flexor carpi radialis, and I will tell you why. Because flexor carpi ulnaris will be medially, flexor digitorum superficialis tendon will be 4. Palmaris longus is a degenerating muscle and not lying in more lateral aspect. So we have got flexor carpi radialis as the right answer. I just want everybody to concentrate on this. When I am talking about flexor carpi radialis, the marked muscle which is shown in the image is flexor carpi radialis. The tendon of flexor carpi radialis, if you will see the forearm in the anterior aspect, you can see the tendon being visible, and it is lying just proximal to the wrist. It is lying just proximal to the wrist. When the wrist is flexed, and its tendon is most lateral, and it is lying more close to that of the thumb. It is lying more close to that of the thumb. So that was the hint which was provided. So exactly that was the hint which was provided, and definitely that is the right answer. If I talk about flexor carpi ulnaris, it is wrong. Why it is wrong, my dear students? So the reason is that why it is wrong, I will tell you. The reason why it is wrong is the location. So if I talk about the location of flexor carpi ulnaris, it will be medially towards the little finger. Flexor digitorum profundus will have 4 tendons going superficially, and palmaris longus is actually middle one, and it is not lying more laterally as the flexor carpi radialis. So definitely all other options are wrong. Now I just want the tendon of flexor carpi. The important point about the tendon of flexor carpi radialis is that it is seen on the anterior aspect of the distal forearm. And what you can see, the most lateral tendon when you see the anterior aspect of forearm is flexor carpi radialis, and in the middle we have got palmaris longus. So the two tendons, if you see the image also, 2 tendons was seen in the image. So the lateral tendon was Lateral tendon which was lying through the thumb was flexor carpi radialis tendon, and the middle tendon which we are seeing here was the palmaris longus tendon. Now I just want you to show an image for it, so you can see this image. In this you can see exactly the tendon of flexor carpi radialis is shown here, and the tendon of palmaris longus is also shown. The tendon of flexor carpi radialis is lying laterally close to the thumb, and it is lying in the middle. Now I just want also for you to concentrate on a cadaveric image. So see here, अगर हम cadaveric image की बात करें तो you can see this cadaveric image. So yes, so if you will see the cadaveric image, you can see the tendon of palmaris longus tendon is merging with palmar aponeurosis. It is merging with palmar aponeurosis, and we have got the tendon of flexor carpi radialis lying lateral to it. So this is the tendon of flexor carpi radialis which is lying exactly radial to it, and we have also have an artery here. So if you will see the artery, so exactly you can see this is the artery, this is the ulnar artery which is shown here, which has been shown and which is lying more if we talk about no, this is the radial artery, sorry, this is the lateral side, then it is radial artery, and sorry, here we have got the ulnar artery. And also deeper to it you can see the nerve. So exactly, I will use this. So exactly you can see this is the nerve. Which nerve is this? This is the median nerve which is passing deep to flexor retiniculum. And here I just want everybody to understand this. This artery which you are seeing on the medial aspect is the ulnar artery. And here on the lateral aspect is the radial artery. And the tendon which is seen lateral to that of palmaris longus tendon, that tendon is the flexor carpi radialis. So let's move on to the next, that is question number 57. Which artery passes in close proximity to, which artery passes in close proximity to the area of the skull as shown in this image? So again, I want to analyze this. This is A option, this is B, this is C, and this is D. Okay, so 4 options are given: anterior cerebral artery, internal carotid artery, middle meningeal artery, and deep temporal artery. So I just want everybody to see this image. As you can see, this is the image which has been shown. So you have to identify. So actually you have to identify this junction. So this is pterion. What is it? This is pterion. Here 4 bones. This is H-shaped suture. This is H-shaped suture. And at this level, 4 bones are meeting. 4 bones are meeting. So which bone is this? This is the frontal bone. This is the parietal bone. This is the temporal bone squamous part, and this is the S for sphenoid bone. So 4 bones are meeting at this suture, that is H-shaped suture, that is pterion. And on this level, deeper aspect, we have got the middle meningeal artery anterior trunk. So exactly in this diagram, you can see exactly this is the pterion which I have already explained. And these are the sutures which has been seen. This is the frontal, parietal, temporal, and sphenoid. And at this level, we have got an important artery which is located at this level. So see here, at the level of pterion, we have got an important artery located, and that artery is called as middle meningeal artery. That artery is called as middle meningeal artery. And middle meningeal, if I talk about middle meningeal artery, the middle meningeal artery anterior trunk, middle meningeal artery anterior trunk is located at this level. So if I talk about middle meningeal artery, anterior trunk is located at this level. Now, let's talk about, so we have got the right answer C, middle meningeal artery anterior trunk is located at the level of pterion. Now talking about the other option, why other options are wrong. So let us come into the explanation of other options. So we can see anterior cerebral artery. If I talk about anterior cerebral artery, is definitely not the right answer. The reason is that anterior cerebral artery is a major artery which is giving arterial supply to the medial surface of the brain. And it is actually it is an important branch from the internal carotid artery, and it is giving majorly blood supply to the medial surface of the brain. It is not located at the level of pterion. If I talk about internal carotid artery, which is one of the terminal branch of common carotid artery. So if I talk about this common carotid artery, it has got two branches. It is having external carotid artery and it is having an internal carotid artery. Internal carotid artery is giving blood supply to the interior. It is giving blood supply to the interior of the brain. External carotid artery is giving blood supply to the head and neck region. And internal carotid artery is not exactly located at the level of pterion. Deep temporal artery is having anterior, posterior, medial branches, and it is exactly located on the it is located between temporalis muscle and pericranium. So exactly this is also not located at the level of pterion. Now, if we talk about middle meningeal artery, clinically it is a very important for you to understand the clinical anatomy of middle meningeal artery. Middle meningeal artery is a branch of, अगर हम middle meningeal artery की बात करें तो middle meningeal artery is a branch of first part of maxillary artery. It is a branch of first part of maxillary artery. It's a branch of first part of maxillary artery, and it is traversing through the pterion level. It will pass through the foramen spinosum of that of the cranial foramen, will traverse and supply dura mater meningeal level, and it is having two branches. One is anterior and the posterior. Anterior is lying at the level of pterion. The anterior branch of middle meningeal artery lies at the level of pterion, and if it is a direct, actually in case of cranial dura, there is no epidural space. अगर हम cranial dura की बात करें तो there is no epidural space. If there is a direct hit on the lateral aspect of the skull, it can lead to the injury of middle meningeal artery anterior trunk and can lead to bleeding, and then can lead to extradural hematoma or epidural hematoma, which will have a lucid interval. So that is the reason we will mark here the right answer as middle meningeal artery. Now let's come up with the next question, that is question number 58. So let me read this question for you, question number 58. A 43-year-old woman is admitted to the hospital of deep abdominal pain. So what is the complaint of the woman? She is having deep abdominal pain. She is having deep abdominal pain, and exact location of deep abdominal pain is occurring in the epigastric region. Okay, so that location of the pain is epigastric region. Please highlight this. Abdominal pain is occurring at the epigastric region. On examination, it is observed that retroperitoneal infections erode the artery that is running along the superior border of pancreas. That is running along which border of the pancreas? Though exactly this is running along. So the artery which is, so relation of artery is, it runs along the superior border of pancreas. So that is the hint for identifying which of the following artery is likely to be injured. Whether the artery is right gastric artery, left gastroepiploic artery, splenic artery, or gastroduodenal artery. So definitely the right answer is splenic artery. I will show you an image for it. Actually, when you see the pancreas, body of pancreas on the superior aspect is having the tortuous splenic artery, which will go towards the hilum of the spleen. So I will just want to show you this image. So if you will see this image, what you can see, this is the pancreas. Okay, so here this is the superior border of pancreas, and just above the superior border of pancreas, you can see, just above the superior border of pancreas, you can see the splenic artery is there. So this is the splenic artery which is located just above, and so definitely the ligation here will be of splenic artery, because splenic artery is the right answer as it is running on the superior aspect or the of the pancreas superior border. So that is the right answer. So definitely the correct answer is splenic artery. Right gastric artery is the wrong option. Why? Because it is running along the lesser curvature, anastomosing with the left gastric artery in the lesser omentum. Right gastroepiploic artery runs along the greater curvature, right lies in the greater omentum, anastomose with the left gastroepiploic artery. Gastroduodenal artery will again give branches at right gastroepiploic artery, which will give blood supply to the to that of the right gastroepiploic artery through the greater curvature of the stomach. So I just want, splenic artery is one of a largest. If I talk about splenic artery, it is the largest branch of the celiac trunk. It runs along the superior border of the pancreas and enters the spleen through. So it is traversing into the spleen and running through lino-renal ligament, and it reaches the hilum of the spleen. So it is a constituent of lino-renal ligament. What is lino-renal ligament? Lino-renal ligament is connecting the spleen and the renal, connecting the spleen and the kidneys. If I talk about right gastric artery, it is wrong. The right gastric artery is the wrong answer. Why? It is not running on the superior aspect of the pancreas. It is running in the lesser curvature, and the left gastroepiploic artery is also going towards the right greater curvature of the stomach. The gastroduodenal artery will give blood supply to the first part of duodenum, and it is also giving another branch, that is right gastroepiploic artery, which is anastomosing with the left gastroepiploic artery along the greater curvature of the stomach. Dorsal pancreatic artery descends behind the neck of pancreas, so this is also not the right answer. So after seeing this image and discussion of all the branches, it is quite clear the artery which will be affected in this condition will be the splenic artery, because it is related with the superior aspect of the pancreas running in lino-renal ligament and ultimately reaches the hilum of the spleen. So let's move on to the next question. That is question number 59. So firstly, let me read the question for you. Question number 59. A 15-year-old boy comes to the OPD. He is not feeling any sensation in the sole of the foot. He is not feeling any kind of sensation in the sole of the foot. Examination reveals, when the examination is done, what happens? It is revealing that the paralysis of the medial side of the plantar muscles of the foot has happened. Which of the following nerve is most likely injured in this case? So यहाँ पे जो hint है और the keywords है जो हमें mark out करनी है, sensation of the sole of foot. Sensation of the sole of foot is a very important point which you have to keep in mind. And we know that sole of foot में sensation medial और lateral plantar nerve से होता है. And this medial and lateral plantar nerve is a branch of, tibial nerve. Examination is showing paralysis of medial side of plantar muscle. So there is also the plantar muscles which is paralyzed. तो एग्जैक्टली अगर हम इस क्वेश्चन के बारे में बात करेंगे तो सोल ऑफ द फुट तो गया ही है, plantar muscles are gone, so the correct answer in this is tibial nerve. So tibial nerve is the right answer here. Now deep peroneal nerve is not the right answer. Basically it is giving innervation to anterior compartment of leg. Sciatic nerve is giving innervation to, actually sciatic nerve is lying on the it's giving innervation. It is having two branches. One is the tibial, another is common peroneal component. And if I talk about the tibial component, it is giving innervation to posterior compartment of thigh. That is hamstring muscle. Superficial peroneal nerve is not the right answer. Why? Superficial peroneal nerve is the nerve of lateral compartment. Is the nerve of lateral compartment of leg. So let's come up with the option. So here tibial nerve is the right answer because the muscles of the foot is mainly supplied by medial and lateral plantar nerve. And we know that both these medial and lateral plantar nerves are the branch of tibial nerve. So this is medial and lateral plantar nerve, and we know that these medial and lateral plantar nerves are the branch of tibial nerve. So muscles and the skin of the sole is getting innervation from medial and lateral plantar nerve. Deep peroneal nerve is not the right answer as it's the nerve of the anterior compartment. Superficial peroneal nerve is the nerve of lateral compartment of the leg. अगर हमारा superficial peroneal nerve injury होती है तो all the muscle which is lying in the lateral compartment of leg, that is peroneus longus, peroneus brevis, will not functioning, and the evertus of the foot is paralyzed. Deep peroneal nerve में all the dorsiflexor of the foot is paralyzed and that will be lost. But if this case यहाँ पे sole muscle is affected, and we know that via the medial and lateral plantar nerve, branch of tibial nerve, the innervation is done. So that if I talk about the tibial nerve, so basically tibial nerve is giving innervation to, if I talk about tibial nerve, it is basically giving innervation to the sole muscle and the muscles of posterior compartment of the leg. So that is the reason we will mark it as the tibial nerve as the right answer. Okay. So what I feel, so I will just give you a break of few seconds. So, okay, no worries. It's okay. It was just a lag of few seconds. Is it okay? Just so everyone is able to See me once again, or the screen was already working only. So see me once again. Okay. So no worries. I wanted to complete one or two questions more, so only. So let's see with the next option. Let's see with the next option, that is question number 60. Let's see with the next question number 60. So let's start with the question number 60. So let me read it for you. A 34-year-old man is pushing some heavy weights during the squat. ठीक है, स्क्वाट में heavy weights lift कर रहे हैं. Unfortunately, while mixing out, he drops the weight and immediately grabs his upper thigh, breathing in pain. बहुत pain हो रहा है. Okay. The man is admitted to the emergency department and during the physical examination, he is diagnosed with a case of femoral hernia. So this is a case of femoral hernia. So what is the reference structure which will found immediately lateral to this herniated structure? So exactly, if I talk about what reference structures could be found immediately lateral to this herniated structure, that is important for you to understand. So options which is given here is femoral hernia, femoral artery, pectineus muscle, and that of femoral. So 4 options are there. And exactly the case which is identified is the femoral hernia. So femoral hernia protrude करेगा एक space से, it will be protruding from one of the space which is the femoral canal. The upper border of femoral canal is the, if I talk about upper border of femoral canal, it is the femoral ring. So we have to know the structure which is exactly lying lateral to this femoral canal. So that means you should have an idea of femoral sheath. We know that femoral sheath is having 3 compartments: medial, intermediate, and lateral. So the medial most compartment of femoral canal is femoral. The medial most compartment of femoral sheath is femoral canal, and the upper border of femoral canal is femoral ring. So femoral herniation occurs through femoral canal, and femoral vein is lying lateral to it. So the correct answer is femoral vein. I would like to show you this image. So exactly femoral hernia, or we know that femoral, if I talk about femoral hernia, the abdominal contents are traversing through femoral ring, and we know exactly the femoral ring is lying lateral to, so exactly अगर हम femoral ring और canal की बात करें तो medially we have got the lacunar ligament, and laterally we have got the femoral vein. So femoral ring is having 2 important structures. So if we talk about medially, it is having lacunar ligament which is dissected out or which has been cut out in case of the treatment of strangulated hernia. If I talk about femoral ring, lateral to it lies the femoral vein. Now, femoral vein is found lateral to that of femoral hernia, so we have marked it as the right answer. Now, adductor longus muscle as the pectineus muscle lying deep to this hernia. So exactly, I would like to show you this image. So all of you just see this image. I'm highlighting this image. When I'm highlighting it, you can understand. Here you can see the sac of indirect inguinal hernia, which is not the question to be asked. Here the question was asked about femoral hernia. And we know that femoral hernia, the herniation occurs through this circular area, and what is that? That is femoral canal. It occurs via femoral canal, and you can write the upper border of femoral canal, the upper border of femoral canal is formed by femoral ring, and the herniated loop is traversing through this canal. So we have got femoral vein, so you can see here, I will just use blue color for the vein, and we have this as an artery. So you can see here femoral vein is just lateral to it. So if I talk about femoral sheath, the lateral most content is having femoral artery, the intermediate content of femoral sheath is femoral vein, and medial content is femoral canal. Okay, so that is the right answer here. And I would also like to tell you about inguinal hernia. It is important that you should also have an idea of inguinal. So these femoral artery is lying more lateral. pectineus and femoral nerve is almost, it is not a content of femoral sheath. Pectineus muscle is lying deeper to it. So exactly agar herniation ki baat kare, if I talk about the herniation, so what you can see, please write down this important point. So if I am talking about femoral, so just a minute, please have a details of it. So if I talk about this herniation, femoral sheath, I just want everybody to understand femoral sheath. Actually, femoral sheath has got an anterior wall. And if I talk about anterior wall of femoral sheath, it is formed by, anterior wall of femoral sheath is formed by fascia iliaca, fascia transversalis and iliaca. And posteriorly, we have got fascia iliaca also. But what is very important is to know the content which has been asked. So what I want everybody to concentrate here is the content. So let's talk about the content. So for the content, it is divided into 3 compartments. It is divided into 3 compartments. So if I talk about the lateral compartment, from the lateral compartment, 2 structures are passing. Femoral branch of genitofemoral nerve and femoral artery. Got it? This is the lateral compartment. If I talk about intermediate compartment, the structures passing through intermediate compartment. So if I talk about intermediate compartment, the structures passing is femoral vein. And if I talk about medial compartment, if I talk about medial compartment of femoral sheath, through the medial compartment of femoral sheath, the structure passing is deep inguinal lymph node, So this is briefly which I told you about the 3 sheaths and their structures lying. One more thing I just want everybody to understand, also inguinal hernias, which I want to talk. So let's see. If I talk about direct inguinal hernia, so direct inguinal hernia protrude out through Hazel-Back triangle, which is also called as inguinal triangle. And this protrusion is medial to inferior epigastric vessel. This protrusion is medial to inferior epigastric vessels. I just want everybody to understand this is a class of 1 day, and these all 100 questions and 100 topics are extremely important if you want to crack your upcoming exam on the 6th July FMG exam. So if I talk about indirect inguinal hernia, if I talk about indirect inguinal hernia, so indirect inguinal hernia is the protrusion which is seen. This protrusion is from the deep inguinal, this is via deep inguinal ring or inguinal canal, and this protrusion of it occurring, this protrusion is occurring, indirect inguinal hernia, the protrusion of herniated loop is occurring lateral to inferior epigastric vessel. It is occurring lateral to inferior epigastric vessel. So done. So we have done with this. It's a very important thing, and all these details are highly important for you. So now thereafter we will start with the next MCQ. So I hope everything is clear to you. So I just want to give you a break. So for a lunch break. So I will write it also if you want. So I just want to show you the screen. Yeah. So I just want, please note down lunch break. Okay, this is the lunch break. So we will exactly so exactly if I talk about this break, so we can exactly resume again by 3:50 or 4. Is it okay? So we can resume at 4 p.m. So I can just, we will resume at 4 p.m. Those who are live, they can understand. So now there is a lunch break. Resume shortly. So we are resuming shortly exactly at 4 p.m. Is it okay? Any doubts? So I would like to tell that you should go through all these things which will highly important for you. Thank you so much. नीचे लगाते रहो। नीचे का नहीं ऑन करना है क्या? ऊपर कौन करना है भाई प्लीज। ठीक से ओहो let me see camera. Okay, hello everyone, am I audible? So let's start with the session. Am I audible? Please do check so that we can start the session now. Let me just check with the session. That's okay. Okay, we can start the session now. So everyone, let's start with, we have completed till 60 questions, no? So we have completed till 60 questions. So let's start with the session. So coming to the question number 61. So coming with the question number 61. So let's start with this. So let me read the 61 question for you so that we can start the description of it. Question number 61. A 35-year-old man A 35-year-old man complains to his physician that he feels congested. So he is feeling congestion, he has trouble with the nasal bleeding and is expecting a yellowish discharge of mucus charge. Yellowish mucus discharge is there. He also mentions that his right side upper molar teeth ache is terrible. The discharge from this sinus initially drains into the nasal cavity, at which of the following labeled points with the discharge from the lateral wall will occur. So the key feature is that, let's see the key features in this condition. So if I talk about the key features, what we feel that the person is having problem with the nasal breathing and experiencing a yellowish nasal mucus discharge. The person is having nasal breathing and a yellowish mucus nasal discharge is there. He also complains of upper molar tooth ache is terrible. So exactly, अगर हम बात करें तो discharge of this sinus initially drains into the nasal cavity. So actually what happens, the most common sinus to be involved. So we have to search for the most common sinus to be involved. This is also causing upper molar tooth being involved. So that is how we are going to understand this. So if we talk about that, we have to just enlarge this image, and when I am enlarging it, what you can see the lateral wall of the nose, which is having A, B, C and D. These are the lateral wall of the nose, which is showing the various sinuses which is opening into it. So we have to identify exactly the maxillary sinus. So here A is not the maxillary sinus. Why? Because A will be the opening for sphenoethmoidal recesses. B will be the opening for the posterior ethmoidal sinus, and that of D is nasolacrimal duct, and C will be the right answer. So in this case, we will have C as the right answer because C is the maxillary air sinus opening. So you can write A is sphenoethmoidal recesses. A is sphenoethmoidal recesses. Then D is the opening for the nasolacrimal duct, duct. And C will be the opening of maxillary air sinus. And B will be the opening of posterior ethmoidal air sinus. Posterior ethmoidal air sinus. Posterior ethmoidal air sinus. Okay, so these are all the sinuses which is opening into it. Now, maxillary sinus, if I talk about maxillary sinus, that is the right answer. Maxillary sinus is the largest paranasal sinus. Is the largest paranasal sinus which is occupying much of the maxillary bone. And infection, if the maxillary air sinus is infected, if I talk about the maxillary air sinus being infected, what will happen? If the maxillary air sinus is infected, there can be a terrible pain which is affecting the upper teeth, causing toothache, because the sinus is separated from the roots of the teeth by a very thin layer of the bone. The maxillary sinus open into the most posterior part of the, it's also important that you should understand where is the maxillary sinus opening. So it is opening in the most posterior part of the semilunar hiatus. The frontal, anterior ethmoidal, middle ethmoidal sinus are not opening exactly. अगर हम middle meatus की बात करें तो frontal, anterior and middle ethmoidal air sinus is also opening close to it. So I just want everybody to see this image. So if you will see this image, you can understand the openings. So here we can see in sphenoidal air sinus opening here in the sphenoethmoidal recesses. Superior meatus में open होता है posterior ethmoidal air sinus, and in the middle meatus on the bulla we have got the opening of middle ethmoidal air sinus. On the hiatus semilunaris, maxillary air sinus, frontal air sinus, and anterior ethmoidal air sinus, and opening of nasolacrimal duct is in the inferior meatus. So done with this. So obviously A is wrong answer because A is sphenoethmoidal recesses. B is wrong because B is superior ethmoidal sinus, as we can see. And we have D as the nasolacrimal duct, which is opening into the inferior meatus. So all these are wrong option. We have got the right answer as maxillary air sinus. Let's move on to the next question. That is, so let's start with the next question. That is question number 62. So firstly, I would like to read the MCQ for you. So let's start with that. A 7-year-old boy is having Down syndrome, and they underwent a surgery to repair a congenital ventricular septal defect. So here the keywords is the boy is having Down syndrome. The boy is suffering with Down syndrome, and the boy has underwent a surgery to repair congenital ventricular septal defect. During the procedure, there is injury to the coronary artery, which is supplying the conducting system of the heart, including sino-arterial and arterioventricular node. So basically, the important structures which is injured here, there is SA node which is involved, and there is AV node which is involved. So SA node and AV node is involved here, and that will result in heart attack. So which artery in the given picture is most likely to damaged by the surgeon? So exactly we have to see the high power view. So exactly enlarged view of this image, and firstly we have to identify the arteries here. So basically important है कि हम arteries को so basically अगर हम SA node और AV node की बात करते हैं, SA node and AV node in most of the context, if I talk about the 60% of the cases, the SA node is giving innervation. In most of the content, if I'm talking about, SA node is getting blood supply from right coronary artery branches. AV node is also in 80 to 90% of cases blood supplies from right coronary. So we have to identify the right coronary artery, and that is A. Right coronary artery is A, so that is the right answer. Okay, so that is important for you to understand. So if I talk about right coronary artery, it gives branches to SA node and AV node. So basically in 60% of the cases, SA node is getting arterial supply from right coronary artery, and is 80% of the cases, or approximately more than 80% of the cases also, AV node is getting arterial supply from the source of right coronary artery. So if there is injury of the right coronary artery, then there is more chance of heart block, because the conducting part of the heart can be affected, that is SA node and AV node. So here I just want you to tell the other arteries, as you can see here, not involved. So we have got right coronary artery here. We have got, this is the C is the LAD artery, this is the circumflex artery. These are the branches from the right coronary arteries only. So basically the main source of the artery which has been seen in this image is the right coronary artery, and the artery being affected in this case for the question number 62 is right coronary artery. Okay, so you have to just make it clear that most of the time the conducting system of the heart containing of SA node and AV node is getting its arterial supply from the source of right coronary artery. Now let's move on to the next question, that is question number 63. So basically, let's move on with this question. Which of the following structures do not take part in formation of marked structure? Okay, so it is not involved in formation of marked structure, that is important. So you just can enlarge this. So when we are enlarging this, what you can see, this is exactly. So if I enlarge this, what you can see, this is exactly. So this is exactly perineal body. What is it? This is PV. What do you mean by PV? This is perineal body. So important muscles are converging it. So what you have to identify is the perineal body, and you can see important muscles are converging at this point. So here we have got transverse. What is this? This is the transverse. This is the transverse perineal muscle. So we have got two superficial transverse perineal muscle. We have got two deep transverse perineal muscle. We have got here. This is the bulbospongiosus muscle. This is bulbo spongiosus muscle. These are transverse perineal muscle. These are the either side levator ani muscle. So LA for levator ani, and this is external anal sphincter. So exactly 10 muscles are interlacing at the point of perineal body. So exactly we have to mark the answer. Which of the following is not interlacing and taking formation of perineal body? External anal sphincter, bulbospongiosus, superficial transverse peri, ischio-cavernous. So exactly ischio-cavernous is the right answer, which is not exactly interlacing at the point of perineal body. So for better understanding, I just want you to show this image. So when you see this image, you can better understand about the perineal body and what all structures are. So exactly agar hum baat kare, 10 muscles are interlacing at this point. So what is this area which I am highlighting it? This is the perineal body. This area is the perineal body. What is this? This is the perineal body. So you can write PV for perineal body. Now you can see here, these are the two transverse muscle. So here we have got superficial transverse muscle of either side, and here here if I talk about superficial transverse muscle, deep to the superficial transverse muscle, we have got two deep transverse muscle. Okay, here we have got bulbospongious muscle. So we have got two muscles on either side. This is the two bulbospongious muscles. That means bulbospongiosus muscle, the deep and superficial. So we have got two superficial transverse perineal muscle, we have got two deep transverse perineal muscle, we have got two bulbospongiosus muscle, and we have got levator ani muscle of either side which is interlacing, and we have got external anal sphincter also lacing, and we have got external anal sphincter which is also lacing. So we have got two levator ani muscle, one external anal sphincter, and this muscle which you are seeing is the ischio-cavernous muscle which is not interlacing at the level of perineal body. So I want to write the list of the muscle which interlaces at the level. So I just want to, so all of you can write muscles included, you can say muscle included or interlacing at the level of perineal body. Interlacing included, that means interlacing in perineal body. In perineal body are following. So you have to know the list of the muscles which is interlacing, and as I told you, how many muscles are interlacing? We have got 10 muscles which are interlacing. So that muscles are, please write on the name, that muscles are, we have got two superficial transverse perineal muscle, two superficial transverse perineal muscle, two superficial transverse perineal muscle. We have got two deep transverse perineal muscle, two deep transverse perineal muscle, two deep transverse perineal muscles. Then we have got two levator ani muscle of either side, two levator Any muscle of either side, two levator any muscle of either side. We have got two bulbospongiosus muscle. And we have got one external anal sphincter, one external anal sphincter. One external anal sphincter muscle. And we have got one longitudinal muscle coat of, one longitudinal muscle coat of rectum and anal canal, rectum and that of anal canal. So altogether how many muscles? So altogether this becomes a total of 10 muscles. So how many? Altogether this becomes 10 muscle interlacing at the level of perineal body. So definitely ischio-cavernous is the right answer, and the reason why ischio-cavernous is the right answer, because it is not leading to the formation of fibromuscular perineal body, which is exactly lying at the junction of urogenital, which is exactly lying at the junction of urogenital and anal triangle. Okay, so and these all muscles are included, so definitely ischio-cavernous is the right answer. In women, if I talk about the women's, in women it acts as a tear resistant structure which is lying between the vagina and that of external anal sphincter. It is exactly lying between the vagina and external anal sphincter. It is supporting the posterior part of the vaginal wall against prolapse, and in the male it lies between the bulb of penis and the anus. Exactly, it is lying between the bulb of penis and anus. Done. Let's move on to the next. Question number 64. Which muscle is supplied by the marked nerve? Which muscle is supplied by the marked nerve? So here A, this will be A, this will be B, this will be C, and this will be D. Which muscle is supplied by marked nerve? So we have got four options. As you can see, we have got four options. We have got tibialis anterior, we have got tibialis posterior, we have got biceps femoris short head, we have got biceps femoris long head. So exactly which muscle is supplied? So exactly you can see this is an image. Again, I want you to show this image. So if you will see this image, how we are going to come up with the right answer, as I will explain you. We can understand the right answer by, this is the femur bone. This is the femur bone, that is the lower end of the femur bone is there. This is the femur bone, the condyles of the femur bone has been shown. Also here you can see this is the patella bone. Now here you can see this is the condyles of the femur articulate with the condyles of tibia. So what is this? This is the tibia bone, and this is F fibula bone. This is the fibula. Now what you can see exactly, that means if we are talking about this, what you can see, this is the neck of fibula. What is this? This structure is the neck of fibula. So around the neck of fibula, if we talk around the neck of fibula, the nerve which is winding is the common peroneal nerve. Around the neck of fibula, the nerve which is winding is common peroneal nerve which is winding, and injury to common peroneal nerve will lead to the will lead to the paralysis of the muscle. So the muscles being paralyzed is short head of. The correct answer will be the short head of biceps femoris. Why short head of biceps femoris? I will tell you. The reason is that the sciatic nerve is having, I just want everybody to understand this point. Actually, if I talk about sciatic nerve, which is the thickest nerve of our body, sciatic nerve is the thickest nerve of body. It is having two components. It is having two components. One is the tibial nerve, and the other component is common peroneal nerve. Common peroneal nerve. So actually the tibial component of, if I talk about the tibial component of sciatic nerve, it is an important nerve which is giving innervation to all the muscles of posterior compartment of thigh. So tibial nerve, or you can say tibial component of sciatic nerve, innervates hamstring muscle, posterior muscles of the thigh. So it is innervating posterior muscles of the thigh. What does that mean? It means they are innervating the hamstring muscle. And we know that hamstring muscles are, we have got semi-membranosus muscle in this category. So we have got semi-membranosus muscle in this category. We have got semi-tendinosus muscle in this category. We have got semi-membranosus, semi-tendinosus. We have got hamstring part of, or ischial part of, adductor magnus muscle, hamstring part of adductor magnus muscle. and we have got long head of biceps brachii, and we have got long head of biceps brachii, long head of biceps brachii, long head of biceps femoris. So what does that mean? That means these are the four nerves which is forming the hamstring muscle, which is getting innervation from tibial component of sciatic nerve. Now what about the common peroneal component? If I talk about common peroneal component, if I talk about common peroneal component of sciatic nerve, the common peroneal component of sciatic nerve is giving innervation to just one muscle, that is short head of biceps femoris. That is the short head of biceps femoris. So the right answer will be short head of biceps femoris, which is innervated by. The right answer will be short head of biceps femoris, which is innervated by the common peroneal component of sciatic nerve. So done with this, we have got the right answer here. So let's move on to the next, that is question number 65. So if so let me just read the MCQ for you, then we will come up with the explanation. So exactly, I have written this. I just want to rub this. We are already knowing this. Okay, coming to the question number 65. So let me read the MCQ for you. During a surgery to remove the gallbladder, that is called as cholecystectomy. That surgery is named as cholecystectomy. A surgery resident damages cystic artery. So what was the injury done by the surgery resident? Damage to cystic artery. Before the clamp is properly placed, the attending physician applies pressure to the free edge of the hepatoduodenal ligament of the lesser omentum to control the bleeding until the damaged artery is clamped and ligated. So which of the following arteries was compressed by the attending physician? Whether the artery compressed is the celiac artery, is the splenic artery, is the gastroduodenal artery, or proper hepatic artery, or the proper hepatic artery. So exactly यहाँ पे जो सर्जरी हुई है उसमें गॉल ब्लैडर cholecystectomy की गई है. So we have got cholecystectomy of the gallbladder which has been done, and damage is done to cystic artery. And which ligament is approached for applying pressure to control the bleeding? So we have approached the hepatoduodenal part of the lesser omentum to control the bleeding. Now the question is asked, which artery is compressed? So that means how we are coming to the right answer in this case. For approaching to the right answer in this case, we have got a hint that the artery which is compressed is lying in the hepatoduodenal ligament. And if you remember, I have already explained to you about the content of hepatoduodenal ligament. We know that lesser omentum is having two components. One is the hepatoduodenal ligament, and another is the hepatogastric ligament. Hepatoduodenal ligament is having three structures. It is having portal vein, it is having bile duct, it is having proper hepatic artery. So the right answer will be proper hepatic artery, which is ligated in this condition. Now, I just want you to show this image. So if you will see this image, what you can see, the lesser omentum content you can see. So lesser omentum content, lesser omentum की बात करें तो if we are talking about the lesser omentum, I just want you to show, right, two important. It is having hepatogastric ligament. It has got two ligaments. Hepatogastric ligament will contain right and left gastric artery, anastomosis mainly, and also the gastric nerve. And if I talk about hepatoduodenal ligament, if we talk about hepatoduodenal ligament, that will contain three important structures. That is portal vein on the posterior aspect, that is hepatic artery anteriorly and to the left side, bile duct anteriorly and to the right side. So here that means in this case the proper hepatic artery was compressed to control the bleeding. Also proper hepatic artery has the source. If we talk about celiac trunk, it gives three direct branches. It gives splenic artery as a direct branch. It gives common hepatic artery as a direct branch, and it gives left gastric artery as a direct branch. Common hepatic artery will divide into proper hepatic artery and then right and the left hepatic artery. So proper hepatic artery is ligated to control the bleeding. So definitely proper hepatic artery is the right answer. So in this case, definitely proper hepatic artery is the right answer. So this is very, very important that you should understand that lesser omentum is having two parts. Lesser omentum is having two parts. One is hepatogastric and other is hepatoduodenal ligament, and you have to know the contents of each individual part of this structure. So celiac trunk, splenic artery and gastroduodenal is not the right answer because they are not the content of the hepatoduodenal ligament. So let's move on to the next question, that is question number 66. A 68-year-old man is brought to the emergency room after being attacked in his office by this disgruntled co-worker. Okay, the co-worker has attacked the person. The attacker reportedly tell that a long narrow blade leather reopener is inflicted and multiple stab wounds to the man's back has been applied. Physical examination shows puncture wound is involving, so this is the keyword, it is involving posterior axillary fold. What it is involving? It is involving posterior axillary fold. The patient presents with weakness. After that involvement, the patient is presenting with a weakness, and that weakness is involving extension, adduction and medial rotation. So that means the muscle which is involved is having an action of adduction of arm, medial rotation of arm or shoulder and extension of his arm. So you have to tell me which muscle is injured in this case. So for understanding this, two hints are provided. Ek hint to hai कि posterior axillary fold is involved. The other hint is the action of the muscle has been given. So the correct answer is latissimus dorsi. Actually, latissimus dorsi is forming posterior axillary fold. And if I talk about latissimus dorsi muscle, the action of latissimus dorsi muscle is, it is causing medial rotation, adduction and extension of arm. Actually, this action of latissimus dorsi, which is adduction, medial rotation, is the composite action. It is also called as climber muscle, and latissimus dorsi is involved in this case. So two hints were provided in the MCQ. One was the action, another was this muscle is forming the posterior axillary fold. The other thing which was told is this muscle is forming the posterior axillary fold. So definitely we have got here B as the right answer. Now moving to, so I just want everybody to see this image, because in this image you can have the idea of the content of axilla and the walls of the axilla. So you can see a transverse section showing the content and the walls of axilla. So here we can see this is anterior. The anteriorly the axilla is having pectoralis major and minor, and also part of subclavius muscle which is forming anterior wall. Here if we talk about posterior aspect, posteriorly we have got subscapularis latissimus dorsi muscle is there, and teres major, and also on the lateral aspect we have got coracobrachialis and biceps brachii. Medially we have got serratus anterior muscle. So serratus anterior muscle is forming medial boundary. So that means medially the axilla boundary is formed by serratus anterior muscle, that is forming the lateral wall of thorax. Anteriorly, the muscles of pectoral region. Posteriorly, the subscapularis muscle and latissimus dorsi teres major. Laterally, the muscles of arm, that is coracobrachialis and biceps brachii. The content which is residing inside will be, the content is axillary artery. We will have the axillary vein, and we will have the cords of brachial plexus. So we will have the lymph nodes, and we will have the cords of brachial plexus. So another content is the cords of brachial plexus, also long thoracic nerve, and we will have the cords of brachial plexus. So all the three, that means all the cords of brachial plexus. So we have got posterior cord, medial cord and lateral cord of brachial plexus, which is also forming the content of axilla. So basically we have to understand the walls and the contents for solving this correct question. So other than that, latissimus dorsi is the action which is giving us the other hint. Pectoralis minor is not the right answer because it is forming anterior axillary, it is anterior axillary fold, and it is actually having the action of stabilizing the clavicle. It is supporting the action of serratus anterior. Levator scapulae has got an action of elevation of the scapula. Serratus anterior is a boxer muscle and it is protractor of the scapula. So definitely the right answer will be latissimus dorsi. Okay, let's move on to the next question. That is question number 60. Okay, so in this contents we have taken two questions. So Broca's area. So the next question is Broca's area. So you have to tell Broca's area is situated in which of the following area, whether it is situated in inferior frontal gyrus. Broca's area is situated in the inferior frontal gyrus. So whether it is situated in inferior frontal gyrus, whether it is situated in the superior temporal gyrus, whether it is situated in inferior temporal, superior temporal, or angular gyrus. So actually, Broca's area, that is motor speech area, is located in area that is pars opercularis and pars triangularis in inferior frontal gyrus. So definitely A is the right answer. Okay. So exactly, I just want to enlarge this image. So when I'm enlarging this image, you can see the highlighted yellow color area is showing the area of Broca's area. So here, this is inferior frontal gyrus. Which area is this? So definitely this area is inferior frontal gyrus. And in inferior frontal gyrus, we have got pars triangularis, we have got the pars opercularis. So area number 44, 45, these are the areas which is the motor speech area, and this is the Broca's area. So definitely inferior frontal gyrus is the right answer. Now basically, एक्चुअली अगर न्यूरो एनाटमी की बात करें तो फंक्शनल एरिया इज अ वेरी इंपॉर्टेंट टॉपिक. सो व्हाट आई वांट एवरी स्टूडेंट्स टू हैव ए क्विक recapitulation of all the important functional areas, numbers and their location. So for each one of it, if you are going to give your FMG exam, it is important that you should have a quick recapitulation. So we will just quickly recapitulate all the functional areas of the brain so that it becomes easy for you to identify these structures. So very, very important. So let's focus on that. Area number 1, 2 and 3. So if I talk about area number 1, 2 and 3. So area number 1, 2 and 3 is called as primary sensory area and it is located in postcentral gyrus. So it is primary sensory area which is located in postcentral gyrus. If we talk about area number 4, it is primary motor area in precentral gyrus. Area number 5 is located in superior parietal lobule and it is somatosensory association area. Premotor area is in supplementary motor area. Area 7 is visuomotor coordination which is located in superior parietal lobule. Now a very important area, that is the frontal eye field area, which is very important for you to understand. This frontal eye field area is located in the anterior part, so anterior, it's located in the anterior aspect of the frontal lobe. Now we have got, and the surrounding area of calcarine sulcus, we have got primary visual area, area number 17, and we have got 18 and 19 as secondary visual areas. Area number 20, which is located in superior temporal gyrus, is the sensory speech area, Wernicke's area. So very important for you to understand that area number 22, which is located in superior temporal gyrus, this is including Wernicke's area, that is sensory speech area. Now if we talk about Brodmann area 39, it is located in angular area. If we talk about area number 40, it is supramarginal gyrus. Area number 41 and 42 is very important area, that are auditory areas, and auditory areas is located in Hazel gyrus. It's very important. What is Hazel gyrus? It is located in anterior transverse temporal gyrus. Anterior transverse temporal gyrus. It is located in anterior transverse temporal gyrus. Area number 43 is primary gustatory cortex. Area number 44 and 45. Please note down the motor speech area. If we talk about motor speech area, we have got area number 44. Area number 44, which is in the area of pars opercularis. And area number 45 is located in pars triangularis area of inferior frontal gyrus. Pars triangularis area of inferior frontal gyrus, which was asked in the MCQ. So definitely this is the right answer. Okay, so now let's move on to the next question. That is question number 67. Which of the following structures develop from dorsal mesentery? Which of the following structure is developing from dorsal mesentery? So when the development of peritoneum, there is formation of dorsal and ventral mesentery. And as a question of your embryology part, it is very important that you should know the derivatives of dorsal mesentery, and you should also know the derivatives of ventral mesentery. So 4 options are there: greater omentum, lesser omentum, liver and diaphragm. And you have to come up with the explanation that which are the derivative of dorsal mesentery and which are the derivative of ventral mesentery. So if I talk about the right answer here, the derivative of the dorsal mesentery is definitely the greater omentum. Lesser omentum is derivative of ventral mesentery, and same goes with the liver and diaphragm. So liver and diaphragm is also not not the right answer. The reason is that if I talk about liver and diaphragm, so here we can see greater omentum is developed from dorsal mesentery, ventral mesentery is lesser omentum. But if I talk about liver and diaphragm, please note down, diaphragm has got a multiple source of development, and as we know, diaphragm develops from septum transversum and pleuroperitoneal folds, and also from the body wall. Liver, agar liver की बात करें, it is also not the right. Actually, liver develops from ventral foregut endoderm. So these are two wrong options. So the right answer here will be the greater omentum, which is the derivative of dorsal mesentery. So the right answer is greater omentum, which is the derivative of dorsal mesentery. Okay, so let's move on to the next question. No, before next question, I just want everybody to go through the list of the structures which is developing from the source of dorsal mesentery and that of ventral mesentery, because it is highly important for your examination that you should know. Embryologically, this question has been asked many times in the previous year of examination. So agar hum dorsal mesentery ki derivatives ki baat kare, to one of the important derivatives is that of greater omentum, gastrocolic ligament, gastrosplenic ligament, gastrophrenic ligament. Also, the splenorenal ligament, mesentery of small intestine, mesoappendix, transverse mesocolon, phrenicocholic ligament, and sigmoid mesocolon. So you can see a wide list is there, which are the derivatives of dorsal mesentery. If I talk about the ventral mesentery lying anterior to that of the liver, we have got lesser omentum, which has got two parts. Lesser omentum, we know that it is having two parts, that is the hepatoduodenal and hepatogastric ligaments. And if I talk about the other falciform ligament and coronary ligament. So falciform ligament, superior, inferior coronary ligament, also right and the left triangular ligament, also the hepatogastric ligament, hepatoduodenal ligament, all these ligaments are derivatives of ventral mesentery. So that list should be known to you about the derivatives of ventral and dorsal mesentery. And wide list of structures are derived from dorsal mesentery, that is the greater omentum, the gastrocolic, the gastrosplenic ligament, splenorenal, mesentery of small intestine, mesoappendix, transverse mesocolon, phrenicocholic and sigmoid mesocolon. So very, very important for your exam. MCQs has been asked so many times in the previous year of exam. So just go through the list and by heart it. Okay, let's move on to the next question now. That is question number 68. Patient with positive Trendelenburg sign. What is the action of the muscle involved? Patients having positive Trendelenburg sign. So what is the action of the muscle involved? So here, flexion, lateral rotation, abduction and internal rotation and abduction and flexion. So exactly, Trendelenburg sign is positive seen in the injury of superior gluteal nerve. कब हम Trendelenburg sign positive देखते हैं? Trendelenburg sign positive in the case of superior gluteal nerve injury, and we know that superior gluteal nerve is giving innervation to, if I talk about superior gluteal nerve, it is giving innervation to gluteus medius and minimus and tensor fascia lata. Gluteus medius and minimus are abductors of the hip, and anterior fibers of these muscles are internal rotators of the hip. So I would like to explain this firstly about Trendelenburg test also. Before that, I just want everybody to write the details. So please write on positive Trendelenburg sign. If we talk about positive Trendelenburg sign, it is seen in the condition of superior gluteal nerve injury. Superior gluteal nerve injury. So it is seen in the condition of superior gluteal nerve injury. And superior gluteal nerve injury gives innervation to gluteus medius muscle, gluteus minimus muscle, gluteus minimus muscle, and tensor fascia lata. And if we talk about the action of these muscles, so gluteus medius minimus and tensor fascia lata, so basically they are abductors of the hip joint. They are abductors of hip joint, of hip, and anterior fibers of these muscle. If we talk about anterior fibers of these muscle, they are causing internal rotation of the hip. So they are causing internal rotation of the hip. Done. Now let me slightly also explain you about the normal and the positive Trendelenburg sign. So exactly what happens, how when we are telling that positive Trendelenburg sign is seen in this condition. So exactly for understanding this, I want everybody to see this image. So when you are seeing this image, you can understand. So normally when a person stand on one leg, when a person stand on one leg, the other side hip is slightly raised. So other side hip is slightly raised by the action of contralateral side abductors of the hip, and this is seen in normal condition. But in case of Trendelenburg sign, there is paralysis of gluteus medius and gluteus minimus muscle, and this occurs due to injury of superior gluteal nerve. So what happens, the other side of hip is not abducted, and it's outwardly raised, it's not slightly raised. The other side of the hip, when you stand on one leg, will sag down. So what you can say, this is sagging down. So other side of the hip is sagging down, and this condition is called as Trendelenburg sign positive. This condition is seen, and the person will have a lurching gait, or this condition is seen in injury of gluteus medius minimus. Both of these muscles are internal rotators and the abductors of the hip joint. So definitely the correct answer will be abduction and internal rotation. Abduction and internal rotation. Now let's move on to the next question, that is question number 69. Lower brachial plex injury leads to Klumpke's paralysis. The characteristic finding of Klumpke's or lower brachial plex injury is, so we have got four options in this category: Horner syndrome, policeman tip deformity, wrist drop, or claw hand. So lower brachial plex injury में अगर होगा तो what will be the sign and symptoms seen in the patient? So basically for understanding this MCQ, you should also know about the difference between the upper brachial plex and the lower brachial plex injury. So lower brachial plex injury is mainly characterized by the involvement of C8 and T1 nerve root, and it will lead to exactly यहाँ पे. So characteristic findings, actually Horner syndrome is included in this condition, but characteristic finding is claw hand. So we'll go with medial claw hand. Okay, so the most correct answer will be medial claw hand. Actually T1 nerve fibers are carrying sympathetic fibers, so lower trunk brachial plexus has got a Horner syndrome associated with it. अगर लेकिन characteristic findings की बात करें तो we'll go with claw hand as the right answer. Now see this condition. So here there are two types of brachial plex injury. One is upper ट्रंक ब्रेकियल प्लेक्स इंजरी जहाँ पे C5 और C6 नर्व रूट इन्वॉल्व होता है. दूसरा है लोअर ट्रंक ब्रेकियल प्लेक्सस जहाँ पे C8 and T1 nerve roots are involved. So if I talk about the upper brachial plex or trunk injury, the deformity which will be seen is the Vater tip deformity. The patient will have Vater tip deformity. In case of lower trunk brachial plex injury, the deformity which is seen is the claw hand, medial claw hand. Okay, so basically अगर upper trunk brachial plex injury की बात करें तो upper trunk brachial plex injury में हमारा जो arm है, the patient's arm or the baby arm, if it is congenital, so the baby arm will be adducted and medially rotated, and the forearm will be extended and pronated. In case of claw hand, we will have the metacarpophalangeal joint extended and the interphalangeal joint will be flexed, which is seen in the condition of medial part. So it is important for you to understand that in case of Erb's palsy or upper trunk brachial plex injury, upper trunk brachial plex injury. So in case of upper trunk brachial plex injury, the patient will have, if I talk about the person, the patient is having or the baby is having adducted and medially rotated arm, will have adducted and medially rotated arm. And the person and the other features will be extension and pronated forearm. Extended and pronated forearm. And this condition is called as waiter tip deformity or policeman tip deformity. But in case of lower trunk palsy, in case of lower trunk or Klumpke's paralysis, the here C5 C6 nerves involved hota hai, yahan pe C8 and T1. So basically the medial cord of brachial plexus is involved and the patient will have or the baby will have ulnar claw hand. And in case of ulnar claw hand, there will be metacarpophalangeal joint extension. The person will have extension of metacarpophalangeal joint and flexion of interphalangeal joint. Interphalangeal joint. So these are the features which will be seen in the lower trunk brachial plex injury or Klumpke's paralysis. Now, I also want everybody to pay attention to the basic difference of injuries. So basically, I just want to enlarge this, and when I'm enlarging it one by one, you can understand. So Erb's or waiter tip deformity, traction is given. So what is the injury? Traction is given, and this will lead to upper trunk injury. The cause will be like difficult vaginal delivery hua hai, and traction on the head and neck is given, and ultimately it will lead to paralysis of the basically muscles like deltoid, infraspinatus, supraspinatus, and this is the position of the arm. So you can see here arm is in this condition, you can see arm is adducted and medially rotated and forearm is extended and pronated. Now in the case of Klumpke's paralysis, lower trunk palsy, C8 and T1 nerve root is involved. Basically if we talk about somebody falling, somebody is having hyperabduction of arm, falling and catch hold of a tree to save himself, that condition is called as Klumpke's paralysis. This is one of the mode of injury. Intrinsic muscles of the hand, lumbrical muscles medially, and that of introsiosi muscles are involved, and claw hand is here, that is extension of mainly medial claw hand will be there, extension of metacarpophalangeal joint and flexion of interphalangeal joint. Thoracic outlet syndrome. When we are talking about thoracic outlet syndrome, in the case of thoracic outlet syndrome, again, we have got compression of lower trunk of brachial plexus, and also we will have, and also in this condition, there will be involvement of subclavian vessels which is compressed. So the reason is Pankos tumor or cervical rib, and the features will be same as Klumpke's paralysis, because in thoracic outlet or inlet syndrome also the lower trunk of brachial plexus is involved. So atrophy of intrinsic muscles, and there will be vascular compression. Winged scapula or winging of scapula is due to injury of long thoracic nerve of bell or Bell's nerve, which give innervation to serratus anterior muscle. Generally, it is seen in case of axillary node removal or breast operations like mastectomy, and serratus anterior muscle is paralyzed. And if you tell the person to force against, to press against the wall, and in that case you can see the medial wall of the scapula, medial border of scapula is protruded out. This condition is called as winging of scapula, which is seen in the condition of long thoracic nerve injury. So done, my dear students. Now I want you to go with the third. So this is the third part today. Let's move on with the third part. So exactly, this is the third part of the MCQ session which we have started today. So few 30 more MCQs I have to just finish. So let's start with that. Okay. So this is the third part of the MCQs discussion. So let's start with the first question, that is Hazel corpulses. So let's start with the first, that is Hazel corpulses. So Hazel corpuscles are seen in, the question number 70 is Hazel corpuscles are seen in which of the following structure? So this is a histology question which you have to solve. Hazel corpus, if I talk about Hazel corpus, it is hyalinized mass, it is acidophilic structure which is lying in the medulla part of the thymus gland. So basically the Hazel corpus is a most important or striking histological feature for the identification of thymus gland. So Hazel corpus is very important point for the identification of thymus gland. So we have got thymus gland as the right answer. But I just want to describe the histological features also. Hazel corpus is also called as thymic body. And these thymic bodies are involved in, are present in the medulla of the human thymus. Where it is present? It is present in the medulla of the human thymus, formed by eosinophilic thymic epithelial cells. If we will see around this lamellated body, harmonized material, there is an harmonized material, the whole surrounding there will be eosinophilic thymic epithelial cells which is arranged concentrically around this. So which is arranged concentrically around it, and that is the Hazel corpus. So we this is characteristic feature which is seen in the thymus gland. So I just want to show you this clinical. So exactly I am highlighting this. So what is this? Is a large view, high powered view of Hazel corpus. So this is what this is. Hazel's corpus, which is hyalinized mass acidophilic, lying in the medulla. It is located in the medulla of thymus gland. Exactly, this is the Hazel corpus, and number of Hazel corpuses will increase. If I talk about the number of Hazel corpuses, it increases with age, and elderly people will have more of Hazel corpuses. Also, calcification amount will be seen in this, and these are surrounded by epithelial cells, and these are surrounded by epithelial cells. Eosinophilic epithelial cells. So Hazel corpuscles are composed of central mass consisting of more of granular cells, and this can be spherical or void. Also keratohyalin granules has been seen, and more of epithelial tissues are surrounding it. It is located in the medulla part of the thymus gland. Now, the other structures, Hazel corpus is not seen in thymus gland. Hazel corpus are seen in thymus gland, but it is not seen in lymph node, spleen, and bone marrow. So let's rule out the other option. And what is the identifying features of lymph node, spleen, and bone marrow? Let's see. So lymph node is not the right answer, and the reason why lymph node is not the right answer, because when you see the slide of lymph node, you will get aggregation of lymphocytes. So you will have an aggregation of lymphocytes there. And that aggregation of the lymphocytes, if you see that aggregation of lymphoid structures or lymphocytes, will have reticular stroma. So lymphatic aggregation, and in case of lymph node, we have got fibrous capsule, which is connective tissue framework. Below the fibrous capsule, there is subcapsular sinus. Actually, subcapsular sinus is traversed by trabecular vessels. And inner side, we have got the cortex area, we will have the paracortex area, and we will have the medulla. So in the medulla, the characteristic feature which we will see is the medullary cords and sinus. Paracortex area is the T-dependent area, T-dependent or thymus-dependent zone containing T lymphocyte. Cortex will have the lymphatic aggregations. Subcapsular sinus will be traversed by trabecular vessels. Now, if you talk about the spleen is also not the right answer. Characteristic feature for identification of the spleen is fibrous capsule तो है ही, but इसमें जो most important feature जो हम देखते हैं spleen में, there is presence of white pulp and red pulp. So there is white pulp and red pulp. So spleen parenchyma is having white pulp and red pulp. When I am talking about white pulp, it is consist of lymphocytes aggregation which is seen, and in the white pulp only we will see the location of central artery which is eccentric in position, and red pulp is consist of splenic cords of Billroth and splenic venous sinuses. So what does white pulp contain? White pulp will contain lymphocytic aggregations, lymphoid aggregations in the form of lymphoid nodules. It contains central artery in eccentric position, central artery in eccentric position. And the red pulp, if I talk about red pulp, the red pulp is having splenic cord of Billroth, will have splenic cord of Billroth, which contains the reticular fibers, macrophages, plasma cells, and it is having splenic venous sinuses. What is splenic venous sinus? This is, if we talk about splenic venous sinus, this is highly fenestrated capillaries having discontinuity not only in the epithelial cells but also on the basement membrane. Now, why bone marrow is not the right answer actually? So this is also, spleen is not the right answer. If I talk about the bone marrow is consist of heterogeneous mixtures of mixtures of adipocytes, fibroblasts, macrophages like cells, and normal biopsy or specimen will show tissue composed of hemopoietic cells. Cellularly, the changes will depend on to the age of the person also. So bone marrow is also not having Hazel corpuscles in it. So definitely Hazel corpuscles is not seen in, is only seen in the thymus gland. At the establishment of Hazel corpuscles function is remaining, as more of the theories and research is going on. So let's come on to the next one. Question number 71. Actually, I want everybody that pay attention to these MCQs, because this is highly important for your upcoming session of FMG exam. So you can just go through this session. This was a session of one day where all important 100 topics of anatomy has been described. So you can just go through this. This will help you to quickly revise all the questions being asked in the examination, which will be giving you a better score. So let's start with the question number 71. Which cranial nerve nucleus is not situated in the medulla oblongata? Which cranial nerve nucleus is not situated in medulla oblongata? We have got facial, we have got glossopharyngeal, we have got vagus and hypoglossal. So exactly 9, 10th and so we have got 9, 10th and 12th cranial nerves. So exactly we have got these nucleuses located in the medulla, but facial nucleus is located in the pons. So this is the odd man out. So the right answer is pons. Right answer is facial nerve because it is located in pons. Now let me just tell you about its description. The nucleus. If I talk about the nucleus of the facial nucleus, it is located in the caudal portion of pontine tegmentum. Where it is located? The location of facial nucleus is in the pontine tegmentum, in the pons. And we also know the axons of, okay, sorry. If we talk about, so we also know, if it, okay, if we talk about the axons of abducens nerve nucleus, it is traversing and it is existing. So actually it is winding around the abducens nerve nucleus so that it can come close to the spinal trigeminal nucleus. This condition is called as neurobiotexis. So it is very important for you to understand that exactly facial nerve nucleus की बात करें तो facial nerve nucleus has got an internal genu which is called as bending of facial nerve around the abducens nerve nucleus so that the facial nerve nucleus can come close to the spinal trigeminal nucleus. That is the maximal sensory stimulus region. So the motor nucleus of facial nerve, as you can see, this is the section of the pons, lower pons area, and you can see definitely the winding. So I just want you to show this. So this is the motor nucleus of facial nerve in the pons, and you can see it is winding around the abducens nerve nucleus and then sticking out. So it is winding around which nerve? It is winding around abducens nerve nucleus so that it can come slightly close to that of the trigeminal nerve nucleus. That is maximum sensory stimulus is there. So this condition of winding is called neurobiotexis, and this winding of facial nerve is called as internal genu of facial nerve. Okay, now I just want everybody to also see, actually this is an image where we can see the ventral aspect of the brainstem. So what you can see, this is the image showing ventral aspect of brainstem, and I quickly want everybody to have the revision of all the cranial nerve exiting out. So this part is the midbrain. So from the midbrain you can see two nerves are emerging, trochlear and oculomotor. So two nerves are emerging from the midbrain, oculomotor nerve, and trochlear. So actually, trochlear nerve is the odd man out. It is the only cranial nerve which is emerging out from the ventral aspect. So you can see, you will see the trochlear nerve, it is winding here. You can see it is winding. You can see this is the trochlear nerve, and if you will see correctly, this nerve is winding around and coming to the ventral aspect as coming from the behind dorsal aspect. So injury is from the dorsal aspect of midbrain. So two nerves coming out from the midbrain is oculomotor and trochlear. Now, if I talk about the nerves coming out from the pons, so we have got the both sensory and motor nucleus of trigeminal nerve. Then we have got, so exactly अगर हम ये point देखेंगे, this is pontomedullary junction. What is this? This is pontomedullary junction. So exactly from the pontomedullary junction, we have got abduction nerve, we have got facial nerve, and vestibulocochlear nerve. These three nerves are emerging. Actually, this is the abduction nerve. And in the facial nerve, we have got motor division of the facial nerve, and we have got the sensory division of the facial nerve, that is called nervus intermedius, and the vestibulocochlear nerve. That means from the ventral aspect of the pons, the trigeminal nerve emerge out, and from the pontomedullary junction, from medial to lateral, the nerves emerging out is abduction nerve, facial motor nerve, sensory facial nerve, that is nervus intermedius, and most laterally is vestibulocochlear nerve. Now coming to the medulla, if you will see the medulla, this is P for the pyramid, and just lateral to the pyramid, the nerve rootlets which is emerging out is hypoglossal nerve, and just lateral to olive, this is O for olive, and just lateral to olive, what you can see, the nerves which is emerging out from top to bottom is glossopharyngeal nerve, the ninth cranial nerve, the vagus nerve, and the accessory nerve. So we have got all the, so in short what we can say, all the nerves. So in short we can say, so we have done with this, and we have described all these nerves already. So in short we can say all the cranial nerve except first and second, all the cranial nerves except first and second cranial nerve emerges out from brainstem. So third and fourth will emerge out from midbrain. Fifth from pons, ventral aspect. Sixth, seventh, and eighth from pontomedullary junction. And ninth, 10th, 11th, and 12th. These all nerves emerges out from the medulla. Okay. Now, let's talk about the next glossopharyngeal nerve. That is actually, if I talk about glossopharyngeal nerve, uh, it is emerging from medulla, so it is not the right answer. Vagus is also emerging from medulla. We have already discussed it, and we also know hypoglossal is also not emerging from pons. It is also emerging from medulla. So these are all wrong option. Only the correct answer will be the facial nerve, which is emerging from the pons, and the right answer here. So let's move on to the next. That is question number 72. Seventh cranial nerve palsy will be seen in which of the following syndrome? So again it is a question regarding brain stem syndrome. So मैंने एक और question discuss किया था previously, and there also I have explained you brain stem syndrome is very important. Clinical questions will be definitely asked from this topic. So I just want to discuss the syndromes like Millard, Gulber, Benedict's, Weber's, and Claude. Actually, seventh cranial nerve syndrome is seen in the case of Millard-Gulber syndrome. So we will discuss about Millard-Gulber syndrome. So it is exactly a syndrome involving pons, and it involves the seventh cranial nerve palsy, Millard-Gulber syndrome. So diagnosis. So if I talk about the diagnosis of Millard-Gulber syndrome, it is manifested with involvement of facial nerve, abduction nerve, along with the contralateral hemiplegia. So Millard-Gulber syndrome, which involves pons injury, it has got three important structures being involved. So it will have facial nerve injury causing lower motor neuron palsy, facial muscle palsy. It will also involve contralateral hemiplegia. Why contralateral hemiplegia? Because of in the involvement of pyramid. And it will also have sometimes abduction nerve involved. Sixth cranial nerve will be involved, and it will, if sixth cranial nerve is involved, the muscle which is paralyzed is lateral, so the patient will have medial squint. So these are the features. So these are all the features of Millard-Gulber syndrome. So you have to diagnose the case of Millard-Gulber syndrome by these features, and then we can come up the right answer. Now, Millard-Gulber syndrome, the functional. So let me more elaborate about Millard-Gulber syndrome. The symptoms of Millard-Gulber syndrome is resulting from the functional loss of several anatomical structures which is involved in pons. If I talk about the injury of pons, here we have got the nerves being involved. We have got the involvement of corticospinal tract. We have got the involvement of seventh cranial nerve. We have got the involvement of abduction nerve. So if abduction nerve is involved, that means the muscle being paralyzed is lateral rectus. So the patient will have diplopia and internal squint, that is loss of power to rotate the affected eye outward. So facial nerve is also involved, causing the paralysis of muscles of facial expression. So, and also corneal reflex will be lost. So disruption of corticospinal tract, contralateral hemiplegia will be also there. That means three basically abnormalities will be seen: contralateral hemiplegia, facial muscle paralysis, and internal squint. These are the three features which will be seen in the case of Millard-Gulber syndrome. Now, let's talk about the next syndrome, that is Benedict syndrome. So if I talk about Benedict syndrome, it is actually characterized by the injury of midbrain. So here what happens, third cranial nerve is involved with contralateral hemiplegia. So exactly the ipsilateral oculomotor nerve palsy will be there and contralateral hemiplegia is there. So only this condition is seen, and along with it also there will be tremor, chorioathestosis will be there, and cerebellar ataxia. So exactly Benedict syndrome is a syndrome which is involving midbrain along with the oculomotor nerve injury, along with contralateral hemiplegia, and along with the tremors, chorioathestosis, and cerebellar ataxia. Weber syndrome is also Weber syndrome is also a condition in which midbrain is involved. The injury is to the midbrain, and here also third cranial nerve will be involved. Alternating so there is also hemiplegia, oculomotor palsy is there, and other features of ptosis will be also there. Claude syndrome is a brainstem syndrome caused by ipsilateral third cranial nerves and contralateral hemiataxia. So there will be also hemiataxia in this condition, and this is called as Claude syndrome. This condition is called as Claude syndrome. Now, before proceeding, I would also like to tell you the important features. So here the substantia nigra, corticospinal fibers being involved, corticobulbar, tract, oculomotor nerve. So the third cranial nerve is involved. So I just want I just want that we should devise Weber syndrome, because Weber syndrome is a very important syndrome affecting the midbrain, and we should quickly revise all the clinical features associated with it. So due to involvement of substantia nigra, what is substantia nigra? It is containing dopamine precursor. So exactly it will lead to Parkinson's. Dopaminergic projections to the basal ganglia is affected, and the person will have tremors. Okay, so the person will have tremor. Corticospinal fibers are involved. What does that mean? That means that there will be hemiplegia in this condition. Okay, and corticobulbar means the lower half of the face, and the hypoglossal nerve function can also be involved. Oculomotor, so basically difficulty in contralateral lower half of the face, that is most important. So don't get confused with hypoglossal nerve nucleus. Just remember in this case this areas will be involved, and other than that there will be oculomotor nerve being involved. There will be also oculomotor nerve being involved. So that is because of corticobulbar fibers traversing. Now let's talk about the next question, that is question number 73. Efferent reflex of cornea is. So we have knowing that corneal reflex is having afferent and efferent. So we know that corneal reflex is having afferent and it is having efferent. So efferent corneal reflex involves which of the following nerve? Whether it is facial nerve, whether it is abduction nerve, whether it is trochlear or trigeminal nerve. So exactly, I would like to describe the corneal reflex. That is exactly, corneal reflex has got two nerves being involved. One is afferent, another is efferent. So if I talk about the afferent loop of the corneal reflex, it is traversed via fifth cranial nerve. And if I talk about efferent loop for the cranial efferents, it is via the seventh cranial nerve. So exactly, that means in this question the efferent corneal reflex loop has been talked about. So we will mark facial nerve as the right answer. So we'll mark facial nerve as the right answer. So efferent reflex of cornea is via facial nerve and afferent is via trigeminal nerve. So before proceeding to the next question, I want quickly to recapitulate the corneal reflex pathway. So you can see this is the flow chart dissipating the corneal reflex. So this is the flow chart. So let's see the corneal reflex flow chart. So the first step is that touch the cornea. So touch the cornea and the fibers traversing will pass through the ophthalmic branch of trigeminal nerve. Then it goes towards the relays, fibers relays and spinal nucleus of trigeminal nerve. From here, what we say in facial motor nucleus is the efferent, and the branch of facial motor nucleus is innervating orbicularis oculi. We know that orbicularis oculi upper part is innervated by the temporal branch of facial nerve, and lower part of orbicularis oculi is innervated by zygomatic branch of facial nerve. This will lead to blinking of eye. This will lead to blinking of eye. So this is a flow chart which is showing you the corneal reflex pathway. Here afferent is via trigeminal nerve and efferent is via facial nerve. So contraction of orbicularis oculi is a efferent component and the ophthalmic branch of trigeminal nerve is the afferent component. Now, the abduction nerve is not the right answer because it is not any type of, it is not a component for the corneal reflex. Trochlear nerve is also not the right answer because it is not a component for the corneal reflex. Same goes with the trigeminal. Actually, trigeminal is the component for the corneal reflex, but trigeminal is forming the afferent loop. So it is not the right answer. And the question has been specifically asking about the efferent loop. So we have got seventh nerve as the right answer. Now let's move on to the next question, that is 74. Let me just pour some water. So which of the following muscle is supplied by glossopharyngeal nerve? Which of the following muscle is supplied by glossopharyngeal nerve? So actually glossopharyngeal nerve means ninth cranial nerve. And we know that stylopharyngeus muscle is the muscle of third pharyngeal arch. Stylopharyngeus muscle is the muscle of third pharyngeal arch. It's the muscle of third pharyngeal arch and it is innervated by glossopharyngeal. So exactly all the muscles of the pharynx are innervated by vagus except stylopharyngeus. Why not stylopharyngeus? Because stylopharyngeus is innervated by the nerve of third pharyngeal arch and that is glossopharyngeal nerve. So that is the right answer. It's a direct question and you should know about this. Now, other than that, we have got styloglossus not the right answer, platoglossus is not the right answer, masseter, because styloglossus, the word glossus, that means it's a muscle of tongue. So styloglossus is innervated by 12th cranial nerve, hypoglossal. Platoglossus is the odd man out, which is innervated by vagus nerve carrying the fibers of cranial part of accessory. Masseter is the muscle of mastication getting innervation from the mandibular nerve branch of trigeminal nerve. So glossopharyngeal nerve, if I talk about, it is the only sole innervator of stylopharyngeus muscle, which is involved in elevating pharynx and larynx. Embryologically, if I talk, I have told you glossopharyngeal is the nerve of third pharyngeal arch. Superior sensory innervation, if I talk about glossopharyngeal nerve, so glossopharyngeal nerve is giving innervation to oropharynx. So you can just chalk down glosso. If I talk about glossopharyngeal nerve, it is the nerve of third pharyngeal arch. It innervates the oropharynx. It also gives innervation to carotid body and carotid sinus. It also gives innervation to posterior 1/3 of tongue. It also gives innervation to middle ear cavity. It also gives innervation to middle ear cavity and that of eustachian tube, and it also gives innervation to eustachian tube, which is also called as auditory tube, eustachian tube or the auditory tube. So done. Now styloglossus is not the right answer. As I told you, styloglossus is the muscle of tongue, so it will be innervated by the 12th cranial nerve or hypoglossal nerve. Palatoglossus is the odd, it is also the muscle of tongue. It's also a muscle of the tongue. It is also the muscle from the soft palate, but palatoglossus muscle is the odd man out. It is innervated by vagus nerve carrying the fibers of accessory nerve, Okay, it carrying the fibers of accessory nerves. Okay, now if I talk about the masseter nerve, if I talk about the masseter muscle is the muscle of, if I talk about the masseter, just a minute. Okay, if I talk about the masseter muscle is the muscle of mastication, and it is innervated by mandibular nerve, that is the branch of trigeminal nerve. So that is also the wrong option. So let's move on to the next question, that is question number 75. Buccal branch of facial nerve is innervating which of the following muscle? Buccal branch of facial nerve. So if I talk about buccal branch of facial nerve, it is innervating which muscle? Whether it is innervating buccinator muscle, whether it is innervating buccinator orbicularis oris, buccinator and superior part of orbicularis oculi, buccinator and internal orbicularis oculi, buccal branch. So if I talk about buccal branch, it is innervating the buccinator and orbicularis oris, So exactly, actually, if I talk about facial nerve terminal branches, so how many terminal branches the facial nerve is having? It is having 5 terminal branches. So that 5 terminal branch of facial nerve will be traversing. So here somewhere we have got anterior to the ear. In this area we have got parotid gland, and this 5 branches which is in the form of pex anserine will emerge out. We have got temporal, we have got zygomatic, we have got upper and the lower buccal, we have got marginal mandibular, and we have got the cervical. These are 5 terminal branch of facial nerve which will emerge out from the anterior border of parotid gland and will give innervation to the muscles of facial expression. So if I talk about zygomatic, if I talk about the zygomatic nerve, it is only giving innervation to lower part of orbicularis oculi. Buccal branch is innervating orbicularis oris buccinator, also zygomaticus muscle. Marginal mandibular is innervating depressor labile inferioris, depressor angulae oris, and mentalis muscle. Cervical is innervating platysma muscle. And which type of muscle is the platysma muscle? Platysma is the muscle which is lying in the superficial fascia. So it's an example of panniculus carnosus muscle. So all important branches of facial nerve has been enumerated. Now I just want a quick revision. I will also share a table with you in which we know 5 terminal branches of facial nerve. We have got temporal, which is innervating frontalis belly here. It is innervating upper part of orbicularis oculi and corrugator superciliary. So 3 muscles are getting innervation from the temporal branch: frontalis belly, orbicularis oculi, and corrugator superciliary. If I talk about zygomatic, it is just innervating the lower part of orbicularis oculi. Buccal. The question was asked about buccal, and very nicely, and it is very important that you should know buccal nerve, branch of facial nerve, innervates orbicularis oris, buccinator, and zygomaticus major. Zygomaticus, the laughing muscles. Marginal mandibular innervate, depressor labile inferioris, depressor labile and depressor angulioris and mentalis. Cervical is innervating the platysma muscle. So exactly in this diagram, we can see the terminal branches of facial nerve. So let's see the terminal branches. So if I talk about the terminal branches, the 5 terminal branches has been shown in this. And these 5 terminal branches, if you will see, temporal is giving innervation to frontalis, orbicularis oculi, corrugator supercilii, zygomatics. This is the first. This is the second. Orbicularis oculi. Buccal is giving innervation to orbicularis oris, zygomaticus buccinator. Marginal mandibular is giving innervation to labile, depressor labile inferioris, depressor labile angulioris, and the 5th one is the cervical, which is innervating the platysma muscle. So all the muscles of facial expression are the example of muscle residing in superficial fascia in the panniculus adiposus. So all these muscle, platysma muscle, muscles of facial expression are example of panniculus carnosus muscle. So this is a table in which you can, if you want to have a detailed detail of all the muscles, like the branch of facial. So this is a table in which all the branches of facial nerve innervation has been. For example, posterior auricular nerve will give innervation to the auricular muscle, posterior and superior auricular muscle, and occipital belly of occipitofrontalis. Digastric branch is giving innervation to posterior belly of digastric and stylohyoid muscle. Temporal, zygomatic, buccal, marginal, mandibular, and cervical we have already done. So buccinator is not the right answer only because other than buccinator, it also gives if we talk about buccal branch, it is also giving innervation to orbicularis oris and zygomaticus. Same way, this superior orbicularis oculi is not innervated, so it is wrong. And inferior orbicularis oculi is also not innervated by buccal, so it is also wrong. So we'll choose the most correct answer and we will mark B as the right answer. Buccal branch of facial nerve innervates orbicularis oris, buccinator muscle, and that of zygomaticus muscle, zygomaticus major and minor muscle. So done with this, let's move on to the next. The next question is middle meningeal artery. Actually, cranial foraminas and the structures traversing through this is very important for you to know. So one of an important artery is middle meningeal artery. So if I talk about middle meningeal artery, it's an important branch. If I talk about middle meningeal artery, it's an important branch of maxillary artery. So middle meningeal artery will pass through foramen spinosum. So the correct answer is it is passing through foramen spinosum. Okay, it passed through foramen spinosum. So middle meningeal artery is a branch from the first part of or mandibular segment of maxillary artery. It will pass behind the condylar process of the mandible and will enter the skull through foramen spinosum. Actually, I want that if I talk about the head and neck part and neuroanatomy also, this topic is very important for the FMG exam. So before your examination, it is very important that you should revise all the foraminas and the structures passing through individual foraminas. So let's give it a quick revision. So I just want you to see this cranial foraminous image. So exactly, this is cribriform plate of ethmoid bone. So this is cribriform plate of ethmoid bone, and from the cribriform plate of ethmoid bone, which is lying in the anterior cranial fossa, olfactory nerve rootlets are passing out. Through the optic canal, we have got optic nerve and ophthalmic artery. Through superior orbital fissure, which is retort shape lying below the lesser wing of sphenoid, we have got third, fourth cranial nerve, sixth cranial nerve, and also the branches from the trigeminal nerve. We have got the branches from the ophthalmic division of trigeminal nerve. Other than that, foramen rotundum, we have got the maxillary nerve, which is the second division of trigeminal nerve. This is the foramen ovale is there, through which the third division of trigeminal nerve, mandibular nerve, passes. And actually foramen ovale से हमारे पास male structures pass करते हैं. So most important one, I will write all the details, don't worry. Internal acoustic meatus से 7th and 8th nerve, jugular foramen से 9th, 10th, 11th. and hypoglossal canal se 12th cranial nerve passes. So that is very important. You have to note down this. So foramen ovale is not the right answer because through this passes male, M-A-L-E. M for mandibular, L for lesser petrosal nerve, E for emissary vein, accessory middle meningeal artery. Foramen lacerum se greater and lesser, greater petrosal nerve joins with deep petrosal nerve to form nerve of pterygoid canal. Foramen rotundum se maxillary nerve passes. So exactly important foraminas and the structures passing. Quickly write down. This is very important for your examination. So nerves has already been written, but I want that all the structures you should know. So write down from foramen spinosum, middle meningeal artery and nervous spinosum passes. Nervous spinosum passes. What passes? Nervous spinosum passes. Okay. So we have got nervous spinosum which is passing through it. Okay. Now foramen spinosum. The next is foramen rotundum. If I talk about foramen rotundum, the structures passing through foramen rotundum is maxillary nerve and emissary vein. So in short, you can write ME. What is it? ME passes through it. Now foramen ovale. So if I talk about foramen ovale, the structures passing through foramen ovale can be memorized by the mnemonic male. ओवा के पास मेल जाता है और M से A से L से E से क्या होता है? What is the structures passing? So quickly we will write down. M stands here for the mandibular nerve. A for accessory middle meningeal artery. A for accessory middle meningeal artery. L for lesser petrosal nerve. L for lesser petrosal nerve. And E for emissary vein. E for emissary vein. Okay. Done? Done? Now, if we talk about more of the foraminas, more important for internal acoustic meatus. So let's talk about internal acoustic meatus. So from internal acoustic meatus, the structures passing is 7th cranial nerve, 8th cranial nerve, and that of labyrinthine vessel. So internal jugular is also given, and if you talk about foramen magnum, very important, the structures passing through foramen magnum. So if I talk about foramen magnum, many important structures are passing. Actually, foramen magnum is divided into two parts, anterior compartment and posterior compartment. So that is important. So if you want to know about foramen magnum, so please write down foramen magnum. Write down the heading foramen magnum. So actually foramen magnum is divided into two compartments by alar ligament. Alar ligament will divide foramen magnum into anterior compartment and posterior compartment. So if we are talking about anterior compartment, the structures passing through the anterior compartment is just the ligaments. So it is called as osteoligamentous compartment. So it is having the apical ligament which is traversing through it, membrana tectoria and cruciform ligament, cruciate ligament and membrana tectoria. So this is the reason no nerves in the vessel is passing through the anterior part of foramen magnum. So it is called as osteoligamentous compartment. So when we are talking about posterior compartment, now when we are talking about the posterior compartment, the posterior compartment of the foramen magnum is termed as neurovascular compartment. It is termed as neurovascular compartment. And why neurovascular compartment? Because only nerves in the vessel passes through it. Nerves passing spinal accessory nerve, anterior and posterior spinal arteries. What else? Anterior and posterior spinal artery passes. Vertebral artery passes. Tonsil of cerebellum. Lower part of medulla oblongata. Okay, done with this. Now we have done with this important structures passing through the important foraminas. Let's proceed to the next question, that is question number 77. So in an emergency, the artery palpated. In case of emergency, which artery is palpated? In case of emergency, which artery is palpated? So carotid artery, femoral artery, radial artery, axillary artery, or brachial artery? So the correct answer will be carotid artery. So carotid artery. It's a very straight questions, and the right answer is, if I talk about the pulsation of common carotid artery, which is done in emergency conditions, and this pulsation of common carotid artery can be felt at the carotid tubercle. One of the previous year of questions, carotid tubercle पे question आया था. What is carotid tubercle? That is important for you to know. So carotid tubercle is actually anterior tubercle. It is an anterior tubercle, and this anterior tubercle is located on the transverse process of, C6 cervical vertebra, and the location of anterior transverse process, the location of anterior tubercle of the transverse process of C6 cervical vertebra is corresponding to cricoid cartilage. So you can see, just see the language has been changed, but the question is similar only. So carotid tubercle, anterior tubercle, transverse process of C6 cervical vertebra corresponding to cricoid cartilage is the palpation of common carotid artery. So common carotid artery is present on right and the left side, but their course is not similar on both the side. If I talk about common carotid artery of right side, it is a branch from brachiocephalic trunk on right side, and in left side it is directly the branch of arch of aorta. The splitting of external and internal carotid artery is exactly occurring at the level of thyroid cartilage at the level of 4 cervical vertebra. Femoral artery is not the right answer. The reason is that femoral artery is deep and it is most sensitive to be located in septic shock assessment, and it is not routinely done. Radial and axillary artery, palpation of radial artery is done for just taking the pulse, and it is done just lateral to, if we talk about the pulsation of radial artery to be felt, it is done lateral to flexor carpi radialis. So it is done lateral to flexor carpi radialis, and it is a common practice done by the health professionals, health personals. And let's talk, axillary is also deep to be palpated inside the axilla, so that is also not done. Most common artery to be palpated, then that is the, in case of emergency condition or in case of emergency, definitely we will go with the palpations of carotid artery at the level of carotid tubercle, which is anterior tubercle of the transverse process of C6 cervical vertebra corresponding to the cricoid cartilage. So done with this. Now let's move on to the next, that is question number 78. Okay, one more option is wrong. Brachial artery is also not the right answer. If I talk about brachial artery, is actually a site of evaluation done for cardiopulmonary resuscitations of the infant. So basically brachial artery का use है. If we talk about the brachial artery, it is evaluated for cardiopulmonary resuscitations of the infant. It is palpated proximal to the elbow between the medial epicondyle and that of humerus, and the carotid artery is most preferred site or during the resuscitation of adults. So that is the right answer, and this is asked in the MCQ 2-3 times in the prior examination also. Now let's talk about the another question, which is more of histology part. Tendon. So let's talk about the tendon. So what is tendon? So we know that muscle, if we define muscle, it is having a belly. Muscles are having a smooth muscle belly, and it's having an anterior part which is in the form of tendon. So tendon is the area of mainly insertion. So actually this is a question about connective tissue question hai, ye general anatomy connective tissue ka question, also a question of histology we can say. So exactly we have to know whether tendon is a loose connective tissue, whether the tendon is specialized connective tissue, whether the tendon is dense regular connective tissue, or whether the tendon is dense irregular connective tissue. So the right answer is tendon is dense regular connective tissue. So exactly अगर हम बात करते हैं dense connective tissue की, तो basically the examples are like tendon, ligaments and aponeurosis. If I talk about loose connective tissue, like adipose tissue is forming the loose connective tissue. Specialized connective tissue like bone, cartilages will be specialized connective tissues, and dense irregular connective tissue will be seen in the dermis part of the skin. So the best answer of tendon is dense regular connective tissue, and we will go with C as the right answer. Now, dense regular connective tissue provides, if I talk about dense regular connective tissue, it is exactly providing the connection between different parts of the tissues in the human body. It is having collagen fibers, so it is having the collagen fibers in the dense regular connective, and that is embedded in the parallel fibers. Example of dense regular arrangement. If I talk about the dense regular arrangement, I have written also there. Dense regular arrangement is seen in the case of tendons, it is seen in the case of bones. It is having longitudinal arrangement of the fibers of collagen fibers. If I talk about ligaments and aponeurosis, so ligaments, aponeurosis, we know that aponeurosis का मतलब होता है flattened tendon. Ligaments are attached to the certain clear to the bones and the joint. So all these becomes an example of dense regular connective tissue. So definitely tendon is the right answer. Now, loose connective tissue is not the right answer, because loose connective tissue will lie beneath the epidermis of the skin, which is loose areolar connective tissue. Specialized connective tissue, if we talk about specialized connective tissue, the example of specialized connective tissue, so exactly loose areolar tissue is mainly loose connective tissue. Better word will be loose areolar tissue, or adipose tissue is also there, please don't get confused. So it is loose areolar tissue. Please don't get confused. It's not that adipose tissue is not the contents, but it's the loose areolar tissue. Okay, now here if we talk about specialized connective tissue, blood, lymphatics and all, and irregular connective tissue is found in the layers of the skin. It is found in the dermis layer of the skin. We have got dense connective tissue, but the arrangement of these connective tissues are irregular. Okay, let's move on to the next. Type of collagen fibers in the hyaline cartilage. Which type of collagen fibers are in this hyaline cartilage? So the option which is given here is type 1, type 2, type 3 and 4. So if I talk about collagens in the hyaline, so we know that cartilages, we have got three types of cartilages: hyaline cartilages, fibrocartilage and elastic cartilage. Again, if agar overall cartilage ki baat kare, and most of the cartilage is having predominantly type 2 collagen fibers, so which will be the right answer? The right answer is type 2 collagen fiber. But I want you to give more details of this, because it is also important for you to know about the cartilages. So because that will be an important question of histology part. So अगर हम hyaline cartilage की बात करते हैं, तो hyaline cartilage is predominantly made of type 2 collagen fibers. Type 2, along with type 2 collagen fibers, there is chondroitin sulfate. There is chondroitin sulfate is there, and also there will be few elastic cartilage, but mainly it is having a cell nest. So exactly if we see the hyaline cartilage, it is present at, it is also important to know the areas where we find hyaline cartilage. So hyaline cartilage is found in the areas of the ribs, it is found in larynx, it is found in trachea and bronchi. And if I talk about hyaline cartilage, it is of two variety. One is the costal variety of hyaline cartilage, and another is the articular variety. Articular variety of hyaline cartilage will be formed at the ends of the bone, but अगर हम costal variety of hyaline cartilage की बात करते हो, तो it is found in the ribs anterior end. So exactly that example is okay, and isogenic cell nest is there in the group of the chondrocytes, and it is having perichondrium present. The perichondrium will have outer cellular, will have outer fibers and inner cellular layer. Now, three type of cartilages has been compared. So agar hum, so don't worry, I will, this is a table comparing the three types of cartilage, but I would like to tell you about the examples, and I would like to explain the types of cartilage on this image. So basically one more thing is important for you to write down. Hyaline cartilage is of two varieties. Either it is costal cartilage variety, or either it is articular cartilage. Okay, it is of two variety. Now, so when we are talking about hyaline cartilage, what you can say,
the hyaline cartilage will have too many chondrocytes. So it will have P for the perichondrium. It will have chondrocytes in large number, but chondrocytes will be arranged in isogenic cell nest. Isogenic cell nest. In elastic cartilage, we have got more of elastic fibers. More of elastic fibers will be there. And in fibrocartilage, there will be more of collagen fibers. So collagen fibers are more in fibrocartilage, and it is of type 1. Type 1 collagen. One of an important feature which you have to note down, that all the cartilage is having type 2 collagen fibers. The odd man out is fibrocartilage, which is having type 1 collagen fibers. Okay, अगर हम सारे cartilages की बात करते हैं तो hyaline cartilage, elastic cartilage or fibrocartilage. So hyaline cartilage will have predominantly type 2 collagen fibers. Also the elastic cartilage have type 2 collagen fibers, and also both hyaline and elastic cartilage will have the perichondrium presence. Fibrocartilage has got absence of perichondrium. And the examples is important. So example, if I talk about hyaline cartilage, it will be of costal variety or articular ends. It is also present in embryonic cartilages. It is present in trachea, bronchi, thyroid, and cricoid cartilage. Also arytenoid, but not the tip. But not the tip. Arytenoid. So here you can write arytenoid. But arytenoid tip. Arytenoid tip. Arytenoid tip is an example of elastic cartilage. Please note down. Epiphyseal plate, eustachian tube, auditory tube, external ear, epiglottis, corniculate, and cuneiform. All these corniculate and cuneiform are the parts of laryngeal cartilage. So this is also an example of elastic cartilage. Apex of arytenoid. So example of this is actually, this should be rubbed out. This is not. So the example of meniscus. So glenoid labrum, you can write this is present in glenoid labrum. So example is, it is present in glenoid labrum, the fibrocartilage meniscus of the knee joint, which is also called as semilunar cartilage, intervertebral disc, articular disc of TM joint, sternoclavicular joint. So all these are example of fibrocartilage. So fibrocartilage, if you will see, the chondrocyte number is less. More number of chondrocyte is there in elastic cartilage and hyaline cartilage. Regular arrangement of this chondrocytes in group is isogenic group, which is characteristic fight, which is seen in hyaline cartilage. Elastic fibers are more in elastic cartilage. Examples done. So type 1 collagen fibers is not the right answer, because type 1 collagen fibers is basically found in tendons, bones, and fibrocartilage. Type 3 is also not the right answer, because type 3 is majorly found in hollow organs like blood vessels, bowel tissues, and uterus and all. Type 4 is found in the basement membrane zone. So it is found in the basement membrane. So definitely the right answer, type 2 collagen fibers will found in the cartilages. So that is the right answer. Now coming to the next question, that is epithelium. The next question is about epithelium. Epithelium of esophagus. So exactly, this is again a histology question. Actually, I want everybody who is appearing for a FMG exam, important examples of epithelium types you should know, because these are many times asked in the examination, and it's very important for you to know. So epithelium of the esophagus, which type of epithelium lies in the esophagus? The answer is, it is having stratified squamous non-keratinized epithelium. So please note down, esophagus is a tube-like structure. Esophagus is lined by stratified squamous non-keratinized epithelium. Non-keratinized epithelium. Epithelium is lined by stratified squamous non-keratinized epithelium. The lining of epithelium of the esophagus, it is not having keratin deposit. So that is C is the, actually stratified squamous non-keratinized epithelium is present in many of the structures. So it is present in esophagus, it is present in anal canal, it is present in vagina, it is present in tongue lining, it is present in the tonsil. So many of the area we have got the stratified squamous non-keratinized epithelium. So esophagus is a muscular tube-like structure. As we know, the function of esophagus is rapidly, the food bolus is propelled from the pharynx, and it will continue with the esophagus. It is approximately 25 centimeter long tube, and the mucous membrane of esophagus is thrown into longitudinal fold. The epithelium is stratified squamous non-keratinized epithelium which has got a protective function to perform. Now, stratified columnar is wrong answer. Why? Because stratified columnar is not found in the esophagus. The example of stratified columnar epithelium is, where we find stratified columnar epithelium? We find in the conjunctiva. We will find this epithelium in the conjunctiva. It will be found also in the pharynx and in the part of male urethra. Part of male urethra. Stratified cuboidal is long. It is found in excretory ducts. It is found in excretory ducts of sweat gland and salivary glands. Also found in the ducts for mammary gland. Pseudo-stratified columnar is long. Actually, it is also very important for you to note down pseudo-stratified columnar epithelium. Pseudo-stratified columnar epithelium, that is ciliator. So ciliator pseudo-stratified columnar epithelium is a very important epithelium which is called as the respiratory epithelium, because major part of the respiratory system, or the major areas of respiratory system, that is trachea and the major bronchus, that primary bronchus, all these structure is lined by pseudo-stratified ciliated columnar epithelium. So we have got this present in the respiratory epithelium. So that means all these are wrong. Only the correct answer will be stratified squamous non-keratinized, which is the lining epithelium in case of esophagus. So done with this. Now we have got just 20 more MCQs. So are you exhausted? Don't worry, just 20 more MCQs and we will cover up in the next 1 hour all the 20 MCQs which will help you to crack your examination with a better marks. So once more, I want everybody to pay attention that these all 100 MCQs and the 100 topics, which I have not just explained the question directly, I have also tried to explain this topic, because that is how you are going to crack your examination. Agar sirf question or answers padhenge, to how you are going to get a better marks. So that is important, that we should also know the things, uske neighboring structures bhi thode padhai kar lete. Okay, that is very important for crack a better marks. So let's move on to the next question, that is question number 81. So just 20 more MCQs, my dear students. The next question is Pierce patches. Pierce patches. So Pierce patches is present in which of the following option given? This is again a question of histology, whether it is present in small intestine, whether it is present in stomach or duodenum, whether it is present in cecum and rectum. Pierce patches. So if you talk about Pierce patches, this is lymphatic aggregation. It is a lymphatic aggregation. And if I talk about lymphatic aggregation, it is in the form of lymphatic nodules. It is in the form of lymphatic nodules, which is located in the lamina propria layer of, it is present in the lamina propria layer of ileum. And the maximum number is found in distal ileum. So the correct answer will be small intestine. So if I talk about Pierce patches, which is a histological finding specifically seen in the condition of small intestine ileum. Actually, jejunum will not have Pierce patches. Mainly the collection will increase as you start with the ileum, and distal most part of ileum will have maximum number of Pierce patches. So that is the right answer. Stomach, cecum and rectum is not having the aggregation of lymphatic aggregation, that is Pierce patches. Characteristic feature for the Pierce patches to be present is in small intestine. So Pierce patches are located in small intestine, and basically maximum number of Pierce patches, if we talk about maximum number of Pierce patches, so maximum number of Pierce patches are seen in the case of ileum distal part. In which part? In the ileum distal part. And the function is to absorb the water and other nutrients from the food. Now, I just want you to show a image, histological image, where you can see this Pierce patches are seen in the, actually Pierce patches is seen in the lamina propria layer of the mucosa, but it can also go into the submucous layer of the small intestines and the ileum. So here you can see this aggregation. Can you see this aggregation? So if I enlarge it, can you see this lymphatic aggregation, which is called as, these are lymphatic aggregations, which is seen in the distal most part of the ileum. This is called as Pierce patches, which is seen in the part of ileum and residing in the lamina propria. It's also important for you to know where it lies. So it is lying in which layer? It is lying in the lamina propria layer of mucosa. And it can also descend. It can also go inside the submucosa layer, but basically found in the lamina propria layer of the mucosa part of the small intestine, basically in the distal part of ileum. Now, my dear students, why stomach duodenum is not the right answer? Actually, if I talk about the stomach, so stomach is not the right answer because अगर हिस्टोलॉजिकल स्लाइड स्टमक से आती है तो आइदर उसका फंडस पार्ट होगा या पाइलोरिक पार्ट होगा. इफ द histological image is from the fundus part, then it will have the beaded appearance, it will have the beaded appearance due to auxentic cells and all. So it will have the other cells, it will have parietal cells, auxentic cells all located. If we talk about duodenum, the characteristic feature for the identification of duodenum will be stomach or duodenum. Both will have the simple lining epithelium, that is simple columnar epithelium, but characteristic feature for identification of duodenum will be presence of Brunner's gland in the submucosa. That all feature was not described and only Pierce patches was asked. So definitely the correct answer is ileum. Cecum is not the right answer. Actually, cecum and colon will have mucosa, submucosa, 4 layers as you proceed from inside to outside. It will have mucosa, it will have submucosa, it will have muscularis, externa and serosa layer. But the most characteristic feature which is seen in the cecum colon is the presence of so many goblet cells. So the presence of goblet cells is maximum in colon and also simple columnar epithelium is there. But the most characteristic feature, पूरा जो आपका histological slide which will be stuffed with the goblet cells. So rectum is also not the right answer because rectum में भी Pierce patches का aggregation नहीं मिलता है. It is a part of GI tract which will have a columnar cells and along with it, it will have the goblet cells with muscularis mucosa, but Pierce patches is not there. So we will not strike rectum as the right answer. So yes, my dear students, let's move on to the next question. That is question number 82. So this question is of anatomy, or you can say this is from the physiology also. Cells in the blood is suspended in. If I am talking about the blood cell, it is suspended in which of the following area? Whether it is suspended in plasma, whether it is suspended in intestinal fluid, whether it is suspended in serum, whether it is suspended in colloid. So if I talk about the right answer, the cells in the blood is, if I talk about the cells of the blood, it is suspended in the plasma. So exactly the right answer is plasma. So it is suspended in the plasma. I just want, this is a very basic thing, but I want a quick revision given to you because you must have forgotten the concept of plasma, the concept of serum, the concept of colloid, and the concept of interstitial fluid. So let's talk about that. So if I'm talking about the plasma, so blood is composed of cells and cells fragment, which are, if I talk about the blood, it is composed of cells which are suspended in the liquid fraction of it. So the liquid, in other words, you can say liquid fraction or liquid part of blood is plasma, in which the cells of blood is suspended. Plasma is the liquid component of the blood in which the cells, कौन से cells उसमें suspend, it contains red blood cells, it contains white blood cells and platelets. So if I talk about constituents which is lying there, more than half of the blood volume, it is consisting more of the water it contains dissolved salts, it contains the electrolytes, it contains the proteins. The major component of the plasma, the major protein in the plasma is albumin. Which is the major protein? The major protein in the plasma is albumin. Now, what is the definition of interstitial fluid? So that is the reason we have got blood plasma as the right answer. Interstitial fluid is the space which is lying around the cell. So the basic definition will be, it is fluid which is lying around the cells. It comes from the substance that leak out from the blood capillaries, and that is the space which is around the blood cell, that is exactly helping in bringing oxygen, nutrients to the cells and to remove the waste materials from the product of them. So this is exactly the space. Interstitial fluid is surrounding the space around the blood cells. Serum, if I talk about the serum is the fluid and solvent. So basically, if you want to define, serum is solvent or fluid component of blood. But it is not having the clotting factors. Serum is not having the clotting factors. So if we define it is it may be defined as blood plasma. So exactly आप confuse हो सकते हो तो serum और blood plasma में क्या अंतर है? So basically the difference is that it can be defined as a blood plasma, but it is not having any kind of clotting factors in it. So serum का मतलब हुआ blood plasma without any clotting factors, and blood with or the blood with cells. So it may be defined as blood without clotting factor, or blood with all cells and clotting factors only removed. Serum has got all proteins, so it is containing protein. Please pay attention to it. It is containing proteins, blood. It is not containing the clotting factors. So it is containing electrolytes. So serum में हमारे पास electrolyte भी होगा. We will have the antigens. We will have the hormones. We will have other structures like drugs, microorganisms, but it is not having any kind of clotting factors. Serum does contains all the forms of blood, but it is not which include in blood cells like leukocytes, lymphocytes, all will be present except the clotting factor. What is colloid? What is colloid? If you remember the secretion from thyroid gland, we have got colloid as a homogeneous mass which is called as thyroglobulin. What is it? It is thyroglobulin. So thyroglobulin is a precursor for the secretion of T3 and T4, that is triiodothyronine and thyroxine hormone, and it is in the form of hormonized material which is lying as a colloid, which is seen in the slide of thyroid follicle. What is the lining epithelium of thyroid follicle? I just want everybody to go through the types of epithelium. Lining epithelium of thyroid follicle is the simple cuboidal epithelium. It can be in the excretory phase. If highly active thyroid follicles देखेंगे तो वहां पे वो columnar भी हो सकता है. So it binds with iodine and so it is exactly bind to the tyrosine residues of thyroglobulin. So exactly by this discussion, it is quite clear that the cell in the blood are suspended in blood plasma, and it is the space around interstitial fluid is space around the cells. So it is wrong. Serum is the blood but not clotting factors, and colloid is present in thyroid gland, which is precursor of T3 and T4 hormone secretion. So my dear, let's move on to the next, that is question number 83. So next question is question number 83. Okay, anterior choroid arteries. If I talk about anterior choroidal artery, it is a branch of which of the following artery? So anterior choroidal artery is a branch of which of the following artery? That is anterior communicating artery, internal carotid artery, external carotid artery, or anterior cerebral artery. So exactly, if I talk about, in this question, you have to know about the branches of internal carotid artery. So if I talk about anterior choroidal artery, it is the branch from internal carotid artery. So the right answer is internal carotid artery. So I want everybody to know that the branches of internal carotid artery in the brain. Okay. So it's important that you should know the branches of internal carotid artery, basic branches which is given in the brain. So 5 important branches are there, and quickly you can write the name of these 5 branches. That is anterior cerebral artery, anterior choroidal artery, we have got posterior communicating artery, we have got middle cerebral artery, ophthalmic artery. So basically these are the 5 direct branches of internal carotid artery in the brain. So these are the 5 branches, that is anterior cerebral artery, which is the major arterial supply in the medial surface of the brain, anterior choroidal artery forming the theria choroidea of the ventricles, posterior communicating artery, middle cerebral artery is the major arterial supply to the posterolateral surface of the brain of the cerebral hemisphere, and ophthalmic artery, if I talk, it is the major blood supply to the eye. So basically in this image, you can see internal carotid artery, which is a branch of common carotid artery. The bifurcation takes place at the C4 level. Intercanal carotid artery traverses inside the cavernous sinus. And we are talking about the branches in the brain. Basically, it is giving 5 branches: ophthalmic artery, anterior cerebral artery, middle cerebral artery, posterior cerebral artery is not the branches. Posterior cerebral artery is the branch of basilar artery. Posterior communicating artery is there. And which is the other one which is not shown? So please rub this. This is making mistake here. So posterior communicating artery, and the one which is not shown here is the ophthalmic artery. So the 5th branch is posterior, is the ophthalmic artery. The 5th branch is ophthalmic artery. Posterior cerebral artery, please note down, is not the branch of internal carotid artery, but posterior cerebral artery will be the branch of terminal branch of basilar artery. Now, anterior communicating artery is not the right answer. What is the reason it is not the right answer? The reason is that anterior communicating artery arises from anterior cerebral artery and act as an anastomotic network which is taking place between right and the left anterior cerebral circulation. External carotid artery is one of the terminal branch of common carotid artery, and external carotid artery is giving so many branches. It's very important that you should know the branches of external carotid artery. I will give you a mnemonic for it. Please don't worry, I will give you the mnemonic. It is mainly giving blood supply to head and neck region. Anterior cerebral artery is a branch of internal carotid artery. It's a branch of internal carotid artery. So yes, it's a branch of internal carotid artery, and basically it is a very important branch which is giving blood supply to medial surface, and it is forming anterior boundary for the circular villus. Actually, I want everybody to write down branches of external carotid artery. So this is very important. So write down branches of external carotid artery. Actually, branches of external carotid artery is basically questions has been asked so many times in the previous year of examination also, and there is a mnemonic for understanding the branches of external carotid artery. The mnemonic is: some anatomists like freaking out poor medical student. Not me, but just remember like this. Some, so just you and write this. Some anatomist like freaking out poor medical students. Poor medical students. So that means we have got 8 branches from external carotid artery. So this is the mnemonic. Some anatomists like freaking out poor medical students. So please highlight the branches of external carotid artery. Very important. Has been asked so many times in the examination. Okay, some anatomists like freaking out poor medical students. So here S stands for superior thyroid artery. A for ascending pharyngeal artery. A for ascending pharyngeal artery. L for lingual artery. L for lingual artery. L for lingual artery. Another F for facial artery. O for occipital artery. P for posterior auricular artery. P for posterior auricular artery. Another M for maxillary artery. Maxillary artery, which is the terminal branch of external carotid artery. Another S for superficial temporal artery. Superficial temporal artery. So I just want everybody to write down this here. Please note down. Superior thyroid artery, lingual artery and facial. These three are the anterior. These three are the anterior branch of external carotid artery. Three are the anterior branch of external carotid. Ascending pharyngeal artery is the only medial branch. This is the medial branch of external carotid artery, because in the previous year, like branches, which are the terminal, which is the anterior, which is the medial branch, such kind of question has been asked. Now occipital and posterior auricular, these two are the posterior branch. These two are the posterior branch of ECA, external carotid artery. And maxillary and superficial temporal, these two are the terminal branch of ECA, external carotid artery. So please go through this mnemonic, that is some anatomists like freaking out poor medical students, and please do know all the branches of external carotid artery. So actually let's move on to the next question, that is question number 84. Now just few more MCQs, no, 16 MCQs, 15 to 16 MCQs more. So let's finish it. How's Brackman grading of the scale is used for which of the following nerve? How's Brackman grading and scale is used for which of the following nerve? So the option given is facial nerve, hypoglossal nerve, vagus and trigeminal nerve. So here you have to just highlight this. How's Brackman grading or scale? So this is again a direct MCQ, but you should know about this grading. And this grading of which is House Brackman grading and scale, this is actually done for the facial nerve. This is done for facial nerve. So we have got facial nerve as the right answer. So definitely we have got facial nerve as the right answer here. Now, my dear aspirants, just quickly we will talk about House Barrack score. What is this? So actually it is the score. It is the score which is used for grading the severity of the nerve damage. So which nerve is taken into account? The nerve which is taken into account is the facial nerve palsy. And the measurement is determined by measuring the upward or superior movement of the mid portion of the top of eyebrow. This mid portion of top of eyebrow outward and laterally. Each reference point is given 1 point out of which 0.25 centimeter movement up to maximum 1 centimeter is taken. Actually, the score is then added together and it will give out a score of 8. The score predicts the recovery which will be seen in the case of Bell's palsy. So I just want कि हम एक table up, we will discuss one table and we will show you how the scoring is done. One of the important point is that House Brackman facial nerve grading should be known to you, and this is exactly this table I have used for House Brackman grading of this facial nerve. So here what is happening in the normal cases? When this is the normal case, the normal symmetric function of all the areas of the face is done. If there is mild dysfunction, slight weakness is noticeable in the close inspection. The complete eye closure with minimal effort can be done. Asymmetric smile with maximum effort, and barely noticeable contracture or spasm. So it's barely seen, as you can say. Then we will inspect it closely, then the abnormalities can be seen. Moderate dysfunction mein obvious weakness is seen, disfiguring also seen, and also closer eye closure is strong but asymmetric movements are seen, and mass movement or spasm is seen. Moderately severe mein maximal effort, asymmetry of the mouth, inability to lift the brow, these are the things. Severe dysfunction mein inability of eye closure, slight movement of the corners of the eyes can be done, and in total paralysis, most severe grading, that is the 6th grade, no movement of can be done of the facial muscle. There is no movement of the facial muscles can be done. So actually, if I am talking about this House Brackman facial nerve grading, you can just go as an overview of this grading. What will be asked is direct question, that House Brackman facial nerve grading is done for which of the following nerve? The right answer is facial nerve. Now let's move on to the next question, that is question number 85. True statement about superior laryngeal nerve injury is all except. So first thing is that you should know superior, if we talk about superior laryngeal nerve is a branch of If I talk about superior laryngeal nerve, it's a branch of vagus nerve. So it's very important to note down that it's a branch of vagus nerve. Now, so the option which is given here, so let's talk about the option. It is giving superior laryngeal nerve supply mucus of the lower half of the vocal cord. So here there is a problem. Actually, अगर हम vocal cords की nerve supply की बात करते हैं, sensory upper part is getting innervation from internal laryngeal nerve, which is a branch of superior laryngeal nerve. बट अगर लोअर पार्ट की बात करते हैं तो इट इज द लोअर पार्ट और लोअर हाफ ऑफ द वोकल कॉर्ड, इट इज गेटिंग sensory innervation from recurrent laryngeal nerve, which is a branch from the vagus. So that is not true. So definitely A is the right answer. I will more elaborate it, don't worry. Injury to the wrong needle can lead to damage of external laryngeal nerve. Absolutely, external laryngeal nerve can be injured if superior thyroid artery ligated not properly. Injury of internal laryngeal nerve can also cause will be anesthetized. Yes, we know that internal and external laryngeal nerves are the branch of superior laryngeal nerve, so it can be involved. Pierces thyroid membrane is also right. Yes, superior laryngeal nerve, internal laryngeal, they are piercing thyroid membrane. So the odd man out on the correct answer, which is not correct statement, is lower half of the vocal cord, their nerve supply. If I talk about the lower half of the vocal cord nerve supply, if I'm talking about, they are done by recurrent laryngeal nerve, not the external laryngeal nerve. So exactly, I just want one more thing to be uh, told to you, superior laryngeal nerve. So please write down. Superior laryngeal nerve, which is a branch of vagus nerve, it is giving two branches. It is giving two branches. One is external laryngeal nerve and the other is internal laryngeal nerve. So अगर हम internal laryngeal nerve की बात करें, it is giving sensory innervation sensation, sensory nerve supply to upper part of vocal cord, और ऑप्शन में क्या लिखा हुआ था, लोअर पार्ट ऑफ वोकल कॉर्ड. एक्सटर्नल लैरिंजियल नर्व इज मोटर वन एंड इट गिव्स इनोवेशन टू वन मसल, दैट इज क्रिकोथायरॉइड मसल. The action of cricothyroid muscle is tensioning effect of the vocal cord. So that is important point about superior laryngeal nerve. Actually, if I talk about lower part of vocal cord, that is getting innervation from recurrent laryngeal nerve. So if I talk about motor supply of the larynx, all the intrinsic muscles of the larynx are supplied by recurrent laryngeal nerve. Sensory supply up to the level of vocal cord by internal laryngeal nerve, but below the vocal cord, as I told you, below the vocal cord, the innervation is by recurrent laryngeal nerve. So that was the wrong statement. So only we have marked A as the right answer. So for that, I just want you to show this image. So you can see here. Here in this image, you can see this is superior laryngeal nerve. And this superior laryngeal nerve is giving internal and external branch. So you can see external branch, if you will see, it is giving innervation to this muscle, that is cricothyroid muscle. And internal laryngeal nerve, if we talk about internal, so cricothyroid muscle, which, and if I talk about internal one, the internal branch is giving innervation to or sensory innervation to upper part of vocal cord. But when you see the internal branch, you can see sensory innervation to larynx is given in the upper part of vocal cord, and the lower part, if you will see the lower part, you can see the lower part sensory innervation is given by recurrent laryngeal nerve. So recurrent laryngeal nerve is giving innervation to lower part of vocal cord. And recurrent laryngeal nerve is giving innervation to all the muscles. It is giving innervation to all the intrinsic muscles of the larynx. So injury to wrong needle can be seen in case of external laryngeal nerve. Definitely, okay, this is true statement, so it is not the right answer. Because this is the true statement. If I talk about inferior laryngeal nerve, that can also be anesthetized because it's a branch from superior laryngeal nerve. And if I talk about thyroid membrane is pierced by two nerves, two structures. One is internal laryngeal nerve and the other is superior laryngeal vessels. Superior laryngeal vessels. So that means all these statement is correct statement about the branches of superior laryngeal nerve. Only the incorrect statement was option A. Let's move on to the next question. That is question number 86. Which of the following fontanelle is last to close? So we have to tell which of the following fontanelles is last to close. Closer of the fontanelles. In the fetus, we have seen that whole of the fetus is having anterior fontanelle, it is having a posterior fontanelle, anterolateral and posterolateral fontanelle. So we have got two anterolateral, we have got two posterolateral, we have got one anterior and one posterior. So anterior fontanelle is also called as bregma and posterior fontanelle is also called as lambda. So सबसे late closer among these fontanelles which has mentioned here, सबसे late closer किस fontanelle का होता है? The right answer is anterior fontanelle. The right answer is anterior fontanelle. Now, I just want everybody to see this image. So exactly, I'm just enlarging it. So when I am showing you this image, you can see the diamond shaped gap which is seen in the anterior aspect. This is anterior fontanelle, which is also called as bregma. And the triangular gap which is seen in the posterior aspect, which is also called as lambda. We have got two anterolateral, we have got two posterolateral sutures. So exactly of all these fontanelles which is seen in the fetal skull, the later closure is seen in the bregma, which varies generally 18 months to 24 months also it can happen. So anterior fontanelle is last to close. If I talk about all the fontanelles closure, which one is the last to close? So in that case, we have got one answer which is right, and in that case, we have got anterior fontanelle is last to close about 1.5, that is 18 months to 24 months. Now I just also want everybody to go with the other options which is mentioned here. So if we talk about, so this is okay, posterior fontanelle closes by about 3 months of 3 months of the age. Two anterolateral sigmoid also closes by 3 months. Two posterolateral closes by 12 months. Typically anterior fontanelle, अगर हम typical time of closure बोलेंगे तो it can close by 12, it can close from 18 months, and actually it can be delayed also. It can also close by 24 months. So posterior fontanelle usually closes within the 2 months after the delivery. But if I talk about anterior fontanelle, the variation can be either 1 year, 18 months, और किसी किसी केस में उससे भी लेट हो सकता है. So basically अगर हमें आंसर मार्क करना है, most correct answer, the most correct answer, then we will go with 18 months. So definitely most later closure is seen in case of anterior fontanelle, which is also called as bregma. Okay, so let's move on to the next, that is question number 87. Question number 87. So I just want so just 2 minutes break I want to give you, just 2 minutes break. So here 2 minutes break, 2 minutes break, just 2 minutes break, just wait. So I just wanted to give you a 2 minutes break. Okay, so just let me check, am I audible? So yes, this break has been adjusted. So I will just check whether I am audible or not. Okay. So we were at the discussion of, so let us check, we were at the discussion of, so am I audible, dear? Am I audible? So exactly at the question number 87, question number 87, we were at the question number 87. Let me just check. This is the question number 87. So let me just check here. So only I will start with that discussion. Let me just. Okay, so I am audible. No problem. I am audible. Okay. So question number 87, spermatogenesis takes how many days? So if I talk about spermatogenesis, it takes how many days? That is a very important question to be known. सो एग्जैक्टली अगर हम पहले के डिस्कशन में जाएंगे रीसेंट बुक्स में नहीं, तो वहां पे 64 days was the right answer, but here we will go with 74 days. So spermatogenesis basically is taking 74 days to complete, and we will mark C as the right answer. So this is A, this is B, this is C and D. So the correct answer will be 74 days. So exactly, in very short, I would like to tell you about the steps of spermatogenesis. I would like to tell you about the steps of spermatogenesis. So you can see here, as you can see here, we have got the primordial germ cell, which is the most primitive form of the cells, which by the mitosis is changing into spermatogonium type 2. Spermatogonium type 2 will again form primary spermatocytes. That is again will by the process of mitosis, and after that what happens, the primary spermatocytes will go with the process of first meiotic division and secondary spermatocytes are formed. This secondary spermatocytes will undergo second meiotic division, which is similar to that mitosis, and the spermatids are formed. Now spermatids will be in rounder globular structure, and this spermatids will have the shape of a sperm, elongated structure. That process is called as spermiogenesis. So if we talk about this whole process, it approximately takes 74 days. So exactly 24, 58 and 64 is not the right answer. Spermatogenesis, which is formation of the mature sperm, or called as that is the process of formation of spermatogenesis, the process of formation of mature sperm, or the other name of sperm will be spermatozoa. And this whole process takes 74 days to complete. So in the earlier edition, it has been mentioned 64 days, but I want everybody to take 72 to 74 days as the most correct answer for this question. Okay. Okay, so let's move on to the next question. That is question number 88. Morula shows how many cells? So the question number 88 is morula shows how many cells, whether it shows A, B, C, D. Morula is showing how many cells? So if you will see the morula stage, it is in the form of mulberry. It represents mulberry in shape, and it is a to 16 cell stage. Exactly, it is again embryology question, which is a direct question, and the correct answer will be it is of 16 cell stage. So definitely 16 cell stage, or A option is the correct answer. Let me give the description in brief. So basically, morula is a typical stage which is having 16 to 32 stages. Morula is formed after fertilization. What happens? Multiple of cleavage takes place. So multiple of fertilization which is taking place in the ampulla part of the fallopian tube. Thereafter, multiple cleavage takes place. And what happens? That blastomeres are formed, and ultimately, agar hum blastomeres forms hota hai, then compaction occurs and tightening of the blastomeres occurs along with the desmosomes and gap junction, and this will be desmosomes. What is the function of desmosomes? So desmosomes are generally protein structures which will keep all the cells together and attaches together to form a morula stage, which is 16 cell stage. Once the zygote is, so how this happens, so once the zygote has reached the 2 cell stage, once it is reached the 2 cell stage, it undergo the process of mitotic division and they become smaller in size. Cleavage होते जाता है और subsequent cells are formed and these smaller size cells are called as blastomeres. After that the blastomeres is arranged and they are compact to each other. Compaction होता है, 8 cell stage is loosely arranged, but after that what happens, blastocytes meres maximize their contact with one another and they will form connection with tight junction, and we will have 16 cell stage, that is morula, which is representing mulberry shape. After approximately 3 days after the fertilization, the cell or the compacted cell which is found is called as the morula or mulberry stage. So 16 cell stage is the most important answer here and the correct answer. So I just want you to show this image. When you see this image, you can see how the 2 cell stage, and then we have got the 4 cell stage, and ultimately 16 cell stage is the morula stage. So you can see they are very compactly, blastomeres are smaller in size and they are very compact, connected to each other by the desmosomes, protein connecting it. Now, if I talk about the inner cell mass of morula, the morula inner cell mass is, and they are, if morula is subsequently arranged as inner cell mass and outer cell mass. So यहाँ पे जब हम inner cell mass की बात करेंगे, inner cell mass, when we are talking about inner cell mass, it is giving rise to, it will give rise to embryo proper. So it will give rise to embryo proper. And if I talk about outer cell mass, if I talk about outer cell mass, the outer cell mass will form trophoblast, and this trophoblast of the outer cell mass will lead to the formation of placenta. This will ultimately lead to the formation of placenta. Done? Okay, so now let's move on to the next, that is placenta. Then the next question is question number, okay, this is question number, okay, again this is question number, should be 89, then it comes 87. Okay, so placenta is formed by, placenta is formed, what is the constituent of the, what is the exactly embryological origin of formation of placenta? So the options which is given here, the options which is given here is chorionic, frondosome and decidua basalis. Decidua basalis and the decidua parietalis, syncytotrophoblast and maternal chorion, cytotrophoblast and syncytotrophoblast. So for following combination is given and we have to go for the most correct answer, which is leading to the formation of placenta. In that case, fetal component of placenta is formed from the chorionic frondosome and the maternal component is formed from decidua basalis. So we will go with A as the right answer. We will call A as the right answer. So here, if I talk about placenta formation, 2 components are there. We have got A as the right answer, and fetal component is developed from chorionic frondosome. Fetal component is developed from chorionic frondosome, and maternal component is developed from decidua basalis. What happens by the end of 3rd week? The anatomical arrangement required requirement necessary for physiological and exchange of exchange which is happening between the mother and the embryo is established. So by the end of 4th week, what happens? By the end of 4th week of intrauterine life, a vascular network is formed in the placenta, by which is facilitating the exchange of gases, nutrients, metabolic waste, and that is happening between the mother and the embryo. So exactly, it was a direct MCQ, and the correct formation from the fetal component is chorionic frondosome, and the maternal component is from decidua basalis, which leads to the formation of placenta. Now moving to the next question, that is also very easy but has been asked in the previous year of exam. A few direct MCQs also I want to give you a quick recapitulation. Fertilization, so this is A, this is A, this is B, this is C and D. And as I told you, fertilization occurs in the dilated part of fallopian tube or uterine tube, and the correct answer will be ampulla. Fertilization takes place in the ampulla part of fallopian tube. In the ampulla part of fallopian tube. So I just want to show you this image. The fertilization is the process of fusion of male and female gametes, and this male and female gamete pronuclear will join together and fuse to form the zygote. So actually this process takes place approximately 24 hours post ovulation, and it happens in the most dilated part of uterine tube, which is called as ampulla. So I just want to enlarge this. You can see here, this is the 10 approximately, the length is approximately 10 centimeters, and you can see the most constricted is the interstitial portion. Then we have the isthmus as the most dilated part is ampulla, where the fertilization takes place, and the finger like projection which you are seeing laterally, and this is fimbriae. This is the finger like, which will help for the oocytes to take and attach to the oocyte. So exactly infundibulum, ampulla, isthmus, and interstitial parts, these are the parts, intramural part, these are the parts of fallopian tube. And if I talk about the part of fallopian tube where exactly the fusion of male and female gametes takes place, fertilization takes place, that area is ampulla. Now other parts, infundibulum is not the right answer. Actually, infundibulum is funnel type part of the fallopian type that is lying very close to the ovaries. You can see finger like projection, fimbriae is lying close to the ovaries. This is ovary. So exactly, infundibulum part of fallopian tube is having finger like projections which is traversing towards the ovary, and a single fimbriae is large. If a single fimbriae is large, which is called as fimbria ovarica. It is called as fimbria ovarica, which will reach to the ovary. If I talk about the isthmus part, it is a constricted part of the fallopian tube, approximately 2 centimeters in the length, connect the ampulla and form a connecting link between the ampulla and infundibulum part of fallopian tube. Now, fimbriae. Fimbriae is not the right answer. Actually, fimbriae is finger-like projections which is seen from the fallopian tube lying very close to the ovaries. What is the function of fimbria? One of this fimbria is long, and this will be attaching to the ovary during ovulation. That one of the each month one fimbria attached to the egg that one of the ovary releases, and fimbria sweep the ovum inside the fallopian tube when the egg can be fertilized. So this is the function. So basically the question was very direct about the fertilization. So ampulla of the fallopian tube is the most correct answer here. Now, let's talk about the question number 89. So, this is again a question of embryology. Superior parathyroid gland is derived from. So, 4 options are there. Superior parathyroid is derived from mesoderm of third arch, endoderm of third arch, mesoderm of fourth arch, or endoderm of fourth arch. So, I will just take some water. If we talk about superior parathyroid gland, it is derived from which of the following structure is the most correct answer? Actually, we have got 2 pairs of parathyroid gland. We have got 2 pairs of parathyroid gland. One is superior parathyroid gland, another is inferior parathyroid gland. So if I talk about superior parathyroid gland, it is derived from 4th pharyngeal pouch. If I talk about inferior parathyroid gland, it is derived from the 3rd pharyngeal pouch. So here the right answer will be, D, that is endoderm of the 4th pharyngeal pouch. So exactly, embryologically अगर हम parathyroid gland की बात करते हैं तो we have got inferior, which is also called as 3rd parathyroid gland, and the inferior 3rd parathyroid gland is developed from 3rd pharyngeal pouch. And if we talk about superior, that is called as 4th parathyroid gland. Actually, parathyroid glands are 2 pair located in the posterior border of thyroid gland. It is developed from 4th pharyngeal pouch, endoderm. 4th pharyngeal pouch, endoderm. 4th pharyngeal pouch, endoderm. So we have got D as the right answer. Now, mesoderm of third arch is not the right answer. If I talk about the mesoderm of third arch, it is giving the structure derived from the mesoderm of third arch is just one muscle, that is stylopharyngeus muscle of the pharynx. So which muscle is derived? Stylopharyngeus muscle. Vascular component give rise to common carotid artery and proximal part of internal carotid artery. It's very important that you should rule out the other options, and you can also study from the other options. So अगर हम mesoderm of third arch की बात करते हैं, तो mesoderm of third arch is giving rise to and forming stylopharyngeus muscle, and the vascular component of it is giving rise to common carotid artery and the proximal portion of internal carotid artery. Please revise it, is very, very important. Now, If we talk about endoderm of third arch, it is not the right because it is giving rise to inferior parathyroid gland. We already talked. Superior is from fourth pharyngeal pouch, but inferior is from third pharyngeal pouch. So both A and B is wrong. Mesoderm of fourth arch, again mesoderm of fourth arch is wrong because mesoderm of fourth arch is giving origin to cricothyroid muscle, levator villi palatini muscle, and constrictor muscles of pharynx. And if I talk about the nerve, so the fourth pharyngeal arch is innervated by superior branch of the superior laryngeal branch of the vagus nerve. So definitely we have got C also wrong. We have got here the right answer, which already marked, is endoderm of fourth arch. That is pharyngeal pouch. That is what? That means pharyngeal pouch. That means fourth pharyngeal pouch. Now I also want to share one table with you where you can quickly revise all the derivatives of endodermal pouch. It's very important that you should give it a quick revision of all the endodermal pouch. So if I talk about all endodermal, the first pouch, the structures derived from the first pouch is tympanic cavity, auditory tube, and inner surface of eardrum. So we will have tympanic cavity derived from it. We have got auditory tube. We have got inferior surface of eardrum derived from it. If we talk about second pharyngeal pouch, palatine tonsil and tonsillar fossa derived. If we talk about third pharyngeal pouch, isthmus, the thymus gland and inferior parathyroid. If I talk about fourth pouch, superior parathyroid gland and ultimobranchial body is formed from the fifth pharyngeal pouch. So let's move on to the next question. That is question number 90. Which type of injury or condition might cause a lesion to olfactory tract? So actually olfactory tract means the first cranial nerve olfaction. So which of the following structures? That means you have to know that olfactory nerve rootlet is traversing through which of the following structure. Whether the fracture of optic canal will involve it, olfactory nerve rootlets, or whether the fracture of cribriform plate, optic canal, pituitary tumor, epidural hematoma, or intracerebral clot in the occipital lobe. So according to you, so we have got 5 options as you can see, and you have to mark the most right answers. Okay. So exactly, if I talk about olfactory nerve rootlets, we know that olfactory nerve rootlets are traversing through cribriform plate of ethmoid bone. It traverses through cribriform plate of ethmoid bone. So cribriform plate of ethmoid bone, and it will involve the B as the right answer. Fracture of cribriform plate of ethmoid bone is the right answer. So definitely B as the right answer. So now fracture of cribriform plate causes lesions of olfactory tract resulting in. So if there is a fracture of cribriform plate, if there is fracture of cribriform plate, it leads to the involvement of olfactory nerve rootlets and olfactory tract, which will lead to the condition of CSF rhinorrhea. Now I just want the other option. So why not other option involving optic canal? Not right answer, because if optic canal is involved, it will involve optic nerve and ophthalmic artery. Blood clot in occipital lobe is not the right answer, because this is coming more anteriorly. Pituitary tumor is also not compressing olfactory nerve. Epidural hematoma is basically by the injury of middle meningeal artery, anterior trunk. So basically the most correct answer will be B. Let's move on to the next. So we have got just 10 more MCQs. Last 10 MCQs. Sagging of soft palate and deviation of uvula. Sagging of soft palate and deviation of uvula to the normal side. Hoarseness might be caused due to the lesion of. So here key factors is soft palate involved है, uvula deviation भी involved है, hoarseness of voice involved है. That means soft palate, uvula and larynx is involved. So which of the following nerve is involved in this case? So basically, if we are talking about, we know that importantly this is from the lesions of vagus. Exactly, vagus nerve is the correct answer. The reason is that Why vagus nerve? Because we know that vagus nerve along with the cranial part of accessory, so हमें सबसे correct answer लेना है, तो vagus nerve along with the cranial part of accessory nerve is giving innervation to pharynx, it is giving innervation to soft palate, it is giving innervation to larynx. So the clinical features which is mentioned in this MCQ is definitely all these structures are being involved, so we will have vagus nerve as the most correct answer. So only accessory is there, so it is not the right answer, because spinal part of accessory is giving innervation to sternocleidomastoid and trapezius muscle. Hypoglossal is not the right answer, because hypoglossal nerve is giving innervation to tongue muscle. Glossopharyngeus is just giving innervation to one pharynx muscle, that is stylopharyngeus. Facial is not the right answer, because facial nerve is giving innervation to all the muscles of facial expression. So if we have to choose most correct answer in this category, most correct answer, we will go with the vagus nerve. So sagging of soft palate, my dear aspirants, sagging of soft palate, deviation of uvula means soft palate is involved, and that can deviate to normal size, along with hoarseness of voice, that is lesion जो है larynx में भी है, तो lesion larynx में भी है, lesion soft palate में भी है, and we know that vagus nerve along with cranial part of accessory nerve is giving innervation to these structures, so definitely C is the right answer. Now coming to the next question, that is question number 92. Superficial neck laceration will lead to which of the abnormal finding? The options are paralysis of sternocleidomastoid muscle and superior fibers of trapezius drooping of the shoulder, paralysis of mylohyoid anterior belly of digastric tensor tympani and tensor villi-palatini, paralysis of posterior belly of digastric stylohyoid and stapedius, anosmia and tinnitus. So exactly अगर हम correct answer की बात करें तो the correct answer is A. I will tell you why. Actually, superficial neck laceration, as I told you, posterior triangle of neck is very important for the location of one nerve. The name of that nerve is spinal accessory nerve. What is the name of that nerve? The name is spinal accessory nerve. That means 11th cranial nerve, spinal accessory nerve. And as I told you, spinal accessory nerve is giving innervation to two muscles. It is giving innervation to sternocleidomastoid and trapezius muscle. So the action of trapezius muscle is, it is involved in overhead abduction when it acts along with serratus anterior muscle. Trapezius is also involved in upper fibers are involved in elevation of the scapula. So it's the middle fibers are involved in retraction of scapula. Sternocleidomastoid is involved when we are lifting the neck flex above, and then also unilateral deviation of the neck and looking the eye to the opposite side. So this is the function of sternocleidomastoid. So basically मैंने पहले भी बताया था, spinal accessory nerve, a very important nerve residing in the posterior triangle of the neck. It is sandwiched between the roof and the floor. Now roof of posterior triangle is formed by investing layer of deep cervical fascia. Floor is formed by prevertebral layer of deep cervical fascia. So basically it get compressed in between these two layers of deep cervical fascia, and there is much more chance of spinal accessory nerve being damaged. So we will mark A as the right answer. Now why not? So this is exactly neck laceration damage spinal accessory nerve resulting in paralysis of sternocleidomastoid and superior fiber trapezius will lead to drooping of shoulder. Now if I talk about the other one, why not paralysis of mylohyoid anterior belly digastric and tensor villi is right? Actually the paralysis, these structures are getting innervation from mandibular nerve, which is a branch of trigeminal nerve. So mandibular nerve is not residing in the neck. Paralysis of posterior belly stylohyoid and stapedius is talking about facial nerve, so this is also wrong. Anosmia means olfactory nerves. Tinnitus means vestibulocochlear nerve. So exactly after this discussion, it is quite clear the nerve being injured by the laceration, which is happening in the posterior triangle of the neck, because it is sandwiched between the roof and the floor. Roof of posterior triangle is formed by investing layer of deep cervical fascia, and the floor is formed by prevertebral layer of deep cervical fascia. So if I have to mark the right answer, I will definitely go with the correct answer A, paralysis of Sternocleidomastoid and trapezius muscle and drooping of the shoulder, because upper fibers of trapezius is causing elevation of shoulder, which is gone in this case. Okay. Question number 93. Which structure passed through a gap between superior constrictor muscle and the skull? Actually, if I talk about the muscles of pharynx, we have got constrictor muscle, we have got superior constrictor, middle constrictor, and inferior constrictor. So in between these constrictor muscle, we have got gap, and we have to pay attention to all these gaps and the structures passing through these gaps. So exactly, अगर हम बात करते हैं the gap between superior constrictor muscle and skull, it is called as the space of Morgagni. Actually, that is called as space of Morgagni. That is called as space of Morgagni. And exactly the gap between the superior constrictor and the skull, space of Morgagni, four structure is passing through this space. Four structure is passing. What are they? The fourth structure passing is levator villi palatini muscle, ascending pharyngeal artery, palatine branch, ascending palatine artery, and auditory tube. So exactly these are the four structures. So if I talk about four structure which is passing through the gap between superior constrictor muscle and skull, that is the sinus Morgagni. That space is called as sinus Morgagni, and we have got four structures passing through these space. We have got levator villi palatini muscle of soft palate, palatine branch of ascending pharyngeal artery, ascending palatine artery itself, and auditory tube. So definitely the right answer will be ascending palatine artery. So exactly, we have actually tensor villi palatini doesn't pass in this gap. Glossopharyngeus and stylopharyngeus will pass in the gap between middle constrictor and superior constrictor. Both glossopharyngeal nerve and stylopharyngeus is passing between the gap of middle constrictor and superior constrictor, and stylohead is not passing through this gap of pharynx. So we have got B as the right answer. So as I have told you, ascending palatine artery, levator villi palatini, pharyngotympanic tube, and palatine branch of ascending pharyngeal artery is passing through the gap between superior constrictor and the skull, which is called as sinus Morgagni space. Now, actually, in the previous year of examination, what is very important for you to know, the vase-like arrangement of all the constrictor muscles of the pharynx, and you have to know individual gap and the structures passing through this individual gap. So I just want to enlarge this. When I have enlarged it, this is called as the base of skull. This area is the base of the skull. So this is exactly base of skull. This is base of skull, as you can see. And this is the superior constrictor muscle. This is SC for superior constrictor. This is MC for middle constrictor. This is IC. And exactly the space which is lying between the superior constrictor and the base of skull, four structure: levator villi palatini, auditory tube, ascending palatine, and palatine branch of ascending pharyngeal artery. Same thing which I have shown you. These four structures are passing through superior most space, and the space which is lying between. So we have got two structures. So exactly in between, the space between superior and middle constrictor muscle, the space between superior and middle constrictor muscle, two structure passes, the nerve and the muscle inner. So we have got stylopharyngeus muscle and glossopharyngeal nerve. We know that glossopharyngeal nerve is giving only innervation to one muscle, that is stylopharyngeus muscle. And in between, so coming to the next one, in between middle constrictor and inferior constrictor, we have got two structures traversing: superior laryngeal artery and internal. So what are they? We have got superior laryngeal artery and internal laryngeal nerve. And below inferior constrictor, actually the space below inferior constrictor is also called as tracheoesophageal groove. This space is called as tracheoesophageal groove, and in tracheoesophageal groove we have got recurrent laryngeal nerve and internal laryngeal artery passes. So these two structures are passing below inferior constrictor muscle. That means we have got three constrictor muscle: middle, superior and inferior constrictor muscle, and there are four spaces in this. We have got a space which is lying superiorly, through which four structure passes: auditory tube, ascending palatine artery, palatine branch of ascending pharyngeal artery, and that of levator villi palatini. In between superior and middle constrictor, two structures: glossopharyngeal nerve and the muscle innervated by ninth cranial nerve, stylopharyngeus. In between middle and inferior constrictor, again we have got two structures passing, internal laryngeal nerve and superior laryngeal artery. And the space which is lying below inferior constrictor muscle, which is also called the area of tracheoesophageal group, we have got recurrent laryngeal nerve residing there along with inferior laryngeal artery. So done with this. Now let's move on to the next question, that is question number 94. So which of the following structure extends into labia majora? So the options are suspensory ligament of ovary, ligament of ovary proper, processus vaginalis, round ligament of uterus and uterine tube. So exactly यहाँ पे हमें जानना है कि which is an important support also for the uterus. So exactly the correct answer, if I talk about one of an important structure which extend till the level of labia majora, the structure will be round ligament of uterus. So we will have the correct answer here, round ligament of uterus. So round ligament of uterus is traversing through inguinal canal, and this is an important structure which will be extending till the level of labia majora. So that is the right answer, D. So descents, if I talk about descents of gonad, it is considerably less in case of female than in males, because ovaries are lying at the level of true pelvis, below the rim of true pelvis. So cranial genital ligament, if I talk about cranial genital ligament, it is forming suspensory ligament of ovary, whereas if I talk about caudal genital ligament, so here cranial genital ligament is forming suspensory ligament of ovary, and if I talk about caudal genital ligaments, the caudal genital ligament is forming round ligament of uterus and also ligament of ovarian proper. So the caudal, the extent of this round ligament will go till the level of labia majora. So if I have to choose one answer here, the extent of round ligament of uterus which is extending till the level of labia majora and providing a very important support. So it is one of the component of support of uterus. We know that support of uterus is done by transverse cervical ligament, Mechendorf ligament, by uterosacral ligament, pubosacral ligament. Also round ligament of uterus is forming one of the support. The reason is that it is extending till the level of labia majora. Now let's solve the next MCQ, that is question number 95. This is also correlated MCQ also. If I talk about the lateral extension of the peritoneum, the lateral extension of the peritoneal fold of broad ligament, actually broad ligament of uterus is actually forming a false support, but it is prolonged superficially. अगर हम superiorly देखेंगे, superiorly it's prolonged, it is going over the ovarian vessel. So it is also important question to be asked, which of the part of the broad ligament extension is seen to be arcing over ovarian vessel. So in that case, we have got the right answer, suspensory ligament of ovary. So actually suspensory ligament of ovary is traversing towards that of the ovarian vessel. Mesoovarium is not, because mesoovarium is posteriorly extension of broad ligament which is containing ovary. Mesosalpinx is the part of broad ligament which is connecting the uterine tube. Mesometrium is also not, which is actually formed with the rest part of the broad ligament. And transverse cervical is the cardinal ligament, and it is an important true ligament of the uterus, giving support, or it's a cardinal support of the uterus. So we have got suspensory ligament which is anchoring. So laterally, if I talk about the extension of peritoneum of broad ligament, it goes more superiorly and it runs over superior aspect over the ovarian vessel. So part of broad ligament which in which the ovary is suspended is mesoovarium. Part of broad ligament, so please write down, ovary is suspended by mesoovarium. Part of broad ligament which is containing uterine tube is called mesosalpinx, and major part of the broad ligament which is in the form of mesentery, which is also called as mesentery of uterus. So mesentery of uterus is formed by mesometrium, which is lying below the mesosalpinx and mesoovarium. So these are exactly mesometrium, mesosalpinx, mesoovarium. These are the parts of broad ligament, and the fold of broad ligament which is prolonged over ovarian vessels, ovarian vessels, is called as suspensory ligament of ovary. So we have marked suspensory ligament of ovary as the right answer. So my dear students, just last 5 questions to be solved. Tongue develops from all of the following sources except. Tongue is developing from all of the following sources except lingual swelling of the first arch, occipital myotome, small dorsal part of hypobronchial eminence, or fifth pharyngeal arch. So we have got 4 options, and actually lingual swelling of the first arch is contributing in the tongue development. Anterior 2/3 part of the tongue, occipital myotome is forming muscles of tongue. Dorsal part is forming, hypobronchial is forming posterior part of the tongue. It is also giving rise to posterior part of the tongue. So the odd man out, and the correct answer here will be the fifth pharyngeal arch. So fifth pharyngeal arch is not contributing to the development of tongue. So basically अगर हम tongue के development की बात करते हैं तो tongue का development is from the sources of lateral lingual swelling. It is from the source of tuberculum impar. It is from the hypobronchial eminences, which is having cranial part and the caudal part. So these cranial part and caudal part of hypobronchial eminences, actually caudal most part of hypobronchial eminence is also giving rise to epiglottis. Tuberculum impar, lateral lingual swelling, all these parts contributing to the first, second, third, fourth arch will contribute to the development of tongue. Also occipital myotome will contribute to the development of muscles of the tongue. So here first pharyngeal arch nerve is mandibular nerve, and lingual nerve is the nerve of general sensation of the tongue. Now, if I talk about second pharyngeal arch, basically one of its branch, which is coda tympanic nerve. Now, coda tympanic nerve is considered to be pre-traumatic nerve of first arch. So it also first pharyngeal arch. It also gives sensory nerve. It is coda tympanic nerve is important for taste sensation in the anterior part of the tongue. Posterior part, both general and that of taste sensation. Both general sensation and taste sensation is given by glossopharyngeal nerve, the nerve of third arch. Posterior most part of the tongue by vagus nerve. So actually this is the correlation of the development of tongue with the nerve supply. Now question number 97. Guyon's canal contain which of the following nerve? What is Guyon's canal? Actually Guyon's canal is the space which is lying below volar carpal ligament and above flexor retinaculum, of the hand or the wrist. So exactly here ulnar nerve and ulnar, two structures traverse from the Guyon's canal. Which two structures? Ulnar nerve and ulnar artery is seen to be moving above the flexor retinaculum, covered by a superficial aspect of flexor retinaculum, which is called as Guyon's canal. So I just want you to show this image. When you see this image, you can see ulnar nerve is traversing through Guyon's canal. Actually, here also you can appreciate that this ulnar nerve is passing above flexor retinaculum, and this is covered by a superficial slip of flexor retinaculum. This superficial slip of flexor retinaculum is called as volar carpal ligament. Now this is about its Guyon's canal, but I also want you to show the medial and lateral boundary of Guyon's canal. Medial and lateral boundary of Guyon's canal. So see here, actually this is an image where you can see the flexor retinaculum has been highlighted, and very nicely you can see above the flexor retinaculum the nerve which is traversing is the ulnar nerve, but it is covered by superficial slip of flexor retinaculum, that is volar carpal ligament. Now if I talk about its boundary, it is exactly bounded between pisiform and hook of hammer. So exactly Guyon's canal, अगर हम Guyon's canals की बात करते हैं तो Guyon canal is passing between two carpal bone, that is pisiform and that of hook of hammer. So that is exactly the location of Guyon's canal. Okay, so we have got the right answer. And why not the other option? Radial nerve, medial nerve, anterior. What is anterior introosseous nerve? It is deep branch of medial nerve, and we know that medial nerve passes deep to FR, flexor retinaculum, and this area is carpal tunnel, and also radial nerve is not passing in any of the Guyon's canal. So we have got A, ulnar nerve, as the right answer. Now let's move on to the next, that is question number 98. So if I talk about question number 98, dangerous space of the neck is found in between which two layers? So if I talk about dangerous space of the neck, it is actually two spaces are there that is showing the modification of deep cervical fascia. We know that deep cervical fascia is made of three layers as you proceed from outside to inside. We have got investing layer of deep cervical fascia, we have got pre-tracheal layer of deep cervical fascia, we have got prevertebral layer of deep cervical fascia. So exactly the space which is lying between prevertebral layer and alar fascia. So actually exactly alar fascia is anterior. Alar fascia is anterior extension of prevertebral fascia. And in between prevertebral fascia and alar fascia, we have got danger space of neck, because infection in this area can go and traverse in various directions. Okay, so here I just want you to show the difference between dangerous space and retropharyngeal space. Actually, yellow color is used for the retropharyngeal space, which is lying anterior to danger space, and red color is used for danger space. Red color is used for danger space. So danger space is shown with red color, and anterior to danger space we have got the true retropharyngeal space. So retropharyngeal space is between posterior pharyngeal wall, bucopharyngeal space and alar. So अगर हम retropharyngeal space की बात करें, it is between alar fascia, anterior to alar fascia, and it is between the bucopharyngeal fascia, or you can say for posterior pharyngeal wall or bucopharyngeal fascia. Bucopharyngeal fascia. बट अगर हम डेंजर स्पेस की बात करते हैं तो डेंजर स्पेस इज लोकेटेड बिटवीन प्रीवर्टिब्रल फेशिया एंड एलर. सो एग्जैक्टली डेंजर स्पेस ऑफ नेक which is shown in the red color, it is lying between alar fascia anteriorly and posteriorly we have got prevertebral fascia of deep cervical fascia. So that is the differentiation between two spaces which is often confused, so you should have this concept clear. Now let's move on to the next question, question number 99. Lateral displacement of the patella is prevented by which of the following structures? Rectus femoris muscle, vastus intermedius, vastus lateralis or vastus medialis. Actually, for the proper understanding of this image, it is important to know which of these muscle has got more attachment of the muscles on the base of the patella. So exactly, if we talk about lateral displacement of the patella, it is prevented by the attachment of vastus medialis muscle. So the right answer is vastus medialis muscle in this case. For that, I want you to show an image. So can you see here? Here in this image, if I just enlarge this image, you can see this is the base of patella. Or on the base of the patella, you can see laterally 1/3 vastus lateralis insert, and on the medial part, and you can see more area, 2/3 part of the base is covered by vastus medialis, and in the middle area we have got rectus femoris and vastus intermedius. So basically base के part और medially भी अगर हम देखें border of patella में, तो vastus medialis is attached. So it is not letting the lateral displacement of patella to take place. So we have to correctly, if we talk about the lateral displacement of patella, is due to the larger area of attachment of vastus medialis on the base medial aspect and medial aspect of the border of the patella. So that is the reason we will mark D as the most correct answer. So you have to just go through the attachment of the muscles which is shown in this image. Attachment of the muscles which is shown in this image. So I just want to complete the next question. Which muscle on the thumb has got dual nerve supply? Actually, the muscles which is having dual nerve supply is called as composite or hybrid muscle. What is it called? They are called as composite or hybrid muscle. So exactly one of the muscles of thenar region, that is a flexor pollicis brevis. So if I talk about flexor pollicis brevis, this is the muscle which is having dual nerve supply. Flexor pollicis brevis is the muscle which is having innervation from both median nerve. Flexor pollicis brevis is the muscle of thenar eminences, and we know all the muscles of thenar eminences, that is abductor pollicis brevis, flexor pollicis brevis, opponens pollicis, all these muscles are innervated by median nerve. Along with it, it also get innervation from ulnar nerve. So that means it is having dual nerve supply. So it is the right answer which is having dual nerve supply. Flexor pollicis longus is not the right answer because it is innervated by anterior introosseous nerve, which is the deep branch of median nerve. Adductor pollicis is also not the right answer because it is only innervated by ulnar nerve. Abductor pollicis brevis is also not the right answer because it is only innervated by median nerve. So if we have to choose the right answer, we will go with flexor pollicis brevis. Now, my dear students, I also want everybody to know the list of the muscle which is getting dual nerve supply. So अगर हम categorize करेंगे thenar region में, तो thenar region, thenar eminences, if I talk about the thenar eminences region, it is having flexor pollicis brevis, it is having opponens pollicis brevis, both are the muscles of thenar eminences. In case of thenar muscle list, which is made of 3 muscle, we have got flexor pollicis brevis and we have got opponens pollicis. So these 2 muscles is getting innervated by dual nerve. These 2 muscle, both of the muscle, most commonly flexor pollicis brevis is getting dual nerve supply. Dual nerve supply. And what is the nerve supply, my dear student? The nerve supply is via both median nerve and via ulnar nerve. Actually, what is important for you is to know the quick revision of all the muscle having dual nerve supply. So, agar hum all the muscles of dual nerve supply, I would like to just quickly give you the list of the muscle having dual nerve supply, then we will end for today. So, in that case, you can just have a look of important muscle having dual nerve supply. So, some of that muscle which is having dual nerve supply is called as composite or hybrid muscle. So, that list is basically having, in that list we have got adductor magnus muscle. Why adductor magnus muscle is the right answer? Because it is getting innervation from both obturator nerve and that of tibial component of tibial part of sciatic nerve. Now, pectineus muscle. Why pectineus muscle is getting dual nerve supply? The reason is that pectineus muscle is getting innervation from both femoral nerve and that of obturator nerve. Other is trapezius muscle, which is getting innervation from accessory nerve, that is spinal accessory nerve, and also proprioceptive fibers from C3 and C4. Then we have got flexor digitorum profundus. Flexor digitorum profundus is getting innervation from both median nerve and that of ulnar nerve. Lateral part from median nerve, deep branch anterior introosseous nerve, and medial part by ulnar nerve. Other than that, we have got brachialis muscle. Brachialis muscle is getting innervation from both musculocutaneous nerve and that of radial nerve, proprioceptive fibers. Other than that, we have got more list in this category. We have also got flexor pollicis brevis and that of opponens pollicis of the thenar eminences. Other than that, iliacus and psoas major muscle. Iliacus and psoas major muscle, that is from both femoral nerve and that of directly from L2, L3 and L4 nerves. Also, we have got digastric muscle. Actually, digastric muscle, if I talk about digastric muscle, it's anterior. अगर हम digastric muscle की बात करें तो its anterior belly is from mandibular nerve. Its anterior belly is from the mandibular nerve, that is a branch of trigeminal nerve, and its posterior belly is from facial nerve, 7th cranial nerve. So exactly many, also the biceps femoris muscle. So if I talk about biceps femoris muscle, again the biceps femoris is having short head. Short head is from common peroneal component of sciatic nerve, and long head is from tibial component of sciatic nerve. Tibial component of sciatic nerve. So yes, my dear students, we have finished with this important, we have at the end finished all the 100 MCQs, actually more than 100 MCQs, I think 101, 102, 101 MCQs I have covered up. These 100 MCQs with 100 concepts and 100 topics, which is very, very important for your quick revision. This will help you to target your exam with a better score. So ये सारे 100 MCQs आपको quickly revise करना है. with the explanation provided with me, by me, and you will get a better rank in your upcoming examination. I think most of the questions, 80 to 80% question will definitely ask from these topics of anatomy only, and this will be highly beneficial for you. We will meet again with the next session, and all the best and keep studying. All my blessings are there to my dear students. You will surely have your positive attitude in your examination. Take a proper rest a day before the examination, and have a proper breakfast in the morning, and all the best for your upcoming examination. All the best and keep studying. Thank you so much, my dear students. Thank you. Best of luck. Best of luck. Okay, dear students. So we'll meet in the next session. Thank you so much.